Sorry, guys. The whole world of Zoom, I'm on mute, but now I'm not. So again, I'm Dr. Justin Martello, movement disorder specialist of Delaware. I work for Christiana Care. I want to welcome you today to our virtual symposium. It's going to be hopefully a great day of presenters. And I want to just quickly mention, if you do have questions, please type them into the Q&A box and we'll answer them at the end. And if we can't get to all the questions, we'll sure to be sending out all the questions and presentation afterwards. There is lunch kind of blocked from 12 to 12:50. We'll be showing some of our sponsors for this, and I'll go over, what the sponsors, who they are during lunch. We'll kind of slide through them and what we plan to do with the funds. So we'll go over that. And then the Q&A session will be at 2:55 p.m. today. So I'm going to kick things off and talk about our program and a little bit about Parkinson's. So as far as the objectives today, so we're going to go into a little bit about Parkinson's disease and just kind of a brief overview of that. I'm going to touch on a tiny bit about COVID and Parkinson's disease, a little bit about our program, which you'll hear much more from other presenters today, and then the future of Parkinson's and what we're doing here at Christiana. And April is Parkinson's Awareness Month, of course, and that's why we're having it. So real quick, what is Parkinson's disease? So Parkinson's is a neurodegenerative disease, meaning that it is something that tends to progress over time. Everyone is different in how they progress or how quickly they progress, but it is something that will always progress over time. The main kind of player in Parkinson's is just a loss of cells that produce dopamine in your brain, and so that's kind of one of the major things that we talk about as far as medications and how they work. It causes mostly slowness of movements, stiffness of movements, tremors, balance impairment. But what you'll see, and I'll show you a slide later about symptoms, that not everyone has all of these things, and so these are just some of the main symptoms that can be seen in Parkinson's. I like to show this picture. It shows you kind of the area of the brain, kind of lower down of the area that produces dopamine. So you can see this kind of black substance here in a normal brain, and it's not as black here. And this just shows you a loss of these dopamine producing cells. And then for those of you who know what a DAT scan is, a DAT scan can be a way to help us diagnose Parkinson's. It's not usually something that we always get because diagnosing Parkinson's is still very clinical and very classically done through history and exam. But sometimes we get a DAT scan, and you can see in the DAT scan, it can show this kind of lighted area in your brain that has these dopamine transporters, and in an abnormal brain, you don't see that as much. So Parkinson's affects about 1 to 2 people per 1,000 in the United States. About 1% over 60 has Parkinson's. As far as the numbers of Parkinson's, you can see that there was a University of Delaware study in 2011 that estimated about 2,000 Delawareans had Parkinson's at that point. And then you can see the number jump for a number of reasons, but an NIH study in 2017 showed it jump to about 3,700. So lots of you out there and lots to take care of, right? So you're not alone in this fight, especially in this region. And then some other numbers. So there's about 1 million people in the United States. This is all based off 2016 data with Parkinson's, which is more than MS or multiple sclerosis, muscular dystrophy, and ALS combined. About 60,000 Americans are diagnosed with Parkinson's every year, about 10 million people worldwide. And as far as men to women, we used to think it was predominantly men who got it. That number has decreased over time, again, could be for several reasons, but definitely still a little bit more often seen in men. Now, just as a word, people throw out terminology like Parkinsonism, Parkinson's disease. And so just to be clear, when we say Parkinsonism, it just means that you have a set of symptoms that look like people with Parkinson's disease, right? So it's kind of like saying flu-like symptoms, right? Fever, chills, all these things. So bradykinesia, meaning just slowness of movements, a specific type of stiffness of your muscles, a specific type of tremor, balance issues. So all these things, instead of kind of listing them out, we just say, oh, this person has Parkinsonism, and then we have to figure out why they have Parkinsonism. Is it from Parkinson's disease, which is most often the case, or is it from other diseases, strokes, medication side effects? So something we have to figure out. Now, I created this slide not for it to be necessarily overwhelming for patients or caregivers, but just to kind of point out that a lot goes on in Parkinson's disease. I don't have to tell you, most of you, that. And a lot of it is kind of internally, right? So we talk about motor symptoms, and that's what I've been mentioning: slowness, tremors, stiffness, and then there's non-motor symptoms. And so this is a good kind of example of just showing you everything that can go on in Parkinson's. Again, not everything has to go on that I'm showing you, but just some of the more common features and symptoms. So again, we mentioned the slowness of movements or bradykinesia, the stiffness of movements or rigidity, and the tremors. What else can go on? So cognitive issues or kind of memory, thinking issues, executive functioning issues with multitasking, planning, organizing, nightmares, vivid dreams, just sleep issues in general, not being able to sleep at night. Something we call REM sleep behavioral disorder, where you kind of punch and kick in your dreams and thrash around at night. Apathy, or kind of this lack of motivation, depression, anxiety, hallucinations, delusions. Again, not in everyone, right? Despite what the commercials may tell you, not in a majority of people, but some people can have it. Blurred vision or vision changes, smell changes, or what we call anosmia. Changes in your speech, so usually a lower volume, sometimes hoarse voice, sometimes slurred speech, drooling. Oddly enough, sometimes people can have like this kind of nasal drip when they don't have a cold or allergies. Swallowing issues, or what we call dysphagia. Blood pressure fluctuations or drops in your blood pressure can be seen. Constipation, slowness of your whole GI system, including your stomach, which what we refer to as gastroparesis. Fatigue issues, big one. Dystonia is kind of like this tightness or abnormal posturing of your muscles. Erectile dysfunction, urinary incontinence, gait and balance issues. So you can just obviously see that a lot of things can go on, and this is not everything either. I tend to highlight the loss of smell, the acting out your dreams at night, and the constipation, because these tend to be precursors to Parkinson's. A lot of people say that they've had this many years, these issues many years before Parkinson's, but Parkinson's does start many years before the onset of symptoms. And so other things that can happen: decreased arm swing, a shuffling gait, a small handwriting, decreased facial expressions, difficulty rising from a chair, especially soft or lower chairs, freezing in movements or walking, hunched over posture, festination, which is kind of like where your feet go faster and faster as they walk and you kind of are going forward faster, and then drooling. Now, so how, when I mentioned before, usually Parkinson's disease is diagnosed clinically, and this is kind of a pitch that, you really should have a movement disorder specialist as a part of your Parkinson's care, even if it's just once a year, because really, we go through a fellowship. There's a lot of subtleties to someone's exam and someone's history, and someone like us who sees 6 to 8 or 10 Parkinson's patients a day or more, versus a general neurologist or primary care doctor who sees maybe that many in a month or in a year. It's just not going to, they're not going to be as, up to date with all the treatments and therapies. So, we do a better job, proven in studies, on not only diagnosing patients, but also taking good care of them as well. And quality of care is usually better. Now, I'd just like to show, a lot of you know what Parkinson's looks like, right? But we'll see if this video works out here. So you can kind of see she has this typical, what we call a pill rolling resting tremor. Resting meaning like her hands are resting in her lap and her hands are shaking kind of on their own. You can see obviously it's usually asymmetric. One side is worse than the other. For her, the left side is a little bit worse, clearly.
In front of you, please.
And usually, unlike other types of tremors, they don't always tend to be when you hold them up or when you're using them. They can be, but it doesn't often happen. You can see she's not really swinging her arms here. She's a little bit hunched over.
You can stop there. Now, if you'll take your left hand and just hold your arm up a little bit, and if you'll just tap your index finger and thumb together real quickly.
And you can kind of see just her amplitude is just lower, and she's kind of a little bit slower there.
Same thing.
And she's a little bit faster on the other side. So
just the 2 fingers. There you go.
So that's kind of all I wanted to show you, kind of what a typical Parkinson's patient looks like. Now, as far as progression, of the disease, this is kind of what we see where over time, especially when patients are taking the mainstay of therapy, which is called carbidopa, levodopa, or Sinemet, what happens over time is that their window where the medicine really works well tends to narrow. So you can, just to orient you, kind of the y-axis here is the levels of dopamine given to you through medications. X-axis is time. And you can just see when you take oral medications, especially levodopa, the dopamine levels rise and then they fall before the next dose is due. And anything within this kind of turquoise window is where the medicine's working really well. And so as time goes on, the medicine doesn't work as long. You have what we call wearing off periods, where anything below this window is when the medicine's not working well, or the dopamine levels are not high enough in your system to really treat your symptoms. And then anything above this, you have the dyskinesias, which is kind of like the writhing dance-like movements, like Michael J. Fox has and things like that. So you can kind of see, this is where we talk about motor fluctuations with Parkinson's and just what happens over time. So just a couple mentions about why Parkinson's happens. There is only about 10 to 15% of people have a clear family history, genetic history of Parkinson's disease. So it's like my dad had it, or my mom, grandparents, things like that. But usually, someone with Parkinson's, they're usually the only one in their family to have it. And so why else do people get it? I will say it is still a working theory. There's this idea that could it start from something going awry with your gut, whether it's the bacteria, the natural bacteria in your gut that goes awry, or some kind of protein that develops in your gut that kind of propagates up towards your brain. This is something that's been theorized for a long time now. And then environmental exposures, right? So what are those environmental exposures? So a lot of them involves your employment or your job. Now, again, many people will look through these slides and say, I have none of these exposures, and that's the case a lot of times. And so we're still trying to learn why some people develop it and some people don't. But did you work with pesticides, or were you a farmer, growing up or for your job? Welders tend to get Parkinson's at a higher rate. Just working in chemical factories, right? There's obviously a big one here. So, how much did that play a role? Other types of, woodworking, laundry services, electricians, things, anytime you work with different kind of chemical or metal exposures can definitely precipitate it. And then there's some odd things that we see, right? That it hasn't been proven one way or the other, but just some interesting findings of like smoking or tobacco maybe will lower your risk. Obviously, we never recommend that because it has much more worse effects. Caffeine has been shown to maybe lower the risk a little bit. So again, is there something there or not? It's hard to say. Well water, how much that plays a role in increasing your risk. There used to be a thought that dairy increased your risk, but we kind of know that this is probably not the case. Other types of pills, could have been the case. People with gout tend to have a lower incidence of Parkinson's, and is there something there that we can use for treating Parkinson's? We're still trying to look into. There, again, NSAIDs or non-steroidal medicines, how much do they play a role? Again, the jury's still out. Again, mostly we don't know. We think it's probably a combination that of some kind of genetic factor, right? That you do have some kind of gene that makes you more at risk of developing Parkinson's in these certain circumstances, right? So every farmer doesn't have Parkinson's disease, right? But is it certain farmers in certain conditions with the right genetic marker to make them at more risk? This slide just kind of give you a brief overview of like all the medicines that we have right now, and depending on how you count them out, it's around 20 or so medication options that we have for Parkinson's. All of these are just symptomatic treatments, so things that just treat the symptoms, they don't slow down the progression of disease. There is a thought that indirectly they may slow down the disease progression, because if they make you feel better physically, right, they make you less stiff, less slow, you're going to be more likely to do more things active, and really it's a physical activity that slows down the progression of disease. And so that is something that's really why we've gone a little bit more aggressive in the therapy in prescribing medications, because we want you as active as possible, and anything that's going to slow you down or stiffen you up, we don't want to be the case. So it's no longer something that you have to be desperate enough to start medicines. We start them early and increase them often. So I always get, we get a lot of talk about medical marijuana. And so I just wanted to mention really quick with Parkinson's, there is an approval for Parkinson's with painful muscle spasms. Painful muscle spasms don't really tend to happen with Parkinson's, but it can happen. The biggest issue with medical marijuana is that it is not an exact science. And so this is something that gets patients really frustrated, because, they'll walk into these dispensaries, there's a million different options, and I nor anyone else will really have any type of idea on how to guide you. We used to think that the CBD portion of medical marijuana was the helpful portion. We know that might not be necessarily the full story. There was a small study, that THC may be helpful in Parkinson's. So people get frustrated, and if one or two options don't work, I usually say, well, try the other 98, but it's pretty frustrating for patients. There is no long-term data in specifically Parkinson's population, right? So obviously marijuana has been around for thousands of years. Having said that, there could be an increased risk of dementia. A very small study a couple of years ago suggested that I wouldn't take much from it, only that we don't really know what specifically Parkinson's patients who use medical marijuana will do. It is not a miracle cure, no thanks to Facebook, right? So if you haven't seen, there's a Facebook video of someone who has Parkinson's. They're really stiff, so they're slow. They're sitting on a couch or a chair. They're given medical marijuana, and they walk around, and it's like they're normal again, right? To be honest, I can give you videos of the same type of thing with our medications, right? So why am I using something I don't really know about, don't know the risks about? And to be honest, everything's a medicine, right? It's just all about how you define medicine and not. And so I'd rather use something that we have a lot more data about. Levodopa has been around since 1969. So again, not a miracle cure. And then it can be expensive. So in Delaware and other places, insurance is not going to cover this. So people who do use it, every day on a regular basis have told me that they spend about $60 to $80 a week. So just something to be aware of there. So there are advanced therapy options that we usually talk about with Parkinson's disease. These are some of the examples here. You can see the top three devices are all what we call deep brain stimulation devices. There's Medtronic, Abbott, Boston Scientific. There's also Botox injections that we can do, usually for abnormal muscle spasms, to help with that, as Botox, or I should say botulinum toxin, as there's different companies of botulinum toxin. Botox is just the most common one, but it's just a muscle relaxer. So it just uses to locally relax muscles without any systemic side effects. So I do Botox injections. I program DBS, or deep brain stimulation. Usually we have the neurosurgeon do them. Either there's two places in Philly or a couple places in Baltimore, even in DC, that I'll send patients to have this device implanted, and then I'll program you from there on out. And then the bottom right picture is just a picture of what we call Duopa, and this is a infusion pump of carbidopa levodopa into the small intestine. And the small intestine is where levodopa really gets absorbed well and brings it to your brain. And so bypassing the stomach is really going to be the next wave of therapy for levodopa, because the stomach really gets in the way of the medicine working well, especially as you start advancing the disease. This is just an example of what it looks like to have deep brain stimulation. So there are leads and electrodes that get inserted into your brain, to the part of your brain where we can actually program or kind of reprogram your cells to fire correctly. And so it stops things like tremors, slowness of movement, stiffness, things like that. So it pretty much makes your on time, right? The time of the day that your medicine really works. We make that for longer periods of the day. This therapy has been around for over 20 years. A couple 100,000 people have had DBS done, worldwide. So this is something that's more of a routine albeit elective procedure, but still a routine procedure at this point. It is connected to a battery device underneath your skin, and all the wiring is underneath. And again, you would come to a movement disorder specialist like myself for programming of your symptoms and of the device. Now, I'm going to not touch too much on physical therapy and speech therapy since we have a whole nother talk about this, just to know that this is super important, both physical, occupational, and speech therapy. And you really want to find someone, whether it's a physical, occupational, speech therapist who has Parkinson's experience and training. There is a night and day difference. This isn't like going to see someone for a knee issue or a hip issue or a back issue. You really need to find someone. So they can be very helpful. I'll leave that to them to talk about. Speech, super helpful, something you have to keep up for, not only for your voice, but also for swallowing as well. Nutrition and supplements. So, there is no proven diet for Parkinson's disease. The only type of diet that's been consistently proven to be helpful for brain health in general is the Mediterranean diet. You will read some studies here and there about other types of diets, but nothing's been consistently shown to be helpful for Parkinson's or for brain health. Food and especially protein can inhibit the absorption of carbidopa levodopa, and so it's just something to be aware of. A lot of times in the beginning, when I start people on that kind of medicine, I'll actually tell them to take it with meals. It helps you to remember the medicine. It helps you to get over the nausea that you can have with the medicine. But over time, if the medicine is not lasting as long, we'll tell you to start taking it on an empty stomach, which is usually a half hour before meals or an hour after meals. Now, obviously Parkinson's is tough to deal with, but there is some, good things that are coming out with Parkinson's. This is just a kind of timeline over the past 6 years of all the different types of medicines and therapies that have come out over this span of time. And you can see it's almost like 2 or 3 new medications every year. So it's an exciting time to be working in this field and to be a patient, in the sense that at least we have more options than we did for your parents' generation, things like that. And the outlook is only looking good as well. Especially we talk about the outlook and future for Parkinson's. Hopefully we're going to have better what we call biomarkers for Parkinson's. So this biomarkers are ways in order to either track the disease progression, versus just examining someone and following your exam over time. Just like diabetes, right? There are markers in your blood that we follow diabetes with. Hopefully in the future we'll have markers to follow your disease progression. Hopefully there'll be blood markers to diagnose you with Parkinson's, right? Like I said, there is the DAT scan, but otherwise we don't really have anything else to really do that. And then ultimately, hopefully for prognosis too, right? So usually for prognosis, when I talk to patients, it's kind of saying, well, we map out your progress and your progression over a few years, right? And then we can kind of connect the dots and extend that line out into the future on how you're going to progress over time. And that's usually the case for people. A lot of people worry that they're going to be kind of steady going along and then fall off the cliff with their symptoms. That usually doesn't happen. As I mentioned, new ways to deliver levodopa straight to the brain. Levodopa is converted by your body directly into dopamine, which is why it's the oldest and still most effective medicine for Parkinson's, because it essentially replaces the dopamine in your body. And so we're trying to find ways to bypass the stomach, whether that's through inhalers, subcutaneous pumps, or other kind of pump systems, patch systems. And then, trying to find true disease modifying agents. And what we mean by disease modifying is things that slow down the progression of Parkinson's disease. So there's a lot of studies going on. Unfortunately, they tend to fail right before FDA approval, but I still have hope that we'll eventually find something that's good for Parkinson's. And then there's a new procedure called the MRI guided focused ultrasound. This is a non-invasive way to put a lesion in the brain in the area where cells are not really firing correctly, to treat some of the symptoms like tremors, dyskinesias, things like that. It is approved officially to treat one side of your body for Parkinson's tremors. We're still studying it to treat other types of Parkinson's symptoms, and if we can do both sides. So obviously, when we're talking about treating both sides of your body with symptoms, deep brain stimulation is still the procedure that we're going to look into. But if you really have just mainly one-sided symptoms, focused ultrasound may be right for you. And then, hopefully we get better medicines for dementia. Dementia is definitely a tough thing to treat. Not everyone with Parkinson's has dementia, but it's been just a tough thing to treat. So hopefully, for better medicines for that. Now, COVID. I'm not going to belabor the point too much. We all know obviously about COVID. Just a couple kind of pointers with Parkinson's. So far, and there's been somewhat good trial data or just observational data for this, that there doesn't seem to be an increased risk or a significant increased risk of death or contracting the disease with Parkinson's, unlike people with like diabetes, heart disease, things like that. I write here as far as does not count as a pre-existing condition. Up till now, you had to have certain conditions to get the vaccine. Now, obviously, it's been open to more of the population, and actually in Delaware, one of the existing conditions that you can apply for if you're under a certain age is just any kind of neurological disease. So now it would count as something that you can get a vaccine for. Vaccines are safe in Parkinson's patients, so you can definitely get that, and you should get that, to be honest. When we talk about COVID and Parkinson's, we talk about any type of infection, any type of stressor to the body, whether it's a physical stressor like an infection, heart attack, stroke, or psychological stressors even, actually loss of a family member, loss of job, things like this that really cause heightened levels of stress can impact and worsen your physical symptoms of Parkinson's disease. And so just to know that really, it's never a good idea, obviously, if you can avoid it, to get any type of infection, but any type of infection can abruptly worsen your symptoms, hopefully just temporarily, but sometimes those effects can persist. So you should get vaccinated, right? There's very few reasons not to get vaccinated at this point. Whether or not you're getting the Johnson & Johnson, the Moderna, or Pfizer, they've all have great safety profiles, been studied in many people. The technology so Johnson & Johnson is based off the typical flu vaccine technology. So we've been doing that for decades, right? So we know that that's safe. The Moderna and Pfizer is based off a newer technology that's been around for about 10 years. It's always been too expensive to kind of put into production for the flu vaccine. But now that everyone's just loading in money, that's how we really adopted it for COVID, also based off safe technology, and everything within that vaccine is based off safe materials. So again, really no reason to get it. And once you get vaccinated, right, and you wait 2 weeks after your second vaccine or a month after the Johnson & Johnson, guess what you should do? Go back to normal life. There's no reason not to. Variants have been shown to be effective for the vaccines now, and if not, shown to have lesser severity of disease. There's no reason not to get back out there, exercise, do physical therapy. So many people have been worsening over the past year with Parkinson's disease from isolation and lack of exercise. And to be honest, you need to, if you really want a good quality of life and you really want to extend your life, you got to get back out there, live your life normally, right? No reason not to. So as far as our Parkinson's team, I'd like to introduce you, and these people will all be talking to you today. So this is Amy Benton. She is our Parkinson's social worker. She offers a lot of different things that are helpful for our patients. I'm going to let her talk about that. This is Melissa, or Missy Pacheco. She's our Parkinson's office assistant. She's the one that's going to be scheduling you appointments, talking to you about changing appointments, things like that. For most of our appointments, we've been sending it out automatically, and if you have to change it, you just call her. This is Karen Reed. She's our newer Parkinson's nurse coordinator. Been with us, I guess, for 1.5 years now, at least, if not 2 years. She's awesome. If you haven't talked to her on the phone, I'm sure you know her very well. She answers a lot of the calls. She has her own office line number that we'll send out with our newsletter. And so if you have any issues, she talks directly to me. So no, there's no way to directly contact me unless you're doing it through the patient portal and you're messaging. But otherwise, you're calling Karen if you can't get into the patient portal or you're just not into computers and technology, and just call Karen and she'll take care of you. And this is, last but not least, our lovely Sarah Hinkle. She is my nurse practitioner, or our nurse practitioner for Parkinson's. She's extremely good, and she better be because I trained her. But she's really nice, really kind, really caring. To be honest, I know a lot of nurses and nurse practitioners. I've never met anyone, as smart or as good as she is. And so we're really lucky to have her. She helps me see my patients because I'm a busy person. I'm only one man show here, right? So I really need help, and these lovely people tend to help me to really see my patients, especially Sarah. If you need to be seen every few months, she's going to be the one to do it. We'll kind of offset visits, and I'll see you obviously continuously, but she really helps take care of you. And really, I have no doubt she can't do as good a job as me. And in fact, some patients even want to see her over me. So you never know. So as far as kind of things that are coming up with Christiana Care and really Parkinson's care in Delaware. So this is kind of a big initiative that I want to make you all aware of, and most people don't know about this. So I just want to kind of bring all the Parkinson's patients and caregivers up to speed. So a couple of years ago now, unfortunately, last year was a wash, but a couple of years ago, we formed the Delaware Parkinsons Disease Task Force. And what this is it's a group of people all experienced with Parkinson's disease in some way, whether they're a physical, occupational speech therapist, rehab facility staff or manager, Delaware leaders, home care agents, social workers, University of Delaware Dean Matt is a part of the group, Michael J. Fox, co-founder, Debbie Moore is a part of the group, Delaware state officials from Delaware Health and Human Services, myself, and pretty much all of our team, Sarah, Karen, and Amy are all a part of this group. And the reason I formed this group is to really improve the care of Parkinson's disease in Delaware. Unfortunately, even with me and our great team here, the care in Delaware for Parkinson's tends to sometimes be lacking in a number of ways. Communication is fragmented. Just organized care is really not there. And really, we need to bring people up to speed with good quality of care with Parkinson's disease. And so this is the goal of this task force. Now, as far as the timeline of this task force, so again, 2 years ago, I invited people to this group. You can notice that there was no caregiver or patient included in this group, and I'll touch that in a second. But so I sent out invitations, got the group together in the summer. We went over kind of what I saw the goal of this kind of project to be, and we broke up into work groups based off different kind of areas in Parkinson's that we wanted to focus on. We had work group meetings, luckily, right before the pandemic started, so we were able to meet and really work out kind of what kind of ideas we had to improve the care in Parkinson's. And what we were supposed to have last year, a year ago, was these town halls. And what these town halls are supposed to do is they're supposed to bring together you guys. So Parkinson's patients and caregivers, we're going to pitch out all of our ideas, right? And we really want your input on what you think is important to you, right? So again, I realize that, not having Parkinson's patients and caregivers at the table to begin with could be definitely an issue, right? You guys are going through this every day. You know what's important to you. We just really wanted to have a focused, group to say, what do we think are important and what do we think we can do for patients? And then here's all of our ideas. What do you all think of it, right? So that's the goal. We are planning to have these town halls this year. In fact, hopefully within the next month or so. It's going to be virtually. More information to come as far as the date, time. We may have 2 of them just to kind of separate them out, allow more voices to be heard. We may even, separate it by location, right? People more down south can have one day, up north can have another day, and we welcome any type of ideas that you have. We want you to be honest. This is, again, to hopefully improve your guys' health and well-being and the caregivers as well. So, come prepared to participate, and again, more information to come. And then hopefully one of the big things that we're going to do, not only with these ideas, with these ideas, but also with the sponsors that support this symposium, is hopefully we're going to develop a Delaware statewide website for Parkinson's that'll have any kind of resource or information, message boards, a lot of other cool things that will be a one-stop shop for Parkinson's patients in the Delaware region to go to say, I need help or I need to know something. Where do I get the information? Hopefully this kind of website will be owned at a state level, but probably will be run by someone from Christiana. But again, it's not going to be a competitive thing. We're going to include all different types of resources for physical therapy, hospitalizations, rehab facilities, nursing homes. We hope to have it all there for your ability to peruse it and get more information on it. So we did get a lot of sponsors this year with the symposium. So this is definitely a thing that's going to be coming out as well. Again, more stay tuned for more information. And so I'm pretty much done. I just want to leave you with one quote from Albert Einstein, very important for Parkinson's patients to keep to heart is, life is like riding a bicycle. In order to keep your balance, you must keep moving, right? And that's what we talk about. Keep moving, please. It's important. You feel better. It's just as good as medications. Again, this past year, no one's doing well. We need to bounce back from this. We need to get out there. And again, especially after vaccinated, live your lives and live them normally. So with that, I would just say thank you for all your support. For Karen's position, which is our Parkinson's nurse, we had a lot of philanthropic support for it. We are taking more support. We want to do a lot more things. We want to hire more people. We want to do more activities, more events in the future. This is just some information if you want to honor a caregiver or honor a patient and support our cause. This is some of the information there, but we're doing a lot of cool things, and hopefully you're going to hear that throughout the day. And so with that, again, if you have any questions, put them in the Q&A box. We will, answer them later in the day in the Q&A session. So I just wanted to say that Dr. Stephen Grill is next. We're going to show you him in a second and his slides, but I do want to introduce him. He is our keynote speaker. So Dr. Stephen Grill is, there's not enough words to say enough good things about him, but right now he is a movement disorder specialist in the Columbia Elk Ridge area in Maryland. He is the leader of the Parkinson's and Movement Disorder Center of Maryland. And he has been working in Maryland for many decades at this point. He, believe it or not, actually, if we were in a live audience, I would expect a huge round of applause for him because he is the reason why I'm here today. So back in high school, my junior year of high school, he would take high school students and mentor them. And I did a year-long mentorship with Dr. Grill. And that's what got me hooked on Parkinson's disease. So, I've only been here for 5 years after my fellowship, but I've been doing this, I say, since my junior year of high school because of Dr. Grill. He's a brilliant man. To be honest, I trust anyone with him, including my own family members. And he does a lot of cool research, even within his private practice, which is a really neat thing. But again, can't say enough good things about him as my mentor over the years, and just I'll let him take it away.
Okay, hopefully, are we sharing?
Yep, I see your slides.
You see the slides, okay, good. Okay, well, thank you, Dr. Martello, Justin, for having me here and to talk about this topic, which is dear to my heart. And I'm going to make the point during this presentation that each individual person out there with Parkinson's can make decisions at any given stage in the disease that will affect how you function in the future. And I would say that you can make good decisions, and if you make those decisions, you can do well, and you can live approximately in your normal lifespan, and it can be good quality. And that's going to be the point of this presentation. I do want to acknowledge Dr. Martello, and that he was a high school student with me, as you mentioned, 25 years ago. And so I take responsibility and credit for any of his subsequent accomplishments. Okay, first I want to point out that I have no Conflicts of interest during this presentation. I have no financial interest in anything that I'll be talking about. Okay, what does it mean to thrive? What is thriving? So a definition that we can look at is thriving means that you grow or develop successfully, that you may flourish or succeed and realize your goals despite or because of circumstances. So here's a nice garden from Japan, and you can see it's a shaded garden, but yet it's still thriving. You can see how beautiful and gorgeous it is. So throughout the talk, you'll see various gardens throughout the world. Okay, so the first thing that I want to address is I want to define what we call functional capacity. So functional capacity represents an individual's ability to perform your daily functions, your daily activities in the physical, psychological, social, and spiritual domains of life. And a few more definitions. So when anybody has a disease, any sort of chronic disease, you may become impaired with it, or just in regular aging. You know, none of us are, doing as well as when we were 18 years old, most likely. So as we age, we develop, other diseases. We might have arthritis. We develop some limitations, and we may have what we call an impairment due to that disease. Most of us are able to continue to function and carry out all of our daily activities. But when you have a chronic disease, it becomes more of a challenge. And I know the term handicap has fallen out of favor, but it's actually a useful medical term that we use in describing functional capacity. So what does it mean to be handicapped? So if you have an impairment, you have some limitation, but if you're impaired and not handicapped, that means you can still carry out all of your activities without any help. If you have a handicap, then that means that by using some device, perhaps maybe using a walker, that you can still carry out all your activities independently with that bit of help. So that's what it means to be handicapped. Even though we don't like the term, the connotation has fallen out of favor. It's actually, you would much rather be handicapped than be disabled, because disabled means that even with some extra help, even with using a walker, for example, you still can't carry out your activities of daily life. And so I would submit that most people, we want to try to stay in the impaired zone. But if you can be in the handicapped zone for the rest of your life, where you can still be independent and carry out your activities, that's pretty good. So when you have a chronic disease, it may shift it more towards the disabled zone. But I submit that if you make right decisions, beginning at the beginning stages of your disease or at any point during your disease, you can shift more towards the green zone. You can become less disabled, less handicapped. Now there are, what I'm showing here is this progression of symptoms, but there can be sudden changes too. So here's an example of someone who was doing pretty well, but then they suffered a hip fracture. And that can be a game changer where suddenly you may become more impaired and maybe become more disabled. So let's talk about how to stay more towards the yellow and even the green zone. And that will be the thrust of this discussion today. So how to thrive. These are 4 areas that I think are important. You should educate yourself about your disease, and not just Parkinson's, your other diseases as well. You should lead a healthy life. Leading a healthy life is shown to be beneficial to you, which makes sense. It's not rocket science. You should be a compliant but savvy patient. So you don't have to do everything that your clinicians are advising you to do, but if you don't, let us know so we can come up with alternatives. And make good choices in how you get your health care. We'll talk about that. And then don't take inappropriate risks. So, and if you do these things, I think people can thrive. Here's another nice garden in China. That's a shaded garden, and yet look how beautiful it is. It's still thriving. Okay, let's turn to, let's start with how to educate yourself and the benefits of education. So there actually has been research done on the benefits of education in Parkinson's. And so people that are satisfied with the explanation of the condition at diagnosis end up having a higher quality of life. So if you understand your disease and you understand, you know, what's causing your disease and how to manage it, you end up having a higher quality of life. And in chronic disease, information seeking is a better strategy than just wishing that things get better. So, you know, I think it is important. It really is important. So if you understand how your medicines work, you're going to be more compliant with taking them. So this is just an example, and I think Dr. Martello touched on this, that, you know, the levodopa in your system, it takes maybe a half an hour to get into your system, and then it only lasts in your system maybe 3-4 hours or so. So if you understand how your medicine works, then you'll understand why it's important to be on a regular schedule and to not miss doses. And here's some fun quotes. Education is a progressive discovery of our ignorance. And then another one, a succession of eye-openers, each involving the repudiation of some previously held belief. George Bernard Shaw. Okay, so this is another study that evaluated over 700 patients and what they did was they looked at their quality of life, and there's different scales that we use to estimate quality of life. And they looked at how satisfied patients were in different educational domains. So for example, how satisfied that they were educated and understand their disease and what causes it, that they understand how medicines are effective, understanding adverse reactions to medicines, understanding what resources are available to them, you know, whether there's some various therapists in their community and different, maybe the Department of Aging has programs for people, and then also understand rehabilitation, physical, occupational, and speech therapies, and how they affect daily activities. So what was shown in this study was that people that had higher education scores, they had a higher quality of life. So really important to educate yourself. So how can you do that? Well, probably the best source to give information specifically about you is from your own neurologist, your movement specialist, because they understand you well, and they also are trained in understanding Parkinson's. So they can give you good information. Parkinson's foundations are a good source. So the Parkinson's Foundation of the National Capital Area, and Delaware is included in that. So Dr. Martello is very active in this organization. So they have a good website, and they sponsor symposia. The National Parkinsons Associations are good sources of information, including the Michael J. Fox Foundation. Support groups, and I know Dr. Martello was talking about getting the community involved. So participating in these various support groups on a regular basis is important. Symposia, so we're talking to the choir right now, you know, those of you that are here, you know, you go attend various symposia, local centers, and there are some national ones as well. Be careful of websites. So, you know, there's a lot of misinformation on the internet if you haven't heard. And so, you know, really be careful what websites you go to. If you go to some reputable websites like the foundations I listed here, and NIH has good websites, so be careful about where you go. There are various books, if you're a good reader, and I'll give a list of them in a minute, that you can use to educate yourself, and then follow what's going on in the news about developments in Parkinson's. You know, clinical trials are always ongoing. You know, be a savvy consumer of information. Here are some recommended books that are written by very esteemed colleagues, and then on the bottom right, there's some personal accounts. Michael J. Fox, his book is very good, and here's one by a hockey player, describes his experiences, and then Joel Haverman was a journalist for the Los Angeles Times, and his book is very insightful as well. So, you know, be careful about how you get your education, get it from good sources. And, you know, most of you are here because you're trying to educate yourself, and that's wonderful. So there's a lot of good ways to educate yourself. Okay, let's turn to this healthy lifestyle. And I know that if you've attended any symposia, and if you're Dr. Martello's patient, I'm sure that he's telling you to exercise. So lead a healthy lifestyle, exercise your mind, exercise your body, eat healthily, and try to be at an approximately an ideal body weight. And here's another beautiful garden in the Netherlands. You see it's shaded and it's still thriving. So exercise. What should you do? What is exercise? Exercise it involves some sort of sustained, ongoing physical activity, and you should get your heart rate up. And that's aerobic exercise. Getting your heart rate up, breaking a sweat is good. You should target 20 to 30 minutes. If you're not exercising now, you get into it gradually. Do 5 minutes, then 10 minutes. Gradually build up to it. And cardiovascularly, it also means that you're increasing your oxygen uptake when you're exercising. So there's all different types of exercise. Everybody's different in what they enjoy, what they want to do. Walking or jogging is great in the neighborhood. Meet the neighbors, all that. If you like on a treadmill, you can listen to the radio or watch television while you're doing it. Elliptical, swimming, water walking is great, overcoming the resistance in a pool. If you like sports, so choose an activity that you're going to enjoy, and you can cross-train. Do one thing one day, another thing another day. So playing tennis is good exercise as long as your balance is good. Fencing. So that picture of the fencing, that's me there. Losing to one of my patients in a fencing expedition. So fencing is a really good activity if you enjoy that. And then if you're doing yard work, that can count. So if you do an hour of raking leaves, that can count as exercise. So you should target about at least 90 minutes a week. And again, if you're not exercising now, you gradually build up. So what are the benefits of exercise? So there, of course, everybody knows that there's general health benefits. It's good for your heart, for your brain, good cardiovascular health. There's a reduction in osteoporosis and fracture risk, just being upright and bearing weight. It burns calories, so if you're trying to take off some weight, burning more calories is a good way to help with that. It also improves your walking. It improves your gait. If you do walking on a treadmill or walking outside, it definitely improves how well you walk. So the more you walk, the better your walking will be. And it also seems to have neuroprotective effects in Parkinson's. Similar magnitude, I think Dr. Martello mentioned smoking and caffeine, but it's a healthier activity. There's no really adverse effects to exercise, and it does seem to slow down disease progression in Parkinson's. It also seems to reduce the risk of dementia, which can happen in Parkinson's, maybe 30% of people, but it reduces that risk. And exercise is also an antidepressant and an anti-anxiety treatment, again, with no side effects to it. So all these are good reasons to really be exercising. And in Parkinson's, it is a standard management protocol that everybody with Parkinson's should be getting exercise. So this is a really interesting study that demonstrates that people that exercised in their adult life, in their young adult life, in their 30s, or at least 10 years before onset of their being evaluated, that there was a reduced risk of developing Parkinson's by 40% compared to people who were sedentary, who weren't exercising. This is real. So it really seems to be beneficial. And once you have Parkinson's, it's also beneficial. So this, this was a study of 2,200 patients who were seen at 2 points in time, a year later after the first evaluation, and they were grouped into 3 groups: people that didn't exercise, people that did low exercise, and that people were regularly exercising. And without going into each one of the individual graphs, what the endpoint of the study was that regular exercise had a better quality of life, better mobility, their disease was progressing more slowly, the caregivers, the partners, were less stressed, and there was less cognitive decline. So very clear, big study, results are pretty clear. Now this is another, this was another randomized study of 3 types of physical exercise. It was a 3-month study, and they looked at 67 patients, and they randomized them to either high intensity exercise where they were really running, almost running on the treadmill, lower intensity treadmill work, and then just stretching. And what they found was that gait improved, walking improved in all three interventions, the lower intensity actually the most, but the treadmill exercise also improved cardiovascular fitness and walking speed. Stretching increased muscle strength. So I always recommend that you do a combination of aerobic exercise as well as some light weights. It's good for bone health. It's good for muscle strength. But again, here's a randomized study looking at exercise and showing benefit. And one more very interesting study. This is really interesting. Not many people know what the hippocampus is out there, but the hippocampus is an area of the brain that cements memories. So it allows you, once you have you're experiencing some event, the hippocampus allows you to keep that, to cement a memory, to put a memory down. If your hippocampus areas are damaged, then you can't put down memories. So the hippocampus shrinks as we age. But what this study was, the whole point of this study was that it was a randomized controlled study. So people were randomized to moderate exercise 3 times a week versus stretching. And what they found was that in the people that exercised, the hippocampus, I guess it's hippocampi, because it's plural, that they got bigger, that now the neurons in the brain don't divide, but the supporting elements around the neurons do, and they were increased, and they helped the neurons function better. So really an interesting study demonstrating real effects of exercise on changes in the brain and improvements in memory. So the people that exercised, also their memory was better than the control group a year later. Okay, so I hope I've gotten the point that exercise is important. So my exercise recommendations are that, again, it's a primary treatment strategy. Everybody with Parkinson's should be exercising. The choice of exercise should be tailored to the individual. So it should be based upon your interests and your limitations. So if you have a balance problem, then then treadmill walking is probably not the best thing for you, and instead an exercise bike or water walking, things like that, may be better for you if you have a limitation. If you have severe heart disease and your cardiologist gives you some limitations, then you need to go along with that. But also your interests. What things do you enjoy? What forms of exercise do you enjoy? And if you enjoy what you're doing, then you're more likely to stick to it. And then cross-training is good, walking one day, jogging, swimming, water walking, you can vary what you do. Often a good idea is to involve your physical therapist, who should be part of your team. Everybody should have a physical therapist and speech therapist as part of their team. So you could ask your physical therapist for a recommendation about what types of exercises would be best for you, given their knowledge of your condition and your specific illnesses. So again, there are some limitations that you may have to adhere to, and but find something that you enjoy doing. Okay, let's touch a bit on weight in Parkinson's. So people with Parkinson's are at risk of malnutrition, of not getting enough food, and being too lean, being underweight, and also with some risk for obesity. So obesity is a real issue in Parkinson's. So and in all aging, in people that are aging without Parkinson's. So with obesity, there's a greater risk of impaired physical functioning and a higher risk of injury, of falls. And differences in how our postural control, in our level of postural control, and our walking and our gait have been found in people who are obese. What happens is, you can see that on the figure, there's that red dot. and that's showing the center of gravity. So normally, the center of gravity should be right over your feet. If you have extra weight, then it shifts that center of gravity forward, and it makes it harder for the brain to control your balance. Because, walking with 2 feet is a lot harder than, animals that have 4 feet. We have to really maintain our balance. And so I always like to say that there should be no weak links in the chain in people with Parkinson's. So you should try to be as fit as you can, and that way the brain has an easier time controlling your body, and there'll be a reduced risk of fall. So this is a study looking at that center of pressure. And so this is an individual standing on a force plate, and it measures the force and the center of pressure. And again, it should be right over the feet. And what the study is showing is that people that are overweight, who are obese, there's more lateral displacements. There's more sway. People are swaying back and forth a bit. And those excursions while people are walking is greater in people who are obese. And this is part of that study. Similar study showed that body mass index, that a higher body mass index results in greater displacement of that center of pressure. So more sway when you're walking, and body weight accounted for 52% of that balance instability. So really trying to be at an ideal body weight, really toned, really exercised, make it a goal that you're going to be in better shape than everybody you know. And then you'll do better long term. Okay, so let's turn to the next topic. And the next topic is about being a compliant but savvy patient. So you should choose the right physician. You should facilitate integrated care. Get all your team working together. All your clinicians working together. And then be prepared for your visits with your clinicians, with your physicians, with your therapists. Come prepared to those visits. And here's another wonderful garden in Toronto. Okay, first thing is you want to choose a specialist. So how do you choose a specialist? Check your insurance, make sure that they're in your plan. Consider the hospital affiliation. If you're one that gets hospitalized for some reason, see that your clinician, your doc, is affiliated there. Look for board certification. It does indicate a certain level of expertise of having documented that your clinician is certified. Watch out for any sort of red flags in the office if things don't seem right. You have to have a compatible relationship with your clinicians, and not everybody hits it off with everybody else. So if you're not communicating well, then maybe bring it up to your clinician. And if you just don't think you can communicate for whatever reason with a specific physician, then you should seek someone else out. Ask about drug reps. If there's more drug reps in the waiting room than patients, that might be an issue. Understand the office policies about scheduling and cancellation. Scrutinize the staff. You have to get along with the staff. They're part of the team too. So hopefully you can have good relationships with the whole staff in the clinic. And then factor in technology. We're all using electronic medical records. There's no way around it. Unfortunately, a lot of office notes now look like a computer interviewed a robot, and we sort of got lost in it. So, but having, most practices use electronic medical records, and it's really hard to practice without that. Okay, so let's talk about the choice of specialists. And Dr. Martello touched on this in his presentation. But it really is important that you see a specialist. And this is one study that looked at a large number of cases in Parkinson's, and 138,000. And of those patients, 58% received care from a neurologist, and the other were just getting care from primary care physicians. Interesting in that study that women and minorities were less likely to seek care by a neurologist. But what came out of this study was that if you see a neurologist to treat you, then you're less likely to end up in a nursing facility, you had a lower risk of hip fracture, and you also lived longer. And that's what this graph is showing. It's showing that from the onset of when they were seen to when they died, that people that was seeing an internist, a primary care physician, died at a faster rate than those seeing a neurologist. Now, there are neurologists and there are movement disorder specialists. And I'm never shy about saying that I think most people with Parkinson's, if there's one in your area, should be seen by a movement disorder specialist. This is a study, and I think Dr. Martello referred to this one too, looking at how well we diagnose Parkinson's. And movement disorder specialists who use specific criteria in making their diagnosis are about 99% accurate in making the diagnosis. And you can see that those neurologists diagnosing aren't quite as good at making the diagnosis. Furthermore, this is a study looking at people who had both an internist and a specialist, a movement disorder specialist, versus compared to just those that was seen by a general neurologist. And without going into the individual graphs, I'm just going to report that the study demonstrated that the quality of life was better in people who were seen by a movement specialist, and so was the motor functioning. So the Unified Parkinson's Disease Rating Scale, that's how we evaluate you with, the finger movements, all that, that people's motor functioning was better when they were treated by a movement disorder specialist. And then finally, this is another study looking at care by a movement disorder specialist versus those that weren't, looking at the mortality rates. And again, this shows that the mortality is similar for the first 10 years, and then there's a modest increase in mortality beyond that. And this is a 20-year follow-up study, so it's a long study. So again, I'm not shy about suggesting that you get your care from a movement disorder specialist. You're more likely to be diagnosed correctly, and you're more likely to be managed correctly. Okay, now once you have your specialist, you should understand that it's not just your movement specialist, that you should have a whole team, and that your care should be integrated as much as possible. And the reasons for this is that, with Parkinson's, as Dr. Martello went over, there's a broad range of motor and non-motor symptoms, and everybody progresses at different rates. And we have to adapt to each individual in how they're progressing. But also, most people have more than one disease. Very few people just have Parkinson's. So it's important that you have a team that can work with you in terms of your Parkinson's and your other diseases. So it's important that we all communicate and try to work together. So the issues that we want to talk about are which disciplines should be involved, how should your team members communicate, and should specialists operate and we should operate in parallel together rather than in isolation. So here are the potential team members. So your internist is really the captain of the ship. For you should be integrating all the other specialists that you might be seeing. So any other specialist, whether you have a cardiologist or a pulmonary doctor or a endocrinologist, we should all be part of your team, psychiatrists, and then other healthcare providers, physical therapists, occupational therapists, speech therapists. Everybody with Parkinson's, I think, should have a therapy team, and try to stick to that therapist so they get to know you, and you should be seeing your physical and speech probably about once a year at least, even from the very beginning. Psychologists are part of the team, dietitians, social workers. I'm happy to see that your clinic there has a social worker. And then your family members, caregivers, friends, they can be part of your team. Exercise trainers, a home safety contractor who's putting in your grab bars in your shower, they're part of your team. And so this and having a team approach is really important. So let's talk about the different team approaches that have been studied. So multidisciplinary care is where each discipline is responsible for a specific need. It's sort of the model in medicine that we have, that you sort of go to different physicians and, you know, we try to get each other to communicate, but sometimes not as well as we would want. Interdisciplinary care means that team members work collaboratively with face-to-face meetings, and there are actually studies on this, and make group decisions. So good luck getting all your team to, good luck getting your team to all sit down and talk to you for half an hour. It would be wonderful. It's great. It works. It's really great, but it's hard to get there. And integrative care is even more synergistically charged plan of care with consensus building and all that. And these models have been studied, but they're just not practical in the real world, most of them. So here's multidisciplinary care, where you sort of go to each of your clinicians, each of your team members, and you know, you're sort of going back and forth. Maybe you see your neurologist, movement specialist, and you say, well, my psychiatrist recommended this, and, you know, or my pulmonologist said this, or my physical therapist said that, and we're not really communicating amongst our, you know, the whole team. So interdisciplinary care is more that we're communicating. Now, you're not going to get us to sit down at the same table together, but you should try to ensure that we're at least all communicating. We're sending each other notes, and we actually do contact each other when there's something urgent that we want to talk about, when we think that, you know, another clinician and maybe a different specialty, what they're doing impacts what we're doing. So, you know, facilitating this sort of communication is really important, and you should be doing this. You should be trying to make your care as interdisciplinary as you can. So what can you do? So first thing is bring a medication list to each one of your visits to all of your clinicians. So if we don't know what medicines you are, we don't know what adverse effects you may be having from them, we don't know what interactions they may have with some of the medicines that we're prescribing. So bring a good medication list. You should have one in your pocket at all times, just in case for some reason you end up in the emergency room and they want to know what medicines you're on. Bring a contact list of all your clinicians that you want your notes sent to. So once you give it to the office, to any given office, you know, we're all using electronic medical records. Once your other specialists and your internist is sort of in our list, then every visit it's just clicking a button to fax it to them, to fax the notes to them. So it's very easy to get it done. Remind your physicians and your therapists to send notes to each other. Now, I try to get the physical and all the therapists to send me their notes, even if I'm not the one that actually did the prescription. You know, they're pretty much obligated to send their notes to the prescribing physician. But if your movement specialist wasn't the one who happened to do the prescription, ask the therapist to send the notes to your movement disorder specialist as well. When you're hospitalized, arrange to have your hospital records sent to your physician. Sometimes they change the medicines. It's really common in people that are hospitalized to come out of the hospitalization and maybe you're on carbidopa, levodopa, you know, at 4-hour intervals, you know, certain times, or 3-hour intervals even. It's not uncommon for people to come out of the hospital where they're just told to take it 5 times a day and without any specifics about the timing, and they sort of inadvertently and not on purpose, they change how the person is taking their medicine. So let's not let that happen. Have your hospital records sent to your physicians, and then be prepared for your visit. So come prepared to your visit with a list of discussion topics. Hopefully not 10, or else it'll take a longer visit. But you know, what are the main things you're concerned about in terms of your disease, and make sure that those get addressed during the visit. Okay, and let's turn to the next topic about taking inappropriate risks, about how to take risks. And here's another beautiful garden in Ireland. There are some things that you just shouldn't do. And this is one of them. So if you're using a walker, you're going to pay some kids in the neighborhood to shovel the snow. You're not going to do it yourself. Okay. What is risk? So in terms of medical risk, we're talking about a probability of threat or damage, of damage or injury caused by an event that could be avoided by avoiding a certain situation or by taking some action. So you should consider risk and consequences together. So if there's a low risk activity that has minimal consequences if you fail, then go ahead and do it. So playing cards, there's no risk. If you fail, well, you've lost some of your pride. But there's that sort of physical activity, there's no risk and of any severe outcomes, and go ahead and do it. However, if you're considering, with Parkinson's, it's about taking up tightrope walking, that's a high probability that you're going to fall. And falling off a tightrope, there's a high risk of injury. So you should avoid that activity. Since the impact can be extreme, falling off of a tightrope is, you're going to break a bone, and the risk is high. Those sort of activities you're going to want to avoid. All right, so this next slide is a little bit complicated, but I do want to try to get to it. And it's about, and it's concerning that, we can help your disease. We can make your symptoms better with medicines and various therapies. And that's one way to have a better quality of life. But the other is that you may need to change your strategy. So you change how you go about your life, and then you can have a higher quality of life from doing that as well. So this is a little bit of a complicated slide, but I do want to try to get it across. So this is what we call, there's a speed accuracy trade-off. So on the graph, we're seeing on the x-axis speed and on the y-axis accuracy. So it makes sense that if you do something really fast, then your accuracy is going to be less. So for example, if I'm going to point to the camera and I go really quick, I might miss it. But if I go really slow, I can get it right on target and be perfectly accurate. And so this is sort of a metaphor for life, that you choose where on this curve you operate. You can decide, well, I am going to walk really fast and not care if I fall. And then your accuracy of your foot placement, for example, is going to be less, going to be worse. And then you may end up suffering a fall and maybe breaking a bone. Or you can decide, well, I'm not going to take any risk. I am going to, just take, really walk slowly and be extra careful and walk at a low speed and then never ever have any risk of falling. Or you can operate somewhere in between. There's some, optimal point where the risk is very low and you need to walk at a certain speed, for example, to get, to function in life. Now, with a disease, that curve shifts down. So for any given speed, you're less accurate, and that's the problem. So in a chronic disease, you're operating on a curve that's at a different location. You still get to choose where you are on that curve, but you may have to decide to really slow down in some of the things you're doing or change your behaviors in order to have the same accuracy and avoid falling. Okay. Just one slide about the risk of falls, because this is so important. I mentioned that people with Parkinson's live about a normal lifespan, right? And most of it can be good quality. But there are some things that really can change that. And one of them is falls and hip fractures. So people with Parkinson's may live a normal lifespan, except for the ones that maybe fall and break hips and end up bedbound. That can happen. So this is a study looking at 1,092 patients who were included, and you can see that almost 50% of them were considered non-fallers. So a fall means that you inadvertently end up on the ground without being pushed. So almost half were non-fallers, but you can see that some were fallers but didn't have any injuries, and some were injured but didn't need any treatment, and then some needed treatment but didn't have a fracture, and then some fractured bones but didn't need surgery, and then some needed surgery. And unfortunately, in regular aging without Parkinson's, most of the fractures happen in the wrist because they have a good reflex to put out their wrist to break the fall. But in Parkinson's, much more risk of a hip or a pelvis fracture or a trunk fracture because those reflexes aren't as good. So, if you are having falls or if you're at risk for falls, then you need to sort of go with the program, and that includes, having good physical therapy and possibly and probably adapting to using a good walker in order to prevent those falls. These walkers can give you real independence, so you can carry out all your activities without much risk of falling. And this shows one of my patients, and it shows that this person had Parkinson's for about 9 years, and then suffered a hip fracture. And on the y-axis, we're showing how fast they walked, basically. And you can see that they were walking at a really normal pace, a pretty good pace, until they developed that hip fracture. And then with the hip fracture, they never quite walked as well again. So this is avoidable by changing your strategy, by changing your behavior, by agreeing to have physical therapy and agreeing to use a walker if necessary. Okay, so let's talk about the ways that you can reduce your risk. The first thing to consider is home safety. So you should make sure that there's good lighting in your home, on stairways, but also, especially at night on your way to the bathroom. If you're getting up to go to the bathroom, turn the lights on. So normally our balance is due to our good balance is due to a combination of different things, including our inner ear helps our balance, our vision helps our balance, and then there are also sensory structures and muscles that gives us information that helps our balance. So if one of those is out, if your vision is low because it's nighttime and you're not seeing as well, then you're at more risk for falls. And one of the studies I was involved in showed that people with Parkinson's were less able to sort of switch which one of those modalities, those sensory modalities, either the inner ear or the sensory structures in the muscle or the vision, that people with Parkinson's were less likely to shift, less able to shift to using the other two if one of them was out. So especially important in people with Parkinson's at night to turn the lights on if you get up to go to the bathroom. Remove obstacles in the home. If you have throw rugs or ottomans, and these are places where you're at risk for falling, then get rid of them. Often it's good to have a home safety evaluation. So therapists can come into your home and you can point out where there are problems, where you seem to hesitate or freeze or fall, and then they can make suggestions in your home about how to modify things so that it's safer. Most middle-aged people should have grab bars in the shower and also have non-skid mats in the shower. The bathroom is the most dangerous room in the house, and the shower is probably the most dangerous part of the bathroom. So have good grab bars installed professionally, not those suction cup ones. Those are not adequate. A lift chair can be helpful for people who fall during transitioning from a chair to standing and walking, and that's shown on the bottom right. And again, be compliant with the use of assistive devices if they're needed. You should avoid certain activities. No climbing ladders. What the heck is that going on there? Shouldn't be happening. That guy should not be climbing a ladder. No cleaning gutters or whatever he's doing. And then reduce your risk of taking medicines incorrectly. So it's really hard to take medicines, and with Parkinson's, you got to do it several times a day most of the time. So, we all go through this where you wonder, did I take my medicine or didn't I? So one way to be more accurate in that is to have a pill box that you filled ahead of time. And that way, if the pill is not in the box, then you know you didn't take it. If it's not in the box, then you knew you took it. So you can reduce the risk of double dosing, of overdosing. And then get a pill timer to stay on schedule. Most smartphones, there are apps for them that can give you an interval timer so that you can take your medicines at regular intervals. Okay, so, and then there's some life decisions that you're going to want, that we all have to make at some point in our life. So we all are determining, when is it time to retire, when or if I need to use a walker, when should I stop driving? This is a big issue in all of us as we get older. We love the independence of driving, but there comes a point when we may just not be safe, whether it's from cognitive problems or that if your stiffness is preventing you from steering well, or your reactions are slower and you can't get to the brake in time. So if you're having some concerns, or mainly if your family is having concerns, then subject yourself to an first in the office evaluation by an occupational therapist, and then on the road driving evaluation. And then we have to decide when and if to move to senior living or assisted living. Most people don't need to move to assisted living, but there may come a point when you want to move to senior living, so you don't have to do the leaves or the snow, that sort of thing. But there are all these decisions, and sometimes your doc will make suggestions that it's time to do something. So I remember, this is not one of my patients, but I did have an 80-year-old lady who was riding a motorcycle, and I did have to ask her that to suggest that maybe it was time to give up riding a motorcycle. So anyway, we all have to make decisions. Just think about it. Maybe on your birthday, think about what decision should I make this year in order to reduce your risks and also maximize your potential to thrive, to realize all the goals that you want in life. Okay, so in summary, what we've talked about is the importance of educating yourself about the disease. And you're here today, you're going to get a lot more education today, but seek out other ways to get educated by reading and certain websites and going to other symposia. And hopefully this symposium will be a yearly event and you'll be able to continue to get your education. Leading a healthy life. This is your way to take charge of the disease. So you can definitely do these things, the exercise, the avoiding risks, eating healthily, all these things really, really make an impact in your disease. And I submit, if you make good decisions, that you can be in the upper part of this progression rather than more towards the disabled part. Be a compliant but savvy patient. Get good care. Make sure you're entitled to it. You have insurance, you have Medicare. You're entitled to the best of care, and you're entitled to a good team that works together. Ensure that your team works together by facilitating communication. And then don't take risks you shouldn't. We all have to face this. I remember a time where I got together with my high school buddies, and we went back 20 years after we were in high school, and we played basketball against some high school students where we used to live. And I sprained an ankle. We all got injured, and we were trying to be 18 years old again, and we're not. So you're not either. So you have to understand that as you age, and also as you age with a chronic disease, there are some activities that you'll have to modify, and some things you just can't do, and you have to figure out how to replace them with similarly enjoyable activities. So come up with ways to do things that don't pose a risk, and really, again, if you have a risk of falling, agree to the physical therapy, agree to use a walker. When I see somebody out on the street, using a walker or maybe crossing some busy street, when I look at them, I don't think pity. I don't think down on them. I think, wow, they're doing great, and they're overcoming their impairment and using their walker, and they're doing what they want to do. And I think, wow, this is great. More power to them, and my respect increases. I don't think of them in a lesser way. I think of them in a greater way. So here's this beautiful tree, the last sort of garden, and it's this beauty. You can see it's an old tree. It's been there for a really long time. And, you know, some of these trees need help. So here's a tree crutch, and it's still a beautiful tree, and everybody loves it. It provides shade. It's hopefully going to be around for a lot longer, and it's going to thrive, but it's handicapped, right? It's got a crutch helping it, and it's still a great tree, and it's still got a lot of life left in it, and it's going to thrive. So I'm going to finish on that really you can take charge of your disease if you do a lot of these things that we're talking about here. And thank you for your attention. And again, thank you for having me at the symposium. I think I'm 3 minutes early, which is fine.
Yes, thanks, Dr. Grill. That was a great talk. I think a lot of times, you know, this is kind of one of those situations where, you know, we tell patients to don't let the disease define you, but you define your disease and how you do with it. And, you know, and you know, half the things we can do for you, right, with medication adjustments and recommendations and things like that. But then, you know, half of it is on you and you know, again, taking ownership of your health. So I think that's, you know, just a great presentation. So thank you for that. The next presentation we have is by Dr. James Ellison. He is one of our expert clinicians and researchers at the Swank Foundation. He is technically the Swank Foundation Endowed Chair in Memory Care and Geriatrics. He is a psychiatrist by training. He also has his master's in public health. He is a professor of psychiatry and human behavior at the Sidney Kimmel Medical College, Thomas Jefferson University, and he is also the editor-in-chief of the Journal of Geriatric Psychiatry and Neurology. And today he will be talking about dementia and other behavioral concerns for Parkinson's. So I will let him take it away. And you're on mute, Dr. Ellison.
How about now? Can you hear me now?
Perfect.
Great. And now, can you see my slides?
Absolutely, yes.
All right, well, now we've gotten over the first hurdle of technology. Thank you so much for inviting me to be a part of this symposium. And already today, I've learned a great deal and am so grateful to be amongst you experts on Parkinson's disease. I have the privilege of talking with you about the non-motor neuropsychiatric symptoms of Parkinson's disease. And although it might sound at first like I'm telling you about lots of other things that can go wrong, the reason for this talk and its importance is to help you recognize many of the associated symptoms in Parkinson's disease that we can help with that may not readily be recognized as part of this complex disease. I have no conflicts of interest to disclose. Some of the medicines that I will discuss are off-label in their use for Parkinson's disease, but I'll identify that. You've already heard about the definition of Parkinsonism and Parkinson's disease. And here's a picture of James Parkinson, who defined this condition. So I won't spend time dwelling on the motor symptoms of Parkinson's disease, which really are what defined it. But James Parkinson was aware also of the non-motor symptoms as well. There are many causes of Parkinson's disease. And again, I'm not going to dwell on those, except to re-emphasize what you already heard from Dr. Martello, that Parkinson's is a syndrome and that there are multiple causes. Now I'm going to get into what I want to talk with you about, which is the non-motor symptoms. And that's everything that doesn't involve physical movement, stiffness, rigidity, or slowness. The reason that these are so important is because they interact with a person's quality of life and also the quality of life and burden on caregivers. They're one of the very important contributors to disability that's associated with Parkinson's disease. And in some cases, when they become severe, and you'll hear about dementia, depression, psychosis, these are things that can accelerate progress towards the need for institutionalization. And when they're treated, those outcomes can be delayed or prevented. What we're going to talk about in the next 45 minutes or so are disorders that affect mood state, sleep, sex, thinking and cognition, understanding of reality. I'm also going to make a mention of some of the behavioral side effects of Parkinson's medications, since these medications, which are miraculous in their benefits, also, like all medicines, have side effects. And then I'm going to talk about, well, if there's some time for questions, I can take some questions. So let me begin with anxiety. We all know what anxiety is, which is the sense of fear dissociated from a specific object of fear. And anxiety comes in many different flavors. When we have anxiety that's hovering, free-floating, physical and also mental, pervasive, it doesn't go away, we call that a generalized anxiety state. And generalized anxiety symptoms are significant in more than half of people with Parkinson's disease. We only diagnose generalized anxiety disorder in about a third of people with Parkinson's. But the important point I want to make is that anxiety can occur and be unrecognized as such. It can be attributed to other factors like worrying about having a disease, even when it could be treated as a separate condition. Now, there are other kinds of anxiety. There's post-traumatic anxiety, obsessive compulsive anxiety. There's also the anxiety that has to do with fearing heights, enclosed spaces, vicious animals. All of these are phobias. And then there's the anxiety that comes on suddenly with an attack of rapid heartbeat, shortness of breath. That would be a panic disorder. And these things are not particularly common in Parkinson's, but they can occur. Generalized anxiety is more typical. When we look for the typical psychiatric syndrome of panic disorder in Parkinson's, we may see something that looks a little like it, but a little different, kind of a partial or related syndrome. And that's true of Parkinson's psychiatric symptoms in general, is that they take on a special flavor that's associated with the disease, and so they can be missed or misattributed. There is a scale called the Parkinson's Anxiety Scale, which clinicians can use, and it's available for people to look at and make use of in their clinical work. It's specialized and tailored to the needs of people with Parkinson's. Anxiety can be caused by lots of different things, but one of the things that we know is that it isn't always just a reaction to having Parkinson's disease. Sometimes it's actually part of the disease itself, and we know that because anxiety can even precede the motor symptoms, and it's also increased in the relatives of people with Parkinson's. On the other hand, it certainly can also be a psychological reaction to a disease which can be more or less disabling. And people worry about losing their mind, ending up in the hospital or a nursing home, dying prematurely. But also, anxiety can be an effect of the medication because the medicines which increase dopamine activity can also heighten anxiety reactions in people. Now, there are no randomized controlled trials that define the best approach, the most perfect approach to treating anxiety in people with Parkinson's. As a psychiatrist, what I would say is we first want to look at the non-pharmacologic approaches. Many people with Parkinson's can benefit in a variety of ways from psychotherapy, particularly what we call cognitive behavior therapy, which examines what we believe about ourselves and the world and helps us refine those beliefs and our behaviors to accord with an accurate view. And in the case of any chronic illness, as you heard from Dr. Grill, there's much that we can do to reduce disability, what we would call excess disability that's added by our fears. We also can use the standard anti-anxiety and antidepressant medications, such as the selective serotonin reuptake inhibitor antidepressants, or the SNRIs, which also affect norepinephrine. Mirtazapine has also been used. One of the problems with these drugs, unfortunately, is that many people with Parkinson's have REM behavior sleep disorder, in which, as you heard from Dr. Martello, they thrash or kick in their dreams and act out dreams, sometimes dangerously so. And these medications, which can help anxiety and depression, sometimes aggravate that condition, not always. So in that situation, we might need different medicines or additional medicines. Buspirone, an anti-anxiety drug, can sometimes be helpful. And even the benzodiazepines, which we worry about using in older adults because of their increasing risk for falls or for confusion, can sometimes be used for short-term periods of time. And we just are careful about oversedation, falls, or cognitive impairment. Now, moving on from anxiety to depression, we've all seen people with depression, sadness, but sometimes rather than sadness, we see loss of motivation or apathy, or we see a sense of withdrawal or irritability. Depression can have many flavors. And depression occurs to a minor degree in almost a quarter of people with Parkinson's, and major depressive disorder, the severe depression, occurs in 17%. It's estimated about 1 in 6. Again, it can precede the motor symptoms or it can occur at any stage, and it can be caused by the disease itself or by the psychological reaction to the disease or by a combination of those. When we say depression is non-dysphoric, we mean that the focus is really on things like emotional or social withdrawal, loss of motivation, flattened affect or masked facial expression, which you know is part of Parkinson's anyway for many people, decreased speech or activity, or slowing. And what you're seeing here is that depression can overlap with some Parkinson's symptoms. So it's important to do a careful differential diagnosis. Dr. Grill mentioned that a psychiatrist can be a valuable part of the team treating somebody with Parkinson's. Depression is not always correlated with Parkinson's severity, and it doesn't always focus on the typical themes of depression, like guilt, shame, or sorrow. And we also know that in Parkinson's disease, the brain undergoes some changes that are likely to affect mood. And these have to do with the dopamine pathways of the brain and those that affect norepinephrine and serotonin, which are the neurotransmitters that are most affected by antidepressants that we use now. This graph or diagram shows you how some of the symptoms that we associate with depression or with Parkinson's overlap. So for example, if we just know that a person has reduced emotional expression, change in appetite or weight, change in sexual interest or function, change in bowel function, change in memory or thinking, or sleep or energy or activity, that alone isn't enough to tell us whether it's depression or Parkinson's. The presence of motor symptoms certainly weighs us towards Parkinson's, and neuroimaging studies can sometimes be helpful. On the other hand, if somebody lacks that capacity to enjoy things or has a history of prior depressive episodes or family history of depression, that sways us in the direction towards depression. We can screen for depression in people with Parkinson's by using any of several widely available tools. And we often like the geriatric depression scale because many of our patients are older. And that has about 30 questions in one form, 15 in a more usable, briefer form. It takes 5 to 10 minutes to administer, and a clinician will administer it. Patients who want to administer a questionnaire to themselves can use the Beck Depression Inventory, which is self-administered. And then there are other tools as well. But what these all focus on is a combination of psychological, emotional, and physical symptoms that are associated with depression. Now, if we do establish that somebody with Parkinson's has depression, one of the first things that we want to do is verify that the medicines for the Parkinson's itself have been optimized because of those overlapping symptoms. Again, like anxiety, let's consider the non-pharmacologic approach of cognitive behavior therapy. There is even evidence that cognitive behavior therapy administered in groups or administered over the phone can help with negative beliefs or behaviors. For example, the belief that I'm too impaired to exercise, because you heard Dr. Grill talk about how very valuable an exercise program can be. But sometimes people resist that for fear that they can't or that they might fall or injure themselves. Many patients prefer talking or psychotherapy, and there also are the experiential groups like exercise, fencing, boxing, dancing. Sometimes, though, antidepressant medication is needed. I talked already about how these SSRIs and SNRIs can aggravate REM behavior disorder, but still sometimes they're used and are useful in treating depression and Parkinson's. The dosing is standard. All of them can also aggravate apathy or motor symptoms. So a clinician has to be experienced in treating people with Parkinson's to recognize when we're looking at depression versus a drug side effect versus the neurological problem. In Parkinson's, sometimes we use some of the old-fashioned medications like nortriptyline, a tricyclic, but because it has different and in some cases more severe side effects, we're careful about that. Pramipexole is a dopamine agonist that may be used to treat the Parkinson's itself or also can be used to treat depression. Mirtazapine or bupropion are additional drugs, and the MAO inhibitor selegiline has been used to boost the SSRI citalopram in one very effective study. ECT is even used, and although many people are concerned about the side effects of electroconvulsive or shock therapy, it actually can have beneficial effects on not only the mood, but the motor symptoms of Parkinson's. TMS is being investigated and may hold promise in the future. As a general guideline, we think about the target symptom that's most prominent, whether it's anxiety, loss of motivation, difficulty with sleep, or psychotic symptoms like delusions or hallucinations. And those will help us pick which antidepressant to try first. The first antidepressant, it's a little bit like that first pancake. It doesn't always turn out perfect. It may not turn out the way we hoped. And sometimes it takes a few tries or a couple tries to arrive at the medicine, the dose, the timing of the dose that works best for any individual patient. Now next, let's talk about fatigue or apathy. And many patients will come to us in psychiatry fearing that there's a situation of depression, when in reality, the symptom is more directly addressed as apathy or loss of motivation, or as fatigue, loss of energy. Fatigue affects as many as half of people with Parkinson's, and many of these people go unrecognized or mistaken for depression. And apathy affects as many as 40% of people with Parkinson's. Apathy is different from depression because depression is loss of enjoyment, but apathy is loss of initiative or motivation. You can tell when somebody has apathy because although they resist doing anything that's fun, once you get them involved in it, be it fencing or dancing or going out for a picnic, they start to enjoy it and they have a good time. They haven't lost that capacity to enjoy themselves that's lost in depression. But effort is diminished. People poop out. And affect can be flattened, which means people are not as emotionally reactive, either to positive or negative types of events. Apathy is a separate condition from depression and anhedonia, but the motor symptoms of Parkinson's, which might involve slowness or reduced movements, can cover up fatigue or apathy and hide it in a way that makes it necessary for us to ask about, this problem. I've heard many patients say, my get up and go got up and went. And that cliche is such a great expression of how people often feel. The mechanism of fatigue and apathy, again, could be psychological, a reaction to having a disease, because that's a downer, or it can relate to the intrinsic pathology of Parkinson's disease, which involves disruption of motivational brain circuits that use dopamine. In addition, sometimes we put people on medicines that are fatiguing, and we have to think about that as well. A medicine that might help with anxiety, for example, might also create tiredness, and so on. So when we're evaluating apathy, we can use special tools like the apathy evaluation scale, which has questions targeted to identify apathy and separate it from depression. But the most important thing is to take a clear history. And I would say the number one thing that we're thinking about is, does the person with apathy lack motivation but not enjoyment? If they've retained their enjoyment, then apathy is the target of treatment. Apathy can be improved by environmental support, such as adequate rest, but prompting and encouragement to get involved and avoiding overexertion. In some cases, medications are used as well. Treatment of a concurrent psychiatric disorder, such as an anxiety or mood disorder, may have secondary benefits for apathy, because apathy can be part of those conditions. The dopaminergic agents for Parkinson's also can benefit apathy. We may get into some other medicines that are less commonly used in Parkinson's, such as amphetamines or methylphenidate. These are drugs that we use very carefully. They're controlled substances. They can have side effects, but in some cases they've been shown to be beneficial for apathy. This acetylcholinesterase inhibitors, like donepezil and its colleagues in that class, also sometimes benefit apathy. A medicine that's designed specifically for wakefulness, modafinil, and works by a different mechanism, doesn't always improve fatigue or motivation, but it can improve sleepiness if that's an issue. Now, next, let me talk about another kind of an emotional disturbance or mood disturbance, which is different from depression or anxiety, but very important and is encountered in Parkinson's. In fact, it's a very common complication. It affects, in some studies, over 40% of people with Parkinson's. Pseudobulbar affect is the term that we use medically to describe inappropriate and uncontrollable bursts of laughter or crying. They can be very distressing to watch and very distressing for a person who's doing them, because it feels like a real loss of emotional control. And for a caregiver, it can seem like somebody's really unhappy, when in reality, it's more about regulation of expression of emotion. This occurs in other neurologic disorders as well. It can occur in various dementias. It can occur in ALS, but it can be prominent also in Parkinson's and especially Parkinson's plus syndromes. There's a brain mechanism for it, which has to do with taking the brakes off of that visceral emotional experience so that it, in essence, a person wears their heart on their sleeve. They may not deeply experience the emotions that they're expressing. Now, we're very fortunate that we have specific medications that can help reestablish emotional control, and they often are effective. First, we usually try those antidepressants, the serotonergic antidepressants that I've already talked about, because oftentimes they're helpful, and practically speaking, they're easier to get and less expensive. There are less barriers to overcome in terms of acquiring the medicine and affording it. However, for some individuals, it's very helpful to use a special medicine that's FDA approved specifically for the treatment of pseudobulbar affect, studied primarily in ALS or MS, but used predominantly in people with Parkinson's and Alzheimer's disease, studies have shown. This is a medicine that combines quinidine, a heart medicine, with dextromethorphan, which you may know as a cough suppressant. These medicines together go to the brain. The quinidine reduces the body's destruction of the dextromethorphan, and the dextromethorphan in the brain helps reestablish control over emotional expression. It works at the glutamate system, the NMDA receptor, and the sigma-1 receptors. Further research has been advocated for use in Parkinson's, but it's already used quite frequently and very effective for some people. Next, I'm going to talk about sleep. And sleep is another area that we often see disturbed in people with Parkinson's, even way before, as you heard, even way before the motor symptoms. Many people can have REM behavior disorder, which is disinhibited motor movements during dreaming sleep, even for years before developing Parkinson's or Lewy body disease. Normal sleep in average young adults is 7.5 hours per night, or we often talk about 8 hours of sleep, and we cycle through the non-REM and REM phases of sleep alternately about 5 times per night. So people have about 5 dreaming episodes per night. The dreaming part of sleep, rapid eye movement or REM sleep, dominates the last third of sleep, but it's about a quarter of total sleep time. Okay. In older adults, we see routinely some deterioration of the architecture of sleep. There's greater variability as we get older in our sleep quality. Sleep is briefer. People wake up more, maybe to go to the bathroom or because of pain. There's decreased slow wave or very restful sleep, increased wakefulness, and the consequence of that is more tiredness during the day. So normally, as we get older, sleep is not as good, but in people with Parkinson's, sleep can be even worse. One study says that 98% of people with Parkinson's have sleep problems, but the range that's generally quoted is from 2/3 to most people with Parkinson's have increased sleep latency, which means longer time falling asleep, greater fragmentation, decreased efficiency, which means more wakeful time during the night, and decreased total sleep time. And again, although there may be psychological factors, there is an intrinsic part of the disease itself that interferes with sleep. In addition, we may want to look at, when we're trying to diagnose a sleep problem, things like medicines that a person's taking, the timing of the medicines, the side effects, of course, pain, sleep habits like too much coffee or exercise right before bedtime, or like some of my patients do, watching Law and Order or CSI right before going to bed and having a nightmare. Depression or anxiety interfere with sleep, so we want to look at that. Or primary sleep disorders, including REM behavior disorder or others like sleep apnea, which can occur with obesity, which, as you heard already today, can be a complication. The sleep disorders in Parkinson's disease include the dysomnias, which are sleeping too little or too much. Also the parasomnias, which are behaviors that occur during sleep that shouldn't occur during sleep. The most prominent of these being REM sleep disorder. And then also the sleep disorders that are related to psychiatric disorders like anxiety, depression, cognitive impairment, or psychotic disorders. As with anxiety and many other symptoms, there's a special tool for assessing sleep in Parkinson's called the Parkinsons Disease Sleep Scale, and that's available with targeted questions. In addition, some people with Parkinson's disease or Parkinsonism may be appropriate candidates for laboratory studies or polysomnography, a sleep study in a sleep lab or at home. The history includes looking at these medications, medical causes, and psychiatric causes. And then when we think about treatment, again, we first look at the non-pharmacologic approaches. Sleep hygiene is the general description for sleep behaviors that make it harder or easier to sleep, like do you have a comfortable place to sleep, your bed is comfortable to lie in, your mattress is not too lumpy, your pillow is good, your bedtime is appropriate, you don't have distractions, the temperature is good, you don't have a sleep partner who snores all night. All of these things can affect sleep. Then we think about medications, and there are medications that can be used to help with sleep. There are the non-benzodiazepine sleep pills like Zolpidem and its relatives. There are the benzodiazepines. There's sedating antidepressants like mirtazapine or trazodone. And then there's melatonin, which occupies a very special place among the sleeping aids because, as you heard already, it's one of the few over-the-counter supplements that really has a role in treating Parkinson's. It can improve sleep onset and reduce REM behavior disorder, and it doesn't generally have any kind of hangover during the day. We also think about, when we're looking at insomnia, we think about adjusting other medicines, treating urinary problems that might occur that wake people up because they have to go to the bathroom, or treating related conditions like restless leg syndrome that might be waking people up or making their sleep uncomfortable. Now, because Parkinson's may be occurring in older and overweight people sometimes, we also think about sleep-related breathing disorders like sleep apnea, and may recommend weight loss or even CPAP, continuous positive airway pressure, to help with breathing during sleep. Next, we might adjust the use of the dopamine medicines or stimulants or modafinil or caffeine. Maybe they're being given too much or too close to bedtime. When there are secondary disorders that are affecting sleep, we also look at those. Now, psychiatrists always get to talk about sex, so I'm going to talk about sex next. It's an important part of life, and like so many other important parts of life, it's affected by Parkinson's disease. Many people with Parkinson's, and in this study you can see like 2/3, men a little bit more than women, but women as well, and especially with the issue of sexual dissatisfaction, people with Parkinson's can experience changes in their sexual enjoyment, behavior, activity. We usually talk about sex in 3 phases. The first would be interest, the second would be arousal, and the third would be orgasm. And all of them can be affected by Parkinson's and by the medicines. It's important for a clinician to ask about these, and for a person with Parkinson's disease to bring this up. This is one of those things that I mentioned at the beginning. You could look at it as another thing that can go wrong, or you can look at it as another thing that we can make right if it's talked about. There are intrinsic aspects of Parkinson's disease that affect sexual function in all its phases. And in addition, since we're all people who care about how we look and how people see us, people's self-esteem and their feeling of being sexy can be affected by disease, many diseases, but in Parkinson's, if people feel like they're not as expressive or can't move as fast, or might be drooling or having other side effects of medicines or the disease, they might be less attractive. And so cognitive behavior therapy is one of the ways that we can help with that. When sex is affected, relationships can show that stress. Depression can also occur. So again, bring it up, talk with your doctor about it. Doctor should ask you about, or nurse should ask you about your sex life and your relationship. And it may be appropriate also to assess endocrine function, since hormones can have effects on sexual function as well, and urologic function as well. There are things that can be done to help each of these 3 phases of sexual functioning. But the first thing is bring it up. Now, I work in the Swank Center for Memory Care and Geriatric Consultation, which is Delaware's largest, most comprehensive memory disorder clinic. And we see patients and collaborate with Dr. Martello and his team in the Parkinson's clinic. We see patients who are developing cognitive effects related to Parkinson's disease. In Parkinson's, because the brain is affected in a variety of ways, we can see changes that impact on memory and other cognitive functions. Mild cognitive impairment is a condition in which people continue to live pretty normally, but they notice, and people around them notice, that their minds may not be as quick or retentive as they had been. And that affects some 1/4 of people in the early stage of Parkinson's disease, but it need not be a deterrent to a pretty normal life. On the other hand, up to 80% in some studies of people with Parkinson's disease develop dementia after 20 years of the disease. And many studies talk about 30 or 40%. You heard Dr. Grill say 30%, I believe. if my memory is working properly. Cognitive changes can precede or follow the appearance of motor symptoms. When it precedes motor symptoms, we may be talking about Lewy body dementia. Executive function, visual spatial function, attention, and language skills can all be affected. And so when we look at somebody who has Parkinson's disease and also cognitive symptoms, we want to think about the disease, whether other factors are involved, and recognize that the etiology of the cognitive changes could be from these secondary factors or from the basic pathology of the disease, which involves loss of dopaminergic function in the substantia nigra, which can affect those frontal subcortical dopamine neurons, which help us with processing speed and executive function and mental control. We often are looking at the differential diagnosis between three related conditions, clinically related conditions: Parkinson's disease dementia, dementia with Lewy bodies, and Alzheimer's dementia. These are all relatively common conditions that affect cognition, and also movement can be affected. The symptoms that they share are the cognitive impairment, the loss of motivation, and sometimes the presence of psychotic symptoms like hallucinations or delusions. But we can also differentiate these conditions by looking at their clinical features. When we are thinking about Parkinson's dementia or Lewy body dementia, we may see the history of REM behavior disorder. The motor symptoms are present. The neuroimaging may be different. The sensitivity to antipsychotics is going to be a very important difference, because somebody with Parkinson's psychosis, which I'll talk about soon, can react very, very dangerously to the typical antipsychotics that are only mildly harmful to people with Alzheimer's disease. They're dangerous drugs for everybody, but sometimes necessary. However, in Parkinson's, the side effects can be quite severe with some of these medicines. I'll talk about the safer ones. How do we screen for dementia in Parkinson's? Well, the mini mental status examination will pick up about 98% of people with the cognitive changes related to Parkinson's, but it'll also pick up some false positives. In other words, we'll say that some people have cognitive impairment who really don't. Maybe they're educational issues, or they don't understand the questions, or we just made them very anxious by putting them on the spot and telling them, take away 7 from 100 and keep on going. That would make me nervous too. The mini mental status is a quick test, and then we have some that are longer and more specific. And then we may also do blood tests, neuroimaging, physical examination to get a complete differential diagnosis. We want to think about exacerbating factors like if there's a urinary tract or other infection, or dehydration or metabolic changes. We want to think about medicines which may be causing problems, like perhaps somebody's taking a sleeping pill or an anticholinergic medicine for bladder control that might be interfering with cognition. We can consider a cholinesterase inhibitor trial, and if I talked about any of the cholinesterase inhibitors other than rivastigmine, I'd be off-label, but all of them may be beneficial, and rivastigmine is actually FDA approved as a cholinesterase inhibitor for treatment of Parkinson's related dementia. For any improvement in the Alzheimer's disease cognitive scale that was used in the study of rivastigmine, the number needed to treat was 9, which means that if you treated 9 people, one person with Parkinson's got more better from taking this drug than they would have just by chance. And still more people than 1 in 9 got better, but we could attribute that improvement to the drug in 1 out of 9. That's not too bad for the medical treatments that we have. For moderate to marked improvement, the number needed to treat was 19, which just says that the dramatic improvement with the drug was less common. But the number needed to harm was 8, which means that you had to treat 8 people with the drug for 1 to have side effects bad enough to cause them to drop out, usually nausea or gastrointestinal symptoms. Donepezil is off-label, but also showed possible benefit. And this is just the graph in which you can see, perhaps I can even show you here, that placebo patients, people who took a medicine that's not active, are indicated by the lighter colored bars. And you can see that the distribution of responses shifts to the left towards more improvement in the people who are treated with medicine. On the other hand, the cholinesterase inhibitors, as we in the Swank Center and people who treat dementia know very well, these are drugs that do have side effects. And unfortunately, the gastrointestinal side effects are the most common ones. Now, next, let me move on to another psychiatric symptom that we often encounter in people with Parkinson's disease, maybe in up to 2/3, or it says here 60% of people with Parkinson's within 12 years of onset. And those are disturbances in reality sense. As a psychiatrist in training, my first exposure to Parkinson's was in talking with patients who were seeing things or hearing things that they shouldn't. Psychotic symptoms come in a variety of different forms. They can come in sensory disturbance, which are hallucinations, hearing or seeing things, or in beliefs that are false but very convincing and not explainable by a person's religious beliefs or political beliefs, for example. Hallucinations that are most common in Parkinson's are very elemental or basic hallucinations like flashes of light or color, or what we call passage hallucinations, where a little animal seems to be traveling through the corner of vision. But people can also see complex formed hallucinations, and this might occur more in dim surroundings where there's less visual stimulation from light. In contrast to some psychiatric disorders where these hallucinations are more acceptable, more accepted as real and frightening manifestations, people with Parkinson's may be quite aware that this is the brain or the eyes playing a trick on them. Auditory hallucinations occur less frequently, but they do occur as well in up to 10% of people with Parkinson's. And they can be non-frightening voices or sounds like hearing your name called, or hearing a sound of something happening that isn't really happening. But they can also be associated with visual hallucinations like hearing and seeing somebody who isn't there speak. Like the other mental symptoms that I've talked about today, there are intrinsic parts of Parkinson's disease and the medicines that cause psychotic symptoms. But even more than with some of the other symptoms, medications are often the cause because they activate the dopamine system, and the dopamine system is very tricky. If we have too little of it, we lose our interest and our pleasure. If we have too much of it, we can really experience things that are not there for other people, like hallucinations and delusions. But in addition, the disorder itself can cause some psychotic symptoms, and we know this because even before our current drug era, people did experience hallucinations and delusions with Parkinson's. And it has, again, like these other symptoms, been related to changes in the dopamine receptors and pathways in the midbrain. When a person is older, has more severe disease, more severe cognitive impairment, or sleep problems, they're more vulnerable to psychotic symptoms. And we assess these with a special symptom rating scale called the Parkinson's Psychosis Rating Scale, or other symptoms checklists that are useful in psychiatry or neurology. And we also evaluate the environment. For example, I can think of one of my patients who sometimes, as the lights were turned off at night, would see shadowy men descend on ropes from the ceiling. A nightlight may be enough to help with the environment and get rid of that kind of experience, which is an illusion or a hallucination. And then the metabolic and medical evaluation and the evaluation medications is important. Now, as with these other symptoms, psychosocial and environmental interventions are really important. If we can avoid using antipsychotic medicines, we're ahead of the game. But the antipsychotic medicines also can be beneficial for some people. We have to balance the effects on dopamine that might impinge on movement versus those that will help with psychosis. First, we might start by simplifying the medicines that are already being taken. For example, if there are unnecessary non-Parkinson's medicines like anticholinergics for urinary control, amantadine, selegiline, that may be part of the Parkinson's treatment, the dopaminergic agonist that might be part of Parkinson's. We may want to be adjusting these. Then when we're treating the psychotic symptoms with medicines targeted towards those, rivastigmine or the other cholinesterase inhibitors may be the medicines that we start with. And if we need to move to an antipsychotic medicine from that class of antipsychotics, it's best if we can avoid the dopamine blocking antipsychotics. The worst would be the high potency ones like haloperidol or its related strong relatives. Among the traditional group of antipsychotics, clozapine seems to be the most effective, with quetiapine being used often because it's relatively safe, although unfortunately less effective. And then there's the new medicine, those are off-label. The new medicine that's on-label from the FDA for Parkinson's psychosis is called pimavanserin, and it's what they call a serotonin 2A inverse agonist, which means it kind of tricks the drug receptors in a way that reduces psychotic symptoms even more than a dopamine blocking drug might do. Unfortunately, like all drugs, it has side effects. In this case, effects on the heart rhythm that prolong the QTC interval, peripheral swelling, nausea, confusion. But this is a medicine that is specifically approved for this condition, has some evidence supporting its benefits. It may require some insurance hurdles to get it, but is generally approved for this purpose, so it can be obtained. Now, next I want to talk about behavioral side effects of the Parkinson's medications, because as I mentioned, these drugs are miracles. They help so many people, but they also can have side effects, which in their own right are like a separate problem. The dopamine-acting medicines can dysregulate impulse control. And so those of you familiar with Parkinson's know that sometimes we see people start to gamble, even seriously gamble, when that hasn't really been a big problem for them before. Or they might do compulsive shopping, or out of control eating, or sexual behavior that's inappropriate for them, or punding, which is a kind of repetitive, not very purposeful movements, like putting things together, taking them apart. These side effects are seen in about 14% of patients who take these medicines, and they can be very distressing for caregivers, of course, and also dangerous, for example, if somebody runs up credit card debt at the casino. And these have to be recognized. So I'm mentioning it so that, like with sexual function, it's something that you know is part of Parkinson's and bring up with your treatment team. They can often be treated by substituting or replacing medicines, although the behaviors sometimes can persist. This brings me to the general end of my presentation, and I'll conclude by summarizing what I've said, which is that these non-motor symptoms in Parkinson's are very important for the quality of life of a person with Parkinson's and for their caregivers. They have very important effects on caregiver quality of life and yet are often unrecognized or unlinked to the Parkinson's and therefore often untreated. But tools are available for specific assessment and specific treatment approaches are available. We need to know more about these conditions because they really affect quality of life, as I've said. And so further research is important. But I hope today what I've done is encourage you to think these are extra parts of Parkinson's that can be addressed separately to improve quality of life. There are ways to talk about them and to treat them. And so I encourage you to do that. Thanks for listening to me here.
Thank you, Dr. Ellison. That was a great talk. Yeah, I mean, we see so often that a lot of times the non-motor symptoms are more bothersome than the motor symptoms. And so, I would just encourage, the patients and caregivers, always bring someone with you to your appointments. Bring these topics up to your doctors. A lot of times, unfortunately, we don't do a great job of screening for these things a lot of times, even though, as Dr. Ellison pointed out, there are screening tools. A lot of times we just don't have enough time to get to them, or we don't have the resources. And so just, a lot of times, as Dr. Grill pointed out, coming to your appointment ready on what to talk about, what is going on. For those who see me, I tend to give out a little survey before your visit that covers a lot of these things. But again, just super important to mention to your doctor. So, on that note, I do want to introduce Sarah Hinkle, as I did before. So Sarah is our nurse practitioner for Parkinson's disease. She graduated with her nurse practitioner degree at Wilmington University 5 years ago. She first started as a hospitalist at Christiana, and then for the past 3 years, she's been working with me. And like I said before, there's not enough good things I can say about her. She's been a great addition to the team. She is the one that's going to help you when things start becoming more advanced, that you need to be seen more often. Lots of people, whoever has seen her, I can guarantee you, love seeing her. Like I said before, sometimes love seeing her over me at times. And so she's a great asset, and she's going to speak, especially with her unique knowledge on, being a hospitalist and that experience. So she's going to talk about the special considerations for the hospital patient. So I will leave it up to you, Sarah. And just as one more thing, we'll have a lunch break afterwards. And so I will come back on after Sarah's done to talk about that. And take it away, Sarah.
Thank you so much, Dr. Martello, for the very kind words. Can you hear me and see everything okay? All right, thank you. So I appreciate everybody being here this morning. I wanted to talk today a little bit about the special considerations for the hospitalized patient. I will go a little bit back into my history. I know that Dr. Martello did a great job talking about where I've been. I started actually here at Christiana 13 years ago. I was a bedside nurse in the medical ICU. I absolutely loved the job in the ICU. Gave me the chance to take care of really complex patients and help the patient and their family through a very difficult time. I went back for my master's as a nurse practitioner because I wanted more say in our patients' care. So right out of school as a nurse practitioner, I started with Christiana Care Hospitalist Partner. For anyone who doesn't know what a hospitalist is, when you are admitted to the hospital, it's the team that's actually in charge of your medical care. They're the ones who consult neurology, cardiology, and they help to make sure everything that needs to take place during your hospitalization occurs. In 2017 is actually when I transitioned to Christiana Care Neurology Specialist, and this is where I was lucky enough to start with Dr. Martello and started my training with Parkinson's. So I feel like, given my bedside nursing history and then working as a nurse practitioner in the hospital and now a nurse practitioner for Parkinson's patients, it gives me the unique perspective of what a Parkinson's patient truly needs in the hospital. So Parkinson's patients are about 30% more likely to be hospitalized than the general population, and they have a 50% higher rate of rehospitalization. So basically, rehospitalization is being admitted back to the hospital within 30 days of your initial admission. So in addition to having higher rates of the hospitalization, there's more complications for our Parkinson's patient. This graph here is just a small piece of the puzzle. It talks about the administration of the levodopa. The blue part here is getting the medication within 1 hour. The red part is within 2 hours of the time. The green part is within 3 hours, and then 1/3 of the patients didn't get it at all. And that's just one medication, one piece of the puzzle. The Parkinson's patients with all these complications tend to stay about 2 weeks longer than the general population, which definitely can increase the risk of deterioration while they're at the hospital. So why is there such an increase in complications? So as we've talked about previously during this presentation, in the outpatient setting, normally Parkinson's patients are followed by either a neurologist or a movement disorder specialist. When you're admitted to the hospital, you're followed by a non-specialist provider. So the hospitalists, while they're very good at taking care of hospital patients, don't have the same knowledge as what a movement disorder specialist would for a Parkinson's patient. In addition to that, it's a frequent changing team. So a provider might be on for 3 or 4 days, and then they go off and you get a whole new provider. So they are intimate with your care because it's a different person every couple days. And as for nursing, I mean, you can have up to 3 or 4 nurses per day. So just when one's getting used to your symptoms, they may go off shift and you have another. The hospital system as a whole is not actually designed very well for Parkinson's patient. And we'll kind of go into this in more detail through these slides, but there's issues when it comes to things like electronic medical records, the nursing demand. A nurse could have 8 patients, so you're not getting that one-on-one care from nursing, and you're not getting one-on-one care to get out of bed and ambulate and walk the way you normally do. So here are some things I want to discuss today. So the first thing I want to talk about is medication errors, and I often talk about this because it's the #1 error for hospitalization, so I think it's really important. Then we'll talk a little bit about falls. We'll talk a little bit about the psychiatric considerations when it comes to hospitalization. I'll talk about infection, as it can be the cause of the hospitalization, but can also be a complicating factor that makes your hospitalization longer. And I'll just briefly touch on some recommendations for patients with DBS, which is deep brain stimulation, and then the duopa pump. And then we'll end with some follow-up care. So I put together this case study to help represent some of the medication challenges for a hospitalized patient. So Mr. Jones, he's our 66-year-old male. He's had Parkinson's disease for about the past 10 years. He's followed by a movement disorder specialist and normally very well controlled with Rytary. For those of you who don't know what Rytary is, it's a longer acting carbidopa-levodopa. He takes 2 tablets about a half hour before each meal. So for him, that's 7 a.m., 12 p.m., and then 5 p.m. So after breakfast one morning, his wife noticed he was starting to get confused. He had some difficulty walking, so she called the ambulance. They brought him in as a stroke workup. Now, luckily for him, his stroke workup was negative, and they did admit him eventually for urinary tract infection. Because he was admitted for a stroke workup, he was made NPO, which is fancy speak for nothing by mouth. And the reason that when you're a stroke alert, when you're doing stroke workup, that you're nothing by mouth is #1, if they do want to go in and do a surgical procedure, they don't want anything in your stomach. They don't want you to risk aspirating or having it go in your lungs. And the second thing is a stroke can actually interfere with your swallowing muscles. So in the beginning, they don't want you to do any swallowing. So he missed both his 12 p.m. dose of his medication and then his 5 p.m. dose. So then the hospitalist came to admit him to the hospital and realized that Rytary, being a newer medication and a specialty medication, wasn't on formulary. So he actually prescribed him the immediate release carbidopa-levodopa, and he entered the order for 3 times a day. Now, earlier I mentioned that our electronic medical system is not really set up for Parkinson's patients. And when you put something in for 3 times a day, it defaulted it for this gentleman to midnight, 8 a.m., and 4 p.m. So the combination of the missed medications, the timing changes, and having carbidopa-levodopa immediate release rather than the Rytary, he started to become very confused. He became agitated. The overnight covering physician actually gave him a dose of Haldol, which Dr. Ellison actually mentioned earlier is not a good medication for our Parkinson's patient because it's actually a dopamine blocker, and so his symptoms worsened. So I like that study because I think it points out a lot of the problems that happen in the hospital. Missed medications is one of the first ones I want to talk about. So any prolonged admission to the emergency department can cause missed medications. If you're made nothing by mouth initially, often medications can be missed, and a medication not being available. Timing errors is another huge one. So we talked about the electronic medical record system. It's a great system, helps keep medications organized. You know, the nurse will scan the patient, scan the medication, you get the right medication. The problem with it is that the timing for it is typically standardized timing. So it has to individually be placed in by the hospitals for the correct time to get it on the schedule that Mr. Jones would have been taking the medication. Some other issues with timing errors is that normally a nurse has multiple patients, can have up to 8 patients. If every patient has medication due at 8 a.m., there is no physical way that all 8 patients are going to get their 8 a.m. medications at exactly 8 a.m. And then there's some other medications that are actually contraindicated, which is just a medication that shouldn't be given to a Parkinson's patient. And I'll go into this a little further in this next slide. So I apologize, the typing on this one is a little small. I actually got this from the Parkinson's Foundation website. I put the website there for you. They have a Parkinson's hospital kit that you can request. They can either mail it to your house or you can download it and print it off. And this is one of the documents from it. So if you want this document for yourself, it's meant to bring into the hospital to help with your stay. And these are some of the medications that are really contraindicated and will make the Parkinson's patient worse during their stay. So the first group of medications are the antipsychotics. Most typical and atypical antipsychotics actually can worsen Parkinson's. The ones that are approved for Parkinson's are the Nuplazid, Seroquel, and Clozaril. Now, in the hospitalization, you'll typically see Seroquel used most often. It's easiest to give, it works quickly, it's available. So that's typically one you'll see given if you're having issues with new psychosis at the hospital. Pain medications, while most of them are safe, we do say that, higher doses of narcotics can worsen confusion, psychosis, and constipation, which are all problems for Parkinson's patients. The next category is anesthesia. I don't think you need to memorize exactly what anesthesia is safe for you. The key to this is to talk to the anesthesiologist, let them know you have Parkinson's, let them know what medications you're on. They can pick the safest medication for you, and we can ask them to use the lowest dose possible so that you have the least amount of side effects. This next category here is actually more frequently used, and it's the GI medications and medications for nausea. So often in the hospital, nausea comes along with it. New medications, new infection, people don't feel well. Medications like Phenergan, Reglan, Compazine can all worsen. So we do recommend something like Zofran, which is easily available. And I often will tell the staff at the hospital that that's a good medication for a patient if they're having some GI symptoms. What's the consequences of these medication errors? So worsening motor function, this one should be easy to recognize. So we saw that Mr. Jones is now getting his medications at midnight, so he's probably sleeping through the effects of the first dose. His next dose is 8 o'clock, and then he's not getting another dose until 4 o'clock. So as the medication wears off, balance is going to worsen, freeze of gait can worsen, and that can actually cause things like falls and injury. Also, with messing with the medication timing, worsens things like delirium, confusion, psychosis can worsen. All of these will prolong the hospital stay and actually could make it necessary for rehab after the hospital, so it prolongs the time to get you home. All right. So now that I've officially scared everybody with hospitalization, what can we do to help? So I tell everyone that you need to have a current list of your medications. On it, you should have what medication you take, what dose, and exactly what time you take the medicine. A lot of patients will even put in the notes like who prescribes it or what it's for. And on the top of this, especially in times such as COVID, you should have your care partner's name and contact information in case there's any questions that comes along with it, that the providers can call them. I tell people actually bring multiple copies of their medication list. And the reason I tell people this is when I was a hospitalist, I would go to the emergency room and I would go to admit a patient and I'd ask for their medications. And they said, oh, I had a list, but I gave it to the paramedic on the ambulance. And that happens all the time because the paramedic's trying to treat you. But often that paper will end up in the paramedic's pocket and they leave and we don't have the list. The same can happen if they provide it to the emergency room personnel and it's not the admitting staff. So bring multiple copies of the list. If you can, I often tell people, bring your medications with you. If it's a specialty medication, have it in its original bottle and make sure it's not past expiration date. What we can do is we can order it as a non-formulary. So if we want to continue medication, but we don't have it, we can use yours from home. I know at Christiana Hospital, I know we had to send the bottle down to pharmacy first for them to validate that it was the right medication, which is why I say send it in the original bottle, and then they can help give that to you while you're at the hospital. So another important thing is just to talk with the staff about how important the timing is. When that person's admitting, you say, I know that 3 times a day defaults to a different time, but these are the times I need the medication so I don't have a fall, so I can swallow my food. often the staff is willing to make all these exceptions. They just don't know until you tell them. And then if you're having trouble or you feel like you just need more assistance, you can ask for a neurology consult. Even if you're admitted for a non-neurologic reason, they can come and help manage the Parkinson's medications. And often that's a really good way to get the medication timing the way you need it to be done. All right, I'm going to move a little bit into the perioperative area. We had mentioned the anesthesia earlier, but the time after hospitalization for Parkinson's patient is actually really, it could be more dangerous than for the general population. One of the studies showed that the risk for falls is 18% for a Parkinson's patient, and the baseline for the general population is 4%. So that's a pretty big increase. In addition, we know that our patients have issues with urinary retention, then that can cause a urinary tract infection. They can have issues with confusion, they have worsening falls, they have concerns for pneumonia. So it's really important to talk to the anesthesiologist and the surgeon about your Parkinson's. Like I said earlier, tell them what medications you take. They'll pick the right medication and request the least amount of anesthesia use possible. This way you come out of it with less adverse effects. So we know that our Parkinson's patients do take longer to recover, and they tend to need more supervision after anesthesia. A lot of times, if a patient's scheduled for what would be considered an outpatient procedure, I'll ask them to talk to their surgeons to see if it could be done inpatient. Sometimes having that extra night at the hospital with the right resources can make it just much safer instead of the family at home worrying about the increased risk of falls and the increased risk of hallucinations. All right, well, let's go into falls a little bit here. So fall is a 4-letter word in any hospital system. There are many things put in place to help prevent falls. Our Parkinson's patients are at a specific higher risk for falls. And there's a couple reasons. So one of them is they just have worse balance and worse freezing of gait, especially if medications get changed in the hospital. Another reason that can cause falls is called neurogenic orthostatic hypotension. It's a really big way of saying when you stand up, your blood pressure drops, and this puts you at a high risk for falls. Prolonged bed rest, not enough movement, all that makes Parkinson's patients higher risk, and then the confusion can also worsen it. So how do we prevent the falls? So one of the #1 things I tell people is to request physical and occupational therapy as early in the admission as possible. The people that work at these departments are wonderful, and they'll help with balance and safety, and they'll keep you moving throughout the admission so you're not laying in the bed the whole time. The second bullet I have here, most people don't like as much. I tell people that you really need to use the call bell. Nobody likes to lose their independence. Nobody likes to wait if they have to use the bathroom, but it's really important. With the extra wires and just on extra medication, you're just at a higher risk for fall. So use that call button. Use the non-skid socks they provide you. If you're working with physical therapy, they can often provide you the walker in the room just to get to and from the bathroom, to walk around. It's important that you sleep when you're at the hospital, and I'll go into this a little bit further in the next couple slides, but if you are sleep deprived, you're going to be at a worse risk for fall. And then staying hydrated. I talked earlier about the blood pressure dropping. #1 way to prevent that is lots of water. Keep drinking water. I know it's not always accessible. Ask the nurse for water, the aides, whoever can help you, but you want to stay hydrated during your admission. And then the last piece of the puzzle is actually something that family and friends can help with. I know when you're allowed visitors during a non-COVID time, family and friends are always looking for something to help you with. They want to, be useful. Helping supervise walking is actually a really useful thing that a family member can help with, as long as, the nurses are comfortable with your ability to walk. All right. Let's pivot a little bit into the psychiatric considerations. Dr. Ellison did a great job talking about, of course, the psychiatric considerations of Parkinson. I'm going to talk a little bit more about what goes on in the hospital. So there's something called delirium, and this is an altered state of consciousness, loss of awareness of the environment, more confusion. It comes on quickly, and it's more temporary. It's not like dementia and Alzheimer's that's going to continue to worsen. This is actually caused by the stress of the hospital. It's really common. In the ICU, up to 80% of the patients can have delirium, which is a huge number. It's caused by the stress of the infection from being in the hospital. If you're there for surgery, it's caused by the stress from the surgery. Vital signs that fluctuate can cause it. So if you have spike of temperature and then it comes down, or if your heart rate's increasing or decreasing, the blood pressure we talked about, all of that's going to cause the vital signs to fluctuate and can worsen this delirium. And then an altered environment. You're not at home, you don't recognize everything. That can actually worsen the delirium, and you can start to see things just because you're not familiar with your surroundings. Altered sleep is a big one. We know that hospitals are not a great place to sleep. There's lots of noise. There's always lots of action, but we need to get you on a good day-night cycle to help prevent this delirium. And then new medications can do it. Whether it's a medication like an antibiotic or a medication for pain, they can actually worsen all of these delusions. Now that's true for all hospital patients, but Parkinson's patients are no exception. In fact, it can actually be worse for Parkinson's patients given the underlying confusion or the underlying hallucinations, delusions that already exist. This is just going to confound it and make everything worse. How do we prevent it? I always tell people, I know that you want to rest at the hospital, but during the day, the curtains should be open. You want natural sunlight in. You want to keep the lights on. If you're able to get out of bed, that's a good thing to do. So getting out of bed for meals. Again, if loved ones are there and they can be there for lunch, sitting next to them while they're in a chair for a meal, talking to them, keeping them aware of their environment is really helpful. And then drinking lots of fluid during the day, keeping yourself hydrated. At night, we ask close the curtains, lower the lights, limit visitors, although some can help with comfort. We don't want 5 or 6 people coming in when you should be resting at night. And then if we need it, we talked about earlier, melatonin is a great supplement that can help with sleep and help keep you on a good day-night cycle. So in addition to the day-night cycle, I tell people you want to make sure that you're not retaining urine. That can be difficult, so setting a bathroom schedule every 3 hours you get up and try to use the bathroom, because the retained urine can actually make all of the psychiatric issues worse. And you want to help prevent constipation. The hospitals are pretty good about this. They have protocols in place, but if you know that you take Colace every day, make sure that they know that, so that they can put you back on it and prevent the constipation. Now, we mentioned earlier that there are 3 medications that can be used for psychosis. So if all of these interventions don't work and there's still issues with psychosis, they can use a medical intervention. One of the ones that started more frequently at the hospital is Seroquel. The problem with the Seroquel is that it's actually only available orally. So if you or your loved one's at the hospital and you're getting more and more agitated and we can't convince you to take the oral one, we sometimes will use either an IV or an IM, so through your IV or into the muscle to help calm you down and keep you safe. And sometimes the staff will use like a low-dose benzodiazepine or a Zyprexa. So even though they're not our favorite medications, the risk of injury is so much worse that we are okay with those. The Nuplazid and the Clozaril are not often available as much at the hospital, so these would be ones that if you're on at home, bring the bottle, let them know you're on it, and they can decide if it's safe for you to continue this at the hospital. All right. I'm going to go a little bit into infections now. Now, infections could actually be the cause of the hospitalization, or it could actually be what keeps you in the hospital much longer than you want to stay there because you acquire an infection while you're there. So there's 3 common ones I was going to talk about today. The first one is aspiration pneumonia, and then I'll go into urinary tract infections and then pressure ulcers. The key to all of these is going to be prevention. All right, so I like this picture for aspiration pneumonia. Basically, there's 2 pipes. One of them is the trachea, that's where the air goes to get to your lungs, and the other one is the esophagus, where the food goes down to get to your stomach. So when someone's gagging and they say it goes down the wrong pipe, these are the pipes we're actually talking about. So the goal is for, of course, the food to stay in the esophagus and not go into the lungs. When it goes into the lungs, that's when it can cause a pneumonia. Bacteria can grow around it. Parkinson's patients are at an increased risk compared to the general population for aspiration pneumonia for a couple of reasons. We know that Parkinson's affects the muscles. So the muscles in the mouth and the muscles in the esophagus are all affected with Parkinson's. And then they also have, thicker saliva or extra saliva that can cause issues with swallowing. In general, if a patient's complaining to me that they're having more trouble swallowing liquids, it's more related to Parkinson's. If they're complaining about more issues swallowing solids, it tends to more be related to just as the aging population and the changes in the esophagus. What can we do to prevent it? So the goal is to always be sitting up nice and straight and tall when you're eating. I know that when you're in the bed in the hospital, they kind of prop the head of the bed up and they want you to eat breakfast or lunch. And if possible, I encourage you to get out into that chair, sit up straight at the table, and there's just less of a risk of the aspiration. And I'm sure that our wonderful speech therapist later on will talk to you more about this, but I often tell people if you're having trouble swallowing, a chin tuck, I'm not sure, when you swallow can help prevent it from going down the wrong pipe. If you know at the beginning of the admission that your loved one needs a special diet, whether it be a thickened liquid or a pureed food, let the staff know. Make sure they know that they're on a special diet. The same is true if they have trouble swallowing pills. A lot of patients will have take their pills crushed up in applesauce. Let the staff know this is something we can help facilitate while you're there. If you've never had these choking issues before, but you're noticing them at the hospital, that's the time to request the speech consultation. Have the therapist come in and assess you and give you the right information and the right diet to keep you safe. The next infection we're going to talk about is urinary tract infections. These are really common in Parkinson's patients, and sometimes they're harder to actually pick up. We often think of a urinary tract infection as pain and urgency. A lot of our patients, as they get older, they just don't have the same symptoms, and it actually presents as confusion, just like Mr. Jones did earlier in our case study. So part of the issue is the brain sends signals to the bladder to help it empty, and these signals can be altered with Parkinson's, and you're just not emptying all the way. If the urine's being retained in the bladder, it can grow bacteria and then cause an infection. So I know it sounds counterintuitive because people say they have to go so frequently as it is, but we encourage hydration. You want to clean out the bladder, you want to keep everything flowing, so lots and lots of water. I usually tell patients drink lots and lots of water in the beginning of the day so it doesn't keep you up at night. And then the urination schedule we talked about earlier. You know, every couple hours we need you to walk over to the bathroom and try to go, even if you don't feel the urge. We want to prevent that infection. All right. The next infection I'm talking about here is actually pressure ulcers. So a pressure ulcer is caused by a bony prominence in the body, leans down on a surface, and it leans there long enough that actually causes a sore. And that sore can be painful and can become infected. So in this picture, it kind of shows you that sores can be in different locations. So the picture in the wheelchair right here, the sacrum is actually the spot pushing on the seat for a long period of time. So that one's at risk when you're in the sitting position. And then in this laying position here, not only is the sacrum at risk, but you can see that the heels leaning on the bed are at risk, the elbows, the scapula, and even the back of the head. So things that make it worse are decreased movement, which we know Parkinson's patients have, increased moisture, so sweating, which is another sign of Parkinson's disease, and incontinence, keeping the moisture in, are all risk factors for this. And then the decreased nutrition, whether it be that you're much thinner and the bones are closer to the surface, or just lower protein. So we encourage good hydration, good meals, but getting out of bed whenever possible, moving your position. When I was in the ICU, if a patient couldn't move themselves, every 2 hours, we would turn the patient to the other side, stack a bunch of pillows under them, and prevent those bones from pushing on the bed. And that's often something that family members can help with too. If you could prop up the elbows on pillows, maybe suspend the heels so they're not leaning on the bed, those are good ways to help prevent this. And then, like we mentioned earlier, you want to stay dry, so a bathroom schedule can be helpful. All right. So I'm going to pivot a little bit here and talk about some specific devices for Parkinson's disease. Dr. Martello had mentioned this earlier, deep brain stimulation. So this is a device that's implanted by our neurosurgeon, and it helps with the symptoms of Parkinson's disease. So the key to this is I tell them you should always have a contact number for the company, because you want to make sure that your device is compatible with some of the things that we're doing here. So an MRI should not be completed unless it's completed at a hospital that's used to doing it with DBS and you have a compatible device. I will tell you, Christiana Care doesn't actually do these MRIs. So if you were at Christiana Care, we wouldn't want you to get an MRI with this device. You want to talk to the movement disorder specialist. Sometimes they turn off the devices before things like EKGs, the EEGs to look for seizures, or even a procedure, we can turn the device off. This is a Duopa pump. So basically what it is it's liquid carbidopa-levodopa in this cartridge, and it goes through this tube here and it goes directly into the intestines where it's best absorbed. So patients typically are very good at working their own pumps, but when you go into the hospital, it's a whole different ballgame. I tell people that you don't want to expose the pump itself to things like X-ray, ultrasounds, MRIs, EKGs. So you might have to remove it for that. If you're not sure if it's safe to do a procedure, the Duo Connect, which is a company, has a number that you can call and that you can talk to somebody about it. Can I have this procedure done? If you are unsure, the safest thing to do is actually to disconnect the pump. I will say if your pump is disconnected for more than 2 hours, you will need an oral carbidopa-levodopa to help supplement what you're not getting through your actual pump. All right, so post-discharge. So there's a couple things to worry about when you're leaving the hospital. The first and foremost is safety. Is it safe for you to go home? People who are at the hospital for 2 or more weeks often become physically declined, and they sometimes need to go to inpatient physical therapy to help build strength back. And I know people just want to go home, but if the safest place is truly to go to the inpatient physical therapy, I do encourage it. If you have some help at home and you aren't debilitated enough to need inpatient physical therapy, we can organize things like home physical therapy and home nursing to make sure that you're safe the first couple days at the hospital. You know, we don't want you to be one of those statistics for readmission. We don't want you coming back within 30 days. The next big concern with discharge is actually medication. So typically when you leave the hospital, there are discharge instructions, and it tells you which medications to continue and which ones to stop. And they usually give you this when you leave. Now, it does become more complicated if you go to a rehab facility first. Typically, that piece of paper will go to the rehab facility, and then when you leave there, they'll give you another piece of paper with the medications to continue. I find when you have multiple handoffs like this, that's the biggest chance for error. My biggest recommendation is to call your movement disorder specialist. Go over what medications you're on, which ones they told you to stop, which ones they told you to continue. What is your plan of care going forward? You know, we don't want you to just be, oh, well, they didn't continue this one, and I'm not sure if they stopped it because it wasn't on formulary or because it's dangerous for me. I never want you playing that guessing game. I want you to call your movement disorder specialist, discuss the plan, get an appointment if needed, so we can make sure you're on a safe regimen. So I thank everybody for their attention today. I never hope a hospitalization on anybody, but if by any means you find yourself in a hospital, I hope that some of this information was helpful. Thank you so much.
Thank you, Sarah. That was a great presentation. Yeah, I mean, one of the tasks of the Delaware Parkinson's Task Force is going to be focusing on trying to make hospitalization safer for Parkinson's patients, since we know the numbers of risk is so high. I mean, you know, obviously hospitals have, you know, a use to them, right? There's a purpose and there's a point to go to the hospital. But having said that, hospitals can also be dangerous for Parkinson's patients. And so we definitely want to make them safer. And so we're going to work on that. Now, we are approaching the lunch hour. I just wanted to make a few announcements. First, you don't need to necessarily leave or close out the presentation. It's going to be cycling through the slides of our sponsors. It's going to be playing music. No one can see you, no one can hear you, so you can just leave it up for the hour. We will be back on around 12:55 for me to introduce the next talk. Get up, stand up. The one thing I forgot to mention was everyone should be getting up, stretching, doing a little exercise, at least in between talks throughout the day. You want to keep active, right? So I would just like to mention, and of course the slides will be up during the lunch hour, but I'd like to thank our presenting sponsors, which is Neurofitness Rehab and Abbott. I'd like to thank our exhibitor level sponsors, AbbVie, Accorda, Adamas, Amneal, Encompass Health, PAM Rehab, Synovian, Supernus, and UCB. And then finally, our vendor level sponsors of Medtronic and Pivot. So thank you. And again, we'll go into about an hour of lunch. Again, you can just keep all your windows open. You don't need to click anything. And we'll be back around 12:55. Thank you. All right, so we are back. I hope everyone enjoyed their lunch and got a stretch break, a walk break, whatever you need to keep moving, right? So our next presentation is from our Christiana Care Rehab Services group, representing speech therapy, occupational therapy, and physical therapy. Our speakers are Dale Gregor, speech pathologist. Dale is a board certified in swallowing and is LSVT and Speak Out certified. Laurie Scott, who's our occupational therapist representing today, is certified in LSVT Big and the interactive metronome. Cynthia Murphine, physical therapist, is also LSVT Big certified. These clinicians specialize in working with patients with neurological conditions, especially with Parkinson's. And today they will be talking about how movement and activity and therapy services can be helpful with Parkinson's. I've worked with all of them many times. I have no reservations for sending any of my Parkinson's patients to them. And I know if you've been working with them, you can definitely attest to the same. So I will let them take it away.
Thank you. Well, this is going to be a very interdisciplinary presentation. Speaking with my fellow occupational therapist and physical therapist, I'm Dale Gregory from Speech Pathology, and we thought that we just had a beautiful morning learning all this new information, and we sat a lot, we just had lunch, and we thought it'd be a great way to start this presentation by getting moving. So we're going to start with movement and voice, just to get our blood and our brains moving. We'd like to start with everybody standing and sitting if possible, and just raising your arms up and stretching. Stretch, 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 stretch. Reach to the ceiling, just to kind of move that body a little bit. We heard a lot about movement this morning. Perfect, perfect. Here, now we'd like you to open your arms up wide, really wide, like you're stretching to each side, moving those arms, nice big movements. And then you can give yourself a hug. It feels great. Whether you're sitting or standing, our next movement is going to be raising your legs up and down like you're marching, moving your arms. Let's get moving. Adding in some very intentional loud voicing. Let's everybody count. 1, 2, 3, 4, 5. Keep on going.
8, 9, 10.
Perfect. Woo, we've moved things around, we got things going. This is to help us get ready for the rest of the afternoon. So what I'd like to do now is, now that your brain's moving, your blood's moving, I'm going to move over and let Laurie Scott from Occupational Therapy talk about what is affected by Parkinson's.
All right, this is kind of a dance, everybody, so please bear with us. We're trying to maintain 6 feet. So now that we've gotten our blood moving and our blood is pumping, we're going to talk a little bit about how Parkinson's affects your everyday life. And as the other speakers have mentioned throughout their presentations, it affects pretty much every aspect. Muscles are affected, breathing is affected, swallowing is affected. So, you know, every bit of movement, from your ability to walk, to move around steadily and with speed, to be able to cross the street if you're out with family and walk around the grocery store, daily living tasks, things like getting dressed, getting bathed, everything from those aspects to getting back to driving, playing with your kids and grandkids, those types of things. Your voice and your swallowing, as you've heard several times this morning, can also be affected, which can affect your ability to communicate with your family and friends. People may have talked to you and told you that your voice is quiet on the telephone, or they're having a hard time hearing you when you're in larger crowds. And swallowing is a big safety aspect as you get weaker, because you have to worry about things going down the wrong pipe, like Sarah had mentioned earlier. So using strategies and changing up your diet in order to help that. The other thing that's been alluded to before that we're going to talk about as well are thinking skills. So things like your ability to focus, your ability to understand, to remember, respond quickly to things that are said to you. So those types of things can also be affected. So let's talk about what helps. Movement matters. You know, you've heard people say that movement and exercise is what helps to keep the progression of the disease at bay. So it's incredibly important to keep moving. Keeping an active brain, so interacting with your family and friends, playing games on the computer, playing games with your family and friends. Exaggerating your voice and your movement when necessary. If you're speaking softly, making sure you speak louder, and it may sound like you're screaming, but other people may just be able to hear you. Healthy eating and socializing. We've already talked about the effects of the Mediterranean diet and how that helps with Parkinson's disease. Socialization, as we talked about before, and living with intention. Everything that you do, making sure that you do it with a degree of intention. When you're walking, walking larger. When you're talking, talking louder. And so that makes a big difference with the way that you are able to present yourself to the world and interact with the environment around you. So now I'm going to turn it over to Cynthia. She is one of our physical therapists, and she is going to talk to you about some risk factors.
Hi, I'm Cynthia. I'm a physical therapist, and I'm going to talk about the risk factors and precautions that you need to be aware of with Parkinson's disease. Now, we often see a fall risk, and that's because of poor balance, because you're shuffling or freezing, and that affects safety. There's also blood pressure changes, particularly orthostatic hypotension, and that's when your blood pressure drops when you change position, whether from sitting to standing, or even when you're bending down, and you can get lightheaded and sometimes even black out. There's sleep hygiene, and if you can't sleep well, that affects your fatigue, and that just makes daily movement so much harder. Not taking care of oneself, lacking the motivation to do so, can affect your participation in what's needed to make your life better. And most importantly, you can have a difficulty swallowing because your speech and voice muscles can get weaker, and that can lead to choking and aspiration, where you inhale food particles into your lungs. So let's talk about what help is out there. Well, thankfully, Parkinson's community in Delaware is vast, and there's a lot of rehab options. LSVT Big and Loud is one of our go-to for treatment in rehab, but Speak Out is individual voice communication therapy is available, and also Loud Crowd for group sessions that are virtual now, of course. And there's also interactive metronome, where we use a metronome and train you to coordinate with it to help improve your attention and timing and motor control. And there are traditional PT, OT, speech, voice, swallow rehab, and that's more tailored to you as an individual at the clinician's discretion to help address your specific deficits, and it does not technically follow a certain protocol. There's also cognitive training that helps working on your thinking skills with attention, memory, initiation, planning. These are your executive functions, and they're so important with PD. I can't forget to mention the Safe Steps program through Christiana Care. You'll find details on our website, but this is a team of experts that specifically trained to assess your risk for falls and then try to find out what factors contribute to your risk and address them. Your doctor might refer you to occupational therapy or physical therapy or speech therapy. So let's talk about how each discipline can help you. Physical movement, it all matters. From the small muscles of your voice box to the large leg and arm muscles, your rehab team has the tools to help you in your daily life. Each therapy assesses your motor movement to determine how well you're functioning based on age and sex-related norms. Now let's find out how we work our magic.
All right, we told you this was going to be a dance. I hope we're not making you dizzy. So again, I'm Lori, I'm from Occupational Therapy. And our goal at OT, what I tell my patients is that it's my goal to help you get back what Parkinson's has taken away. So we look at things, we look at a focus on your daily tasks. So as I mentioned before, this can be everything from dressing and bathing to signing that card to your grandchild or your child or your loved one, providing assistive devices, doing home safety checkouts, and helping with health literacy and some resources. So there are things that we typically will look at in occupational therapy, starting as early as the acute care stage. So I want to look at some of our handy helpers. In traditional occupational therapy, we're going to look at improving fine motor skills and improving your motor skills to be able to do activities of daily living. However, you may need some gadgets to help you along the way. So you'll see the handy helpers in two different categories. You have your durable medical equipment, which are those larger pieces, shower chairs, raised toilet seats, grab bars, handheld showers. They're all things that are going to help with getting you more mobile in your environment. Things that also within the environment, you may be looking at modifications on how you set things up in your home. Do you keep the most commonly used things where you can reach them? So you're trying to reduce your reaching up and down to, affect your balance. Side rails on your bed, using a hospital bed if necessary, and training family members on how to use this equipment as well as the person who is in our care. The right side, you'll see our little gadgets are more the smaller adaptive equipment. So you'll see the long-handled sponge, you'll see gadgets to help you with putting your socks on, knocking your socks off, picking things up off the floor. You see there's a long-handled shoehorn there, and things that are as simple as soap on a rope, adaptive equipment in the kitchen, all of those things are helpful. One of the things that helps a lot of people are adding additional weight, particularly with people who have tremors. So you'll see in that right side, there's some equipment that has handles added to them. Those are typically weighted and they will help to reduce some of that tremor to help get some control over that. These are in addition to the big and loud things that are performed with the LSVT program. And also, these types of things will also help with coordinating among the different disciplines. So we work very closely with the other disciplines in order to make sure you get everything that you need and get those pieces back that PD has taken from you.
A lot of great speakers talked this morning about how important activity is. Dr. Grill in his amazing lecture mentioned that activity is a key factor in thriving with Parkinson's. Well, physical therapy can help you with that. It's our job to make sure every part of movement matters. Walking is huge. If you can't walk, well, you stop moving, and that just makes everything worse. And posture, without realizing it, your posture gets worse because gravity keeps pulling you down, and the muscles that hold you upright weaken over time. And we help you train to know what good posture feels like. Am I in good posture? I hope so. And balance is important because we want you to be able to move confidently, go grocery shopping, do your yard work, if you can do it safely, right? Strengthening, there's so many ways to do this. You can use repetitions, weights, bands, machines, but it's our job to figure out what's best for you. Flexibility or stretching, that just feels good to do. It can help with your stiffness and rigidity. Endurance or stamina, that's important so that you can keep going longer without getting short of breath or tired. Emphasis of everything we do is on daily functional mobility, helping you do what you want to do every day. Physical therapy can also help with safety education, and we also recommend assisted devices if it helps you move better and safer.
So have you been told that you mumble or that people can't hear you or that you should speak up or repeat yourself? That does get tiring after a while. But we know that with Parkinson's, we may experience a change in voice. It may sound monotone, mono-inflection without inflection or variation in pitch. The volume may become lower. And just like the movements with walking or with our arm movements, the movements of speech also become smaller and with decreased amplitude or range. So that can affect how you're talking and how well people can hear you. So that can result in maybe you feel less social. You don't want to interact with other people and you become a little bit isolated because of the effort is required to become interactive. Because we use the same muscles to speak with, to voice with, to swallow with, and they can become weak or incoordinated as a result of Parkinson's, we would also assess not only your speech and your voice, but we would look at your swallowing as well. Parkinson's can affect how well you chew, how well you move things around your mouth, and how well you swallow your coffee. Food might get stuck in your throat, or maybe it does go down the wrong pipe, like was spoken about previously. Maybe you're coughing more during meals. If you have had aspiration pneumonia, that's not normal, and that's something that should be addressed. Or maybe you notice that you're not as sharp, or you're not remembering as well as you were before. This might happen, and this is something that would be assessed by your speech language pathologist. So we would assess these areas, and with swallowing, we might use additional objective assessments where we use fluoroscopy in radiology to look at your swallow under X-ray, or we might use a special type of fiber optic endoscope or camera to look inside your throat, to look at your vocal cords, and also to evaluate your swallowing. If you need swallowing therapy, the exercises that we do are just like the exercises that physical therapy or occupational therapy might do to help strengthen the muscles. These are much smaller than your arms and leg muscles, but still exercise helps. Studies have shown that LSVT and some of the other documented evidence-based programs can help with voice, but also help with swallowing. So working on them both helps. We may need to change the texture of your food or consistency of your liquids while we're working on strengthening the coordination of your swallow and strengthening the muscles. So that's where some diet modifications are required, but that's okay. It's temporary, hopefully, while we work to remediate the problem. If you're having trouble with your thinking, we can work on your memory, your attention, word finding, problem solving, insight and awareness. We have strategies that we would review with you to help you become more aware and to be more safe and independent. But we all work together. This is a collaborative effort with the therapist, with your family, but mostly with you driving our interaction.
The reason all this works well is because we train you for these crucial factors. Training for calibration, helping you realize what it takes to talk normally or move normally. And daily practice. Who doesn't like a good homework assignment, right? Carrying over into your daily function. Regardless of whether you think you need it or not, it's important to use these techniques every day, as often as you can, like answering the phone with confident, loud voice, or reaching big for a pan to cook a delicious meal and surprise your family. And intentional use, like Lori mentioned earlier, it's important to use it and use it again and again. Practice makes perfect, right? Getting reevaluated every 3 to 12 months. Now that's important as well, because everybody changes, life changes, and you don't know how you're changing. And if something that worked for you 3 months ago is not working right now, it's time to get checked out. Remember, it's more than just talking or exercise. You are capable of doing so much better.
Okay, so we're going to look at other resources. Am I in? Okay, sorry, I wasn't centered. So we're going to talk a little bit about some additional resources available in the community. So there's so much out there, and in being part of the Parkinson's Alliance, it really has become evident how much there is available in our community. There are some programs that, in addition to traditional therapy, that are available for you. One thing that's not listed on the slide are the support groups. You can find support groups online, but they're also available throughout all 3 counties of Delaware. And I'm sure that information can be provided for you if you need it. But there are support groups and education groups available on top of these other activities. So we've got Rock Steady Boxing, which is a very specific boxing program focusing on honing those big movements into something with additional force to allow for better movement, and it helps with balance as well. You're stabilizing yourself while you're boxing. Dancing is great for movement because it's intentional. You're moving in specific ways. You're having to lift your feet for specific steps, and there are dance programs out there. Tai Chi, which is also slow movement, but again, intentional and large movements. Yoga for weight bearing, for flexibility, for all of those aspects, and sometimes just for some peace of mind. Swimming is really, really helpful. You've heard reference to exercising where you're able to. Some people may have other things going on like arthritis or joints that are painful. Swimming and water walking are very, very helpful for being able to get that exercise in without having to worry about the impact on your joints. Exercising virtually. Online exercise programs, as well as motion controlled gaming. Break out that Wii and get that moving. Even the newer programs, they now have a lot of dance programs and fitness programs that are embedded into those motion control gaming systems, which are really helpful for getting you moving, and you can have a good time while you're doing it, which is really helpful. And then lastly, I want to bring up for voice, there is the Neuro Notes, which is a singing group. They are a choir out of University of Delaware, and we checked it out. We weren't sure if they were still meeting because of the pandemic. However, they are meeting virtually, and they meet on Zoom the third Thursday of every month, and you don't need any singing experience to do it. So it's for people with Parkinson's, and their family members can participate as well. And again, it's something that's fun and allows you to practice these skills in something that you will enjoy, and get some exercise as well. So we're going to give you some tips for an active life. You want to make sure that you stay motivated. Motivation is probably the hardest thing. How many people have started a diet and dropped off after a week after they had that one piece of cake? It's really easy to do. When you stay motivated, get someone to exercise with you. Get a family member to exercise with you. Get a friend to go for a walk with you. That'll help you to keep motivated. Do everything as possible to stay independent. Even if you need to use some of the handy helpers to be able to do that, you're going to stay independent. Remember, it's not going to take away from people respecting you or seeing you in a positive light if you're using the skills and the tools available to keep your independence. We talked about involving your care partner or family and friend, participating in house chores. Now, you may not want to do your laundry. However, it will help you to keep moving. Folding those big blankets and bed sheets with family members is going to help with some big movement and also with a little bit of balance. Keeping your voice and your brain active. Participate in activities with friends. Do a trivia night. Do some Zoom meetings with family and friends and get online and talk to them. And keeping your brain active through reminiscing or just talking to family members about your story. Engaging in other fitness activities. It could be anything. We talked about doing your yard work. We talked about getting out and walking at the park. Barbecue with your family once we're able to. And then again, we talked about support groups and community activities. This is a good example. Previously, this was performed live. It's nice to still be able to do it, but being able to get out and commiserate with other people who are in the same situation, and that goes for people with Parkinson's and their caregivers, that support is eternally helpful to be able to help you through this journey. Oh, that's you. Is it you? Okay, anyway, I'm still here. Some other general helpful tips. You're going to make sure that you're wearing supportive shoes. Flip-flops and clogs are not necessarily helpful. Any sort of obstacles on the floor. They talked about this earlier today. We talked about removing clutter from your home, throw rugs, making areas wider for passage through your house, particularly if you're using a piece of equipment, a walker or a cane or a wheelchair, making sure that those areas are negotiable for you. Lighting is so important. Adding a motion sensor light or a tap light or keeping a night light even in the hallway to your bathroom is going to make a huge difference in your safety within the home. And then simplifying things. Using travel cups with lids, especially if you have tremors, will keep you from shaking and spilling. Using smaller containers. So instead of getting that gallon jug of milk, maybe get a half gallon or a quart, or get a smaller container to put things in when you're not using that large container, and have family help you to manage those things. And then little shortcuts like the pre-cut foods in the produce department. I've had many patients tell me, I like to chop my own vegetables. Well, that's good, but if you're going to chop off a finger, it's not a good idea. So I would recommend, if they have those little bins that have the celery, peppers, and onions already pre-cut, you just have to throw them in the pan. And you know, using those little tips make a huge difference with keeping yourself safe. So all of the therapists can help with those types of things, as well as recommendations from community people, social work, and your physicians to try to help keep you safe. So these are some general tips for you.
Whoa! Oh, hi. I'm here to talk about mobility and fall prevention. So physical therapy can help to make sure that your devices, including your wheelchairs, move safely, and that how to maintain them and train you to use them safely so that you can, you know, work well and not do what I just did. And let's talk about walking and fall prevention. Try not to carry things with two hands, for example, a laundry basket. Instead, try to use smaller loads of laundry in tote bags, leaving one hand free to catch yourself if you lose your balance. Lift your feet to avoid shuffling, or so that you don't trip over your toes, because that's a very real thing. Keep feet apart so that you don't cross over and end up tripping. It's also important to take wide U-turns and not the spinning pivot turns, unless you want to fall with jazz hands. It's also important to use two handrails on steps. Even if you don't think you need both, think about it. Sometimes you're more comfortable using the right handrail for walking up, but you also want it on the right side for coming back down. So at least it's there if you need it. If you freeze, think about stepping big over something to get started again, or look ahead past what you're walking and follow a target and just walk towards it.
So what can help you when you're talking or when you're eating or swallowing? Because of the movements, we found that if you over exaggerate your facial expressions or your speech as you're talking, it helps the range of movements, it helps you speak clearer, and also speaks louder. So these are things that will help you speak and communicate more intelligibly or understandably to your neighbors and your family and friends. Keeping your voice active is vital. If we always stay quiet, our muscles think that's all we have to move. But by purposefully engaging our voice and singing louder, maybe reciting poetry, reading out loud, talking on the phone, don't shy away from it, talk on the phone with intention, that can keep these little muscles in your voice box, your vocal cords, that can keep them active and strong. Mind. How do we keep our mind active? We've heard previously that by doing puzzles and playing Sudoku and games, crossword puzzles, these are all great things to keep your brain active and moving. If you do have any problems with either a dry mouth or too much saliva, you can chew gum. You can purposefully, intentionally swallow. Sometimes patients with Parkinson's don't swallow as frequently as others because the saliva is body temperature. You may not realize that it's in your mouth and you tend to drool. So purposely, intentionally gathering your saliva and swallowing can help reduce that drooling. Keeping your mouth moist with liquids or with different types of sprays that can combat the dry mouth from medications, that's also available. And if you're fatiguing, if you find that you just can't eat as much and that a full meal just looks too much and you're not eating an entire meal, it's affecting your nutrition, maybe you are losing weight, we do recommend that consider smaller, more frequent meals. Instead of 3 huge meals during the day, Maybe smaller, more frequent meals throughout the day is something that can keep you going without fatiguing during a meal. Access to therapy. It's important for you to know you best. So be aware of any changes in your voice, in your movement, in your thinking skills. And if you see it or feel it or notice it, don't shy away from it. Talk it over with your physician or with your movement specialist that you're noticing a change. And we talked about tune-ups or even assessments. Your doctor will refer you for an assessment to an occupational therapist, physical therapist, or speech pathologist to evaluate and treat those skills to keep you safe and keep you moving and interactive. Your doctor will have you contact the facility or company that matches your needs. It might be home care, it might be an outpatient therapy or a university clinic. These are all things that are unique and will best serve you in addressing your needs. But don't be afraid. But if you notice it, talk it with your physician. There's also resources. We've heard already of the national resources available, the Parkinson's Foundation, the Michael J. Fox Foundation. Through Speak Out, there's the Parkinson's Voice Foundation that has online group exercises for those who are working with the loud crowd. There are blogs and chat rooms. There's so many resources. This is a great opportunity for us to reach out and interact, whether it's virtually or in person. And there is the Delaware Parkinson's newsletter that Dr. Martello's office puts out. What a great way to stay connected. Over your lifespan, we've heard that it's important to stay in touch, be interactive, reach out to people with different Parkinson's support groups that are from the north part of the state to the south part of the state. Therapy tune-ups, we've heard, are good because we don't stay static. We are not the same now as we were even a month ago. So any change is important to be noted. And sometimes we need a tune-up. We need a refresher to remind us what exercises we have to do to keep our muscles moving and to keep us strong. Don't be afraid. Check out the community and web resources. And you are your best advocate.
All right, so as you've heard a lot today, movement matters. Speaking out, not just speaking out loudly, but speaking out and advocating for yourself matters. Living your life with intention matters. There are so many rehab professionals and programs in the community that are available to help you to maintain where you are and to help you get better with what you're doing. It's really, really important to keep yourself going and to keep your mobility going and keep yourself as independent as possible, keep you thinking clear, keep you speaking clear, and keep you safe with all the things that you need to do. So thank you so much for getting us to speak with you today and inviting us. It's been our pleasure to be here. Remember, you have so much potential. You want to make sure that you use your resources to be able to live your life to its fullest potential. And we're all here to help you with that. So just as we started, we're going to end with some movement. So I would like for all of you to wave at your screens, give us a big wave and a big loud bye. Bye.
Thank you, ladies. That was great. I love the energy. I love that you guys kept moving around, and I think we really needed that. So that was awesome. Good work. Yeah, so definitely, we always recommend, at least on a yearly basis, to see the therapy specialists. I think it's super important that, there's a lot of things that you wouldn't even think about that they monitor and help you with moving forward with your disease and just making you even better. And as the disease progresses, new developments happen, new issues happen, and I think they're just really, they're the experts. They're the ones that are going to be spending hours of their day with you over weeks to really kind of tune you up per se, and keep you going. So thank you, ladies. So our next talk is from Amy Benton, who is our social worker. She is a master's level licensed social worker with Christiana Care and has been working in our outpatient practice serving Parkinson's, multiple sclerosis, and epilepsy programs for the past 5.5 years, but she's been here for 19 years in our system. She holds a bachelor's degree in psychology and literature from Grove City College and a master's degree in human services, healthcare management from Liberty University. So, Amy's going to tell you all the great things and how great of a resource she has been to our patients and our clinic. And so I know you will learn a lot and really enjoy her talk today. So go ahead, Amy.
Hi, everybody. Thank you, Dr. Martello, for that introduction. Today, I'd like to talk to you about social work across the spectrum. And a lot of this is going to be a summation of what we've heard before from our other presenters, which is actually a really good introduction to what social work is, because the social worker tends to catch everything and be the wayfinder to help you get to the next resource. The first is I would like to present an overview. I know we've talked about Parkinson's disease being a lifelong progressive disease, and it's marked by changes of movement, marked by changes in your movement function, your cognition, sleep disturbances, and even can have components of psychosis. When we talk about Parkinson's and affecting across the spectrum, I'm talking about the life spectrum, because you can be diagnosed in your 40s or all the way up into your 70s or 80s. The majority of diagnoses occur in the late 50s to the late 60s, but if you're diagnosed younger than 45, it's early onset, and over 70 is considered late onset. The majority of persons with Parkinson's disease will need assistance with daily care, finances, medical appointments, and so much more. So it's important to look at the entire system of the family as well as the person with Parkinson's themselves. Most of the caregivers for persons with Parkinson's disease are most likely family members, spouses, partners, children. And the goal of the social worker within the healthcare system for a Parkinson's center is to provide you with a mutually agreed upon intervention to the person with Parkinson's, caregivers, and families, so that you can live your life to the fullest potential and even thrive with PD. So one of the things that is really important to know is that we like to partner with you to find out what your goals are and how we can get you to living that best life, living with chronic disease. One of the things I'd like to talk a little bit about is like just my passion for psychology, is Erik Erikson is talked about the lifespan and different development. And he was a theorist that developed stage theory, whereby each stage has a crisis that you have to solve. And each grouping, each stage of life, you go through different crises to resolve. At the time of diagnosis for Parkinson's, you would be in the middle adulthood stage, is what he called it. And the stage was driven by the need to solve the crisis of generativity versus stagnation. What he would do for his crises to solve them is that one would be more of a positive solution than another, so that you can live to have more ability to thrive and adjust. So generativity is to give life purpose. So, and this is mid 40s and up, you start thinking about what's a legacy that you're going to leave for the next generation? What have you done in your life? So solving for generativity means that you are really finding positive things to move towards and to have goals for. For stagnation, it's like, oh, I'm not doing anything. I'm all washed up. I'm not going to continue to have any purpose anymore. So it's super important that when you're diagnosed with a chronic condition like Parkinson's, that you still find something to strive for. You still have meaning to your life and purpose. A person with Parkinson's will soon move into Erikson's old age stage. And then as you get even older, they have old age and old age. So those are the names. But the old age stage is defined by ego identity versus despair crisis. And an ego identity is marked where you're reevaluating your life and really looking back instead of saying in generativity, what can I still do to achieve that goal? Ego identity is saying, let me reevaluate my life and see what have I done that has order, meaning, and dignity. And that is a tough thing to solve with Parkinson's, because the person with Parkinson's really doesn't feel like there's order, meaning, and dignity left in life. So there's certain tools that you have to use to try to assign meaning and to continue to strive forward, because your life does have purpose and meaning, even though it's harder to move in the body that you have. Despair is when one's life has no more meaning or dignity to offer, and you're just really just giving up hope. So someone with a diagnosis that's chronic like Parkinson's can have a deep impact for not only the person with Parkinson's, but the caregiver, because a lot of times you're faced with a diagnosis of this is a progressive disease and what am I going to do? And this isn't the life that we had planned and tried to have. So how do you redefine that and continue to move forward? One that we heard a lot about earlier, is resilience with Dr. Grill's speech in the early morning. And I want to talk a little bit about that. That is something that's super passionate for me. But Broderick and Blewett had defined the lifespan theory as the process of adapting to the constant flux of life. And I really love this definition because life is ever adapting and ever changing, especially with Parkinson's, because you have to have a way to pivot and redefine and move forward. So some of the questions that this brings up is, how do you focus on thriving when when you're living with a chronic illness that is progressive? When you get those words in that diagnosis, how do you plan on saying, okay, I'm still going to live and do everything that I can when I have it? And a lot of our speakers have presented great ways and tools and tricks to try to loop things in. The presentation just before me with the speech language OT and PT presenters, they have a great way of saying, like, let's get your body all tuned up so that you can continue to move and continue to thrive. How do the loved ones of the person with Parkinson's thrive when faced with watching the person that they love start to decline with Parkinson's disease? And those are things that you have to think about of your own nature, of what moves you, what do you have in your relationship that you can continue to grow. Through the development of resilience, coping with Parkinson's disease can lead to the ease of burden of care for the caregiver and for the patient with Parkinson's. So it is important to look at little tiny things that you can hold on to find hope to continue to move forward. Broderick and Blewett also define resilience as healthy coping and adaptation in spite of changes. So you can find ways to adapt what you do daily in spite of the changes that you're faced and the frustrations that everybody in the home is dealing with. The person with Parkinson's, the caregiver, the children, things that just usually seem hard, find a way to adapt and still find that meaning. You can find the generativity, the meaning and life purpose, your ego identity, and enjoyment at any stage in life by embracing what you can do right now. Some of the methods to become resilient is through adaptation. And adaptation is a really great thing to have because it means that you're not stagnating, you're not stuck in one thing anymore. It helps you to grow. You can add new skills or understanding. Like coming to this symposium is a great way for you to understand the depth of Parkinson's, because a lot of people just think that it's one thing. You know, there's a lot of movement, but we saw with Dr. Martello's talk how it impacts the entire body. And that is really important to understand as you walk through the diagnosis, and the caregivers also can see the changes that's happening in their loved one. Resilience and maintenance is another way for adaptation to be achieved, because you can find new ways to function at the same level in the face of a challenge. So say you like to do yoga every day for 30 minutes, but then maybe you can only do it in the chair for 5. You're still doing something that you love because you're adapting. And the regulation of loss. There's sometimes you're just going to lose the ability to do certain things. So how do you reorganize the way to handle that? Is there humor? Is there just being happy in the moment that you can still do something else? As a person with Parkinson's or a caregiver faces the psychological challenges to achieve the adaptation, the Parkinson's Center social worker can actually assist. The social worker in your center is happy to provide assessment, coaching, support, and connection with resources. Social workers can aid to adaptation because we can be available at many touch points throughout your Parkinson's journey. There's your initial diagnosis where you're trying to understand and gather your information and see what's happening. And a lot of times in our center, for your first diagnosis, there'll be a referral to our nurse, Karen Reed, and she'll give you some education on the new diagnosis. And then you'll meet with me and we'll do just a full basic assessment. And that's really just a meet and greet, get to know me, I get to know you, find out where you are in your journey and how you understand and what kind of barriers you may or may not have. So it's really just a nice touch point to know that if something comes up, I'm here to help you. As the disease progresses, sometimes there becomes some barriers and some hardships that come with that. If you're losing mobility, or if you're needing more care, or if you're just having a hard time understanding that this disease is continuing to progress despite the frustrations of doing all the other things we talked about throughout the day. I'm here to help, listen, and see if there's anything else we can do to point you to. And I'm also here for caregiver support. Caregivers need a lot of support in this area because there's many dynamics into the relationship of caring for a loved one with Parkinson's. There's the support that you need to know how to care for someone. There's also support that needs to be provided just to have somebody to listen to, because as a caregiver, sometimes it's hard to express how you're actually feeling because you don't want to provide more burden to your loved one, and vice versa. Your person with Parkinson's that you care for also doesn't want to provide more burden to the caregiver. So I'm a listening ear for those things. I can send resources into the community, and we can find ways to get you to help wherever you may need it during the assessment process. Also, sometimes when you're still working, if you need a leave of absence for work, or if you're providing care and you need a leave of absence, I can help walk you through those decisions. And sometimes we need to talk about future planning, and we can connect you with resources in the community as well. When there's a desire to achieve an adaptation, I can just add a lending hand or a listening ear, and we can just walk forward from there. Social work intervention and support into achieving adaptation. The social worker can help navigate the healthcare system. Sarah was talking a lot about what happens in an inpatient situation and what happens next. My previous experience with Christiana Care for 14 years prior to coming to the Parkinson Center and neurology outpatient was as a discharge planner for Christiana Care in the social work department. So I'm really adept at knowing how to navigate the healthcare system and helping you understand what the next steps are, and understanding some of those words that they say when it's time for discharge. Because likely if you're in the hospital for a good period of time, you'll need to go to the next level of care, which would be a nursing facility for rehab, where you can get physical therapy to get back up to the level of function you had prior to your hospitalization. We can talk about those decisions. The hospital has resources that will come, and the case management, case managers is the name of the department, they will come and work with you. But if you have other questions or concerns, I'm here to kind of listen and help you guide through some of that, because during a hospitalization, those questions and decisions happen very quickly. We can help troubleshoot barriers to care. I can assess if there's needs for intervention somewhere. Maybe we're talking and I find out that maybe you're not functioning and you need a little bit of a physical therapy tune-up, and I can make a referral to that. We can connect to community resources, and that could be just a whole host of anything, honestly. If you have a question, just ask and we'll see if we can figure out how to get that answered for you. We can help with the leave of absence and Social Security disability claims, and talk about the insurance components as you move forward. We can help discern where extra care options are needed. We can alleviate burden by partnering with the person with Parkinson's and the caregiver to achieve the goals that you have. What is your long-term goal? Do you want to age in place? Do you want to remain at home? Or are you looking for assisted living, independent living? What are you looking for? How can we help? We help find resources for the durable medical equipment that they talked about with the speech and OTPT presentation. There are sometimes motorized wheelchairs or specialty equipment, hospital beds, all kinds of different things that can happen. And I'll partner with our OTPT and speech resources to help determine what is needed. And we can work through that process to see what we can get. And I can talk to you about what insurance covers and what insurance doesn't cover. And also sometimes there's some financial grants available for medications if your medication copays become too cost prohibitive, but we find that maybe that's a really good resource for you, and we can look into those things as well. When we talk about refining adaptation, we talk about being realistic. So instead of holding on to what you used to do, try to hold on to what can you do now, and let's be realistic about what you're able to do. Another thing to do as a caregiver is recognize the hidden symptoms of Parkinson's disease. Sometimes we talk about how somebody just doesn't care anymore and you can't get somebody moving anymore because they don't want to. And sometimes that could be apathy. It could be a slow response time, slow movement, could be some depression or anxiety. And we can talk about those things to see if there's a referral to psychological services that need to happen, or if we need a medication tweak, and I can send you back to Erin. So we have ways that we can talk about those things, but just recognize that sometimes there's some hidden disease, hidden symptoms that might be the barrier to the frustration, to the care, and that's what's causing some frustration. And it also might be causing frustration for the person with Parkinson's because they can't express exactly what it is that's holding them back and is not allowing them to keep moving forward. So that's something we can talk about too. You can change your goals to something that's more narrow and attainable. And instead of saying, okay, I'm going to walk all the way around the block today, and know that maybe that's not something you can do, you can just maybe walk around the house a couple times. You know, if you used to go to like 4 or 5 different things during the day, you make one activity your goal. You know, so really just think about what those goals are and really know how to manage your energy and your resources. And you can feel your feelings. It's important to know that it's okay to feel what you feel about having Parkinson's or caring for Parkinson's. It doesn't mean that you have to think or feel this way. Like society says, I need to feel this way because this is my relationship and that's what it needs to be. No, if you're feeling that this is really hard, it is okay to say this is really hard. And if you need to call and talk about that, that's okay. But if you just hide from that and say, I shouldn't feel like this is hard, this should be easy for me, then you're going to set yourself up for failure. So that's something to think about as well. Do the best you can, embrace what you can do right now, and redefine success and find a new way to do what you want to do. So what's a creative way that you can achieve a goal that you'd like to achieve that's realistic? You know, is it that you really like to manage the finances in the home, but maybe you can't write because your handwriting's too small? Can you get somebody to write for you? You know, really just try to figure out creative ways to still achieve so that you can really work towards your positive Ericksonian crisis solutions with ego identity and generativity. Some factors that you can think about that feed into resilience are maintaining a positive attitude. You can have a sense of humor. That is such a great way to help break down the tension of having to deal with the day-to-day ins and outs of trying to make sure that the daily care and medication is taken care of. You can actively cope by seeking solutions, by managing your emotions. So if this is something that's really, really bothering you, reach out to me and see if it's something that we can talk about to help try to manage those emotions. Or if there's something that you really need help with, we can refer to our psychologist and she can work with you. You can find meaning in the value of as you face adversity. So even if there's something so small, find meaning in it, find purpose in it, because no action is too small. And you're still here, so you all have something to give. Caregivers have something to give. Persons with Parkinson's have things to give. There is still reason for being. And anchor yourself. Find a moral compass that you hold dear. What is it that will not waver, and tap into that so that you can really dig deep when things get tough. Engage in physical exercise. We've heard that over and over and over today, and it is so important. It really helps keep moving and helps keep you functioning as best as you can. And like I said earlier, if there's something that we need to tune up and you think that maybe you're declining a little bit, let's go back and make a referral to our speech language and OTPT staff and see what they can do to help. Also, it is so very important, and I hear this a lot, that we don't want to do this, is to establish a social support network. That is important for caregivers as well as persons with Parkinson's. Excuse me. It is so very important because you cannot do this alone. This is a very big burden in trying to make sure that you are holding yourselves, each of you together, the caregiver as well as the person with the diagnosis. And it is important to have somebody to talk to. It is important to look forward to something. A lot of times I hear, I don't want to burden my family. I don't want to burden my children. I don't want to burden my friends. But if somebody reaches out to offer you support, it is so very important for you to accept it, because sometimes people need a reason to serve you. And that gives them some purpose as they're trying to solve their lifespan crises as well. So you're giving an opportunity to others to help. By helping you, you're helping them. It is something to think about, and we can talk through some of those little glitches if you'd like to. We're going to move to some caregiving dynamics, because this is a very dynamic situation, because it affects so many people involved, because the whole family system is involved in different ways. There's different relationships that each person has with each person in their family. So they are expressed in a different method. Like my sister has a different relationship with my dad than I have with my dad. My brother has a different kind of relationship, and we meet each other's needs in different ways. So that being said, there might be one person better to work with each other in different ways. So it's very important to know what your relationship looks like, what you're able to do, and how we can involve one another. It's important to talk about the diagnosis in a couple and the impact it has on your relationship. It's really very important, because you want to try to find ways that your relationship is not only caretaking. What can you do to enjoy life together in the situation you are? How do you adapt that? It's okay to be frustrated that this is your circumstance right now, but it's not okay to live in it forever. It is okay to identify it and work through it, but don't get stuck there. Find something to hold on to and find some joy in what you do. Providing care for a loved one can feel so isolating, but it's important not to fall into the trap that no one understands or can help. That's what the support groups are for. And it is so very important to understand that even though you're so busy and stuck in the day-to-day, and nobody understands maybe the unique what you deal with in your home, there are other people out there that understand what it's like to have Parkinson's and what it's like to care for Parkinson's patients. Involve your family as much as is reasonable, and allow someone else to lighten your load. Does somebody want to bring you a meal? Does somebody want to cut the grass? Does somebody just want to be allowed in to make sure that you're okay? Join a support group, talk about the role reversals that are happening, and include each other in discussions on how to keep the relationship more than just the caregiver and the persons with Parkinson's. Figure out ways to still, like I said, keep that relationship alive. Take time out each day to just breathe. Do one thing you enjoy, decompress. It doesn't have to take a long time. It could be just a few minutes, but find a way to constantly refill that cup. If it just means that you have to go and scream in the bathroom because you're just so frustrated that you can't do something that you used to do before, or is it something as, just going and seeing the flowers outside, or listening to the birds, or watching TV, or whatever it is that you enjoy. Find a little thing and just refill each of your cups. Reframe each day by finding one funny or positive interaction that you've had. So that way you can kind of recap the day to see, even though there were some hardships, what was something great that happened in there. And acknowledge your loss and the change that you both feel, and allow yourselves the opportunity to grieve the loss of the dream that you guys had planned in your golden years. That is a really important thing. And then redream that dream to see what you can do. Caregiver burden is something that is really important that we have to look out for, because it is definitely something that can turn into a big problem if it's not identified soon. It is the psychological, physical, occupational, financial, and social impact that has on one who provides care. Social work can intervene to help mitigate some of the impact, as long as we talk through and see if we can make a plan ahead of time. The majority of caregivers, like we said earlier, are the spouses, partners, or family members of the persons with Parkinson's. And you have to be very careful, because when the caregiver finds that the demands of caregiving are too great, or they're greater than the available resources, role strain is experienced. And when you feel some role strain, according to Broderick and Blewett, you can lead to a caregiving burnout. This is a serious problem, and it can lead to a negative impact on the health and well-being of the caregiver. And that is something that we really have to take care of, because we do not want to have two patients that are having some problems. We want to make sure that we can take care of each other the best that we can. Caregiving impacts the relationship dynamic between the person with Parkinson's and the carer. So it is very important to make sure that you are, like I said earlier, refilling your cup. When one is feeling burdened, it's important to reach out to your Parkinson Center social worker and your support system to see what we can do to unload some of that burden. The best thing that we can do, that we say in our clinic, is that by mitigating and buffering our burnout is to plan ahead. Parkinson's is a progressive disease, and you will need extra help at some point in time. The level of extra help is going to be different, but it is important to know about what levels of help we have available and what we can do to help prepare them. By buffering burnout, we need to know that resources take time, and we have to plan for them. There's resources in the community. There's home health aides that can come and provide light housework, or helping getting dressed, or care, or staying in the home if somebody needs to be supervised, so somebody else can go out and go to the grocery store. Home health aides are not typically covered by insurance. They are private pay, and that is important to know. Sometimes there's some things that can happen that can be covered, but more often than not, it is private pay. There's independent living facilities, there's assisted living facilities. Those take some time and depend on your level of need and takes resources. They are also not covered by insurance most of the time. There's also acute rehab, which is when you would be discharged from the hospital. You would either go to a short-term rehab that has 1.5 hours of therapy a day to help build yourself up. And then there is also acute rehab, and there are two main ones in our area. There's a third. From our sponsors, we're from Encompass and PAM. And then there's another rehab downstate a little bit further, in Milford, I think. And then there's another acute care, Christiana Care has an acute rehab session as well. And that is for somebody that can handle more therapy throughout the day, 3 hours, and to get tuned up that way. There's extended care facility placement. That is when the care is greater than one can provide in the home, and you need that 24-hour supervision. And it's something that also needs to be looked into, because that is usually also not covered by insurance right away. There's long-term Medicaid, and that is something that can actually help cover some of these resources. However, that is a 30-day process for application, and that's something that our elder law attorney is going to talk about too, I suspect. And that's something that we can talk about, and I can get you a referral for. Medical equipment can take a little bit of time to get, depending on when your last appointment was and what our notes are saying. And so there's certain things that we have to look for that. And home modifications can also take some time. Things also that I didn't list on here are, we can have in-home healthcare, we can have home nurses or PT or OT come to the home if you can no longer leave the house. You can also go outpatient for OT, PT, and speech. And then sometimes you can also have hospice care come into the home and get some help in the home that way. And then we also have resources for in-home primary care. So those are some other things we can talk about as well. This is just the beginning. It's not the ending of my talk, because it's the beginning of a partnership that I would like to extend to you. If you have questions or concerns, we are here and we are happy to help, try to help you navigate where you need to go and just manage how you're feeling. This is not anything that we want you to walk through this diagnosis. We want you to know that there's support systems and you're never alone, and we're here to come alongside you for that. We'd like to help you adapt, adjust, access your care, and adhere to your medication plan as best as possible. And I just want to thank you for your time and let you know it's an honor to partner with you and your family.
Thank you, Amy. That was great. You know, I can definitely say I try and tell patients all the time, a happy caregiver means a happy patient, right? So, yeah, I mean, taking all that into account, I know there's so much more you could probably talk about for, patient support, and obviously everyone has a different situation with where they're at in their disease, and where they're at with their family situation, living situation. And so what I would say is, yeah, just, obviously reach out to us, especially Sarah and myself, Karen, Melissa. We can all get you a call organized with Amy to talk about your particular issue, because again, you can only say so much in a half an hour, right? So, but she's great, and she's a great resource for our clinic. So moving along, we have Dr. Lindsay O'Donnell, who will be our next presenter. Dr. O'Donnell graduated her medical degree from the Philadelphia College of Osteopathic Medicine, and then joined Christiana Care System as a resident, where she did her family medicine residency, and then she completed her fellowship in interdisciplinary geriatrics and research at the University of Pennsylvania. She is a Chair's Leadership Council Award recipient and is board certified not only in family medicine, but also she has certificates for qualification in geriatric medicine and hospice and palliative medicine. And so she will be talking about hospice and palliative medicine care, and as this affects a lot of our patients. So Dr. O'Donnell, thanks for joining us, and go away with it.
Great. Can you guys hear me? Of supportive and palliative care into Parkinson's disease treatment specifically. I work as the clinical lead for our outpatient supportive and palliative care programs here at Christiana Care, and that encompasses our outpatient clinics and our home visiting program. And so I see patients with lots of different medical conditions, a lot of people with things like heart failure, COPD, which is chronic obstructive pulmonary disease, and have many patients with different neurodegenerative disorders and disorders like Parkinson's disease. So this is definitely a topic that's near and dear to my heart, and I hope it's educational for everybody. So I'm going to be talking about a lot of different things. One thing I'm going to do is really define palliative care, because it's not always something that people know about. And we'll talk a little bit about why are we talking about palliative care now? What do we know about palliative care? Some new research. And then we'll go through a little case to really show what this could look like in action. I'm going to spend some time on something that's near and dear to my heart, which is advanced care planning, and also answer a little bit of information, provide a little information about hospice and what hospice entails. So I'll start with palliative care because this is the space in which I have built my practice. So palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of a serious illness. And the goal is to improve quality of life for both the patient and also for the family. It's provided by a specially trained team with palliative care physicians, nurses, and lots of other specialists who work together with the patient's other doctors and teams to provide an extra layer of support. Another key message here is that it's appropriate at any age and any stage in a serious illness, and it can be provided alongside curative treatment. So, nice words, hopefully helping you understand a little bit about what palliative care is. But what does that look like from an actionable standpoint? Like, what does that look like to me? Well, I'll give you a couple examples. So it can be helping you make care decisions. Open discussion about treatment choices. Do I do this procedure? Do I do this surgery? What's more consistent with my goals and values? And advanced care planning. We address overwhelming symptoms, pain, shortness of breath, fatigue, nausea, mood, appetite issues, sleeping issues. We really focus also on psychosocial distress, not only things like anxiety and depression, but fears and even sometimes spiritual tension. Sometimes we use a crazy big word for that called existential distress. This, why is this happening to me? This is so challenging for me and for my family. And we also spend a lot of time examining support, uncovering what systems of support and what things in general give you strength, and really trying to understand what values drive your preferences in care. Because if we understand what's important to you, it's a lot more easy to talk about any options that are put in front of us. Parkinson's disease is an illness that has a lot of symptoms. So some of the ones that I mentioned that we work with are mood, things like depression and anxiety, pain, constipation, issues like that. I really like this slide. It's from a journal called the Journal of the American Medical Association, JAMA. And it actually really zeroes in on palliative care through the lens of Parkinson's disease. So palliative care involves the team of professionals who work together to improve quality of life of seriously ill patients and their families. And it talks about some Parkinson's disease specific things we help with. And this is kind of reiterating what I'd mentioned before. Physical symptoms, pain, constipation, fatigue, psychological changes, mood, grief, worry, preparing for the future, advanced care planning, spiritual support, finding hope and meaning, and education about diagnosis, helping people understand prognosis and progression of disease. And the palliative care team can involve any number of people, but quite often if you have a really strong care team, like those who receive their care here at Christiana have, it's just so great to work with those teams. So a lot of my patients with Parkinson's disease are working hard to live well. They want to have a good quality of life. And, that is so important and it's so inspiring. And it's really what we want to support. We want to support good quality of life, being able to do what you want to do to the best of your abilities. It's talking about living well, and quality of life. It's not unheard of that I will see one of my patients with Parkinson's disease and they'll say, all right, doc, it was great seeing you today. I'm going to go on and go do my boxing class. And that's awesome. And that's exactly what myself and my team, what we want to support. But also, we know there is another side to any serious illness, Parkinson's disease included, and that is the symptoms, the pain, the medications, the hospitalizations, the things that sometimes get in the way of your quality of life or, make it harder to have a good quality of life. So we know that there's two sides to a coin. We're very hopeful and we're very supportive of living well, but also coping when things get tough. So Parkinson's disease has a natural course, and it has early stages and later and more advanced stages. Like most illnesses, symptoms, in particular burdensome symptoms, can start early on, but they really do start to compound in the later stages of Parkinson's disease. So the reason I say this is I'd love to see you all, come to my office right now. But there are some patients who are having more symptoms who might be more suited for receiving palliative care. And we'll talk a little bit about who that might be. As I alluded to before, the Parkinson's disease care team is just an amazing care model. Multidisciplinary teams that provide long-term continuity of care and supporting patients in maintaining health, education specific to their diseases, and symptom management. All so important and such a great team to be able to partner with in care. So why are we talking about palliative care now? Well, part of that is we are having more and more evidence towards the effectiveness of palliative care in lots of serious illness states. And, I'll talk a little bit about it in a minute, but we're kind of the new kid on the block. We're actually one of the newest medical specialties. And as such, I spend a lot of my time educating patients as to what we are and what we are not. And luckily, in medicine, we know when something's good, but it always helps when we have a study that also shows that, yes, indeed, this is good and this helps in these particular areas. And palliative care is getting more and more of those studies all the time. historically, evidence for how, what, when, where, why, how we integrate palliative care into the care of the Parkinson's disease patient has been limited. We know that it's good, I've been consulted, but there haven't been a lot of studies. We get a little information from clinical practice and best practices and working with our partners. It makes sense. There's a lot of parallels in patient care, care needs, and what palliative care provides. But I was really excited whenever I saw, not that long ago, a study that, again, it's in our JAMA journal, JAMA Neurology, and it was in 2020. And this was a super cool study that basically integrated outpatient palliative care, what I do, with standard care of patients with Parkinson's disease and related disorders. And it looked at patients who received that palliative care intervention and some patients who didn't. So the results of this study, I'll go through a little bit here. So as we know, Parkinson's disease and related disorders have consequences for quality of life. And despite growing interest, there were few studies of both Parkinson's disease and palliative care. So the JAMA study integrated what we call primary palliative care interventions done by the Parkinson's Disease team with guidance and support, involvement, and consultation from a palliative care specialist like myself. And patients who had that palliative care focused intervention reported better quality of life outcomes. They completed more advanced directives. They talked about caregiver anxiety and burden, and also motor and non-motor symptom burden. To describe a little bit better what that study shows, it would help me to describe what is specialty palliative care versus primary palliative care. See, the cool thing about palliative care is a lot of doctors, and hopefully many of your doctors, do this. It really is a basic skill that all physicians and all care team members should have some understanding of. And I know that you see this in your care. Management of pain and symptoms, depression and anxiety, and discussions about goals, code status. Specialty palliative care tends to get a little bit more involved when some of these symptoms might be a little refractory or a little more challenging. Maybe there's other medical conditions that kind of complicate the picture. Maybe there's a little bit more grief or existential or spiritual distress. Or maybe, there's needs to be a little bit more conversation about goals and how to decide what's wanted, what isn't wanted. Maybe people are on different pages. So that's kind of the delineation. And so some of those cases where specialty palliative care is needed, we very much get on board. And, there are some cases where we see people initially and we say, you know what, your doc's doing an awesome job. Follow along and come back and see me in 6 months, see me in a year, catch me up on how you're doing. But there's other patients who I'll say, your symptoms are really burdensome. You're having a really difficult time with quality of life. Let me work really closely with you and your doctors and see you a little bit more frequently. So I've told you a lot about palliative care, about what it is, about some of the studies surrounding palliative care. But in a way, just kind of using the words, if you haven't experienced it, it can kind of sometimes be as clear as mud. What does this look like? It just seems very abstract, hence my abstract art pictures up here. So I'd like to take a minute to really talk about a case. And hopefully by talking through this patient case, you'll be able to understand a little bit about what palliative care interventions were brought in this situation. Now, this case is not one patient, it's a combination of different factors that I have experienced and helped patients through. Obviously, I didn't want it to be identifiable, but all of this is very real and very possible, and it shows, I think, a case and how palliative care helped. So the case is that the patient is an 83-year-old man. He had a past medical history of falling. He actually had a traumatic brain injury and a subdural hematoma from the fall 12 years ago. And then he was actually diagnosed formally with Parkinson's disease 10 years ago. So he had been seeing his neurologist, getting treatment, but really over the past few months, he's had a change. He's had some mental decline. He's had a very rapid functional decline. He was actually hospitalized because he was getting more confused. He was hallucinating. He went from walking to kind of being stuck in the wheelchair. And so he went to the hospital. They made sure that there wasn't anything else causing this, no infections, no other process. And after that, he was actually transitioned to a rehabilitation facility because he was having some increased needs. So kind of like what was just spoken about, he went to skilled nursing to get stronger, to do physical therapy. His family had really been questioning what had happened. Why did he worsen so much? And the hospital stay didn't seem to make him better. If anything, he seemed to be a little worse. And they identified some things that might have contributed to this. They found out that in the hospital, his Cinemet was held, but it was restarted in the SNF, the skilled nursing facility. So he'd been in rehab as well, and he hadn't during that time yet followed up with neurology. He was busy at rehab doing his physical therapy, and he hadn't seen the neurologist during that time. So he was basically discharged home, and he was discharged home with some physical therapy, home physical therapy, and he'd been home a few weeks. And the therapist was trying really hard to work with him, but he was discharged because he wasn't able to obtain further improvement or further goals. He'd plateaued, as is often said. And as they were leaving the home nursing team said, hey, we didn't really get to where we wanted to. Have you guys talked or thought about something like hospice? So the family met with the hospice agency to get information. And they came to their primary care doctor saying, we have a lot of questions. What are next steps? What can I expect? And the primary care doctor, we actually were embedded in this primary care doctor's office, meaning that we saw some patients there a couple times a week. And so he stopped by and said, hey, Dr. O'Donnell, can you see this family and talk about the options? So they came in and they saw me, and we talked about a lot. Some easy things right off the bat. The patient actually had really thought about what his goals were and what sort of things he wanted and didn't want with his health. He had an advance directive. His wife was his power of attorney, and his living will said that he did not want resuscitation at the end of his natural life. So we really sat down and tried to understand what's been happening over time. Where was this person before? And tell me a little bit about this decline and this experience over the past few months, what it's meant for the patient, what it's meant for the caregiver. And the caregiver really said, look, I do have a goal, and my goal is to improve this patient's quality of life, my husband's quality of life, if it's possible. But if there aren't other options available, we would want to change the focus of care to comfort. We don't want him to suffer and linger in a state that he wouldn't want to be in, but we just want to make sure we're making the right step at the right time. So with that, noticing some things like he'd been off some of his Parkinson's disease medicines, we actually reached out and collaborated with the patient's neurologist, collaborated with the PCP to identify some options for his care and his medications. So the neurology team said, hey, here's some medication changes. Why don't you try them? And then maybe he can do some physical therapy. We also talked about other symptoms. Some other things that were impacting his quality of life is that he was waking up at night sometimes agitated, and he was complaining of some pain during the day. So we recommended taking Tylenol routinely through the day and at bedtime to assist with any discomfort. Sometimes that can help people be a little less agitated at night. We also realized he was getting very constipated and updated his bowel regimen. And then again, we did talk about, what did hospice tell you about their service? What are your goals? And talked about when that might be the right decision for them. So luckily in this case, with the medication changes, this person was much more able to participate in physical therapy and actually started to improve a little bit. And we met again and said, that's great. This is what we were hoping for. We're hopeful that he'll continue to stabilize. But we did have the conversation that, when might we want to consider hospice again? What would it look like if his quality of life declined despite being on the right medications and the right treatments, or if something worsens? And the family felt more empowered at that point. They knew what their options were, and they were able to weigh all of those. So I hope that helps you understand a little bit from the setting of a very real palliative care case, how we were helpful in the care of this patient. So I'm going to switch gears a little bit because all through this conversation, I've slipped in and mentioned things called advanced care planning and advanced directives. And this is something that's very important to me. I think that we should all have an advanced directive. Literally everyone on this call, myself included, should have an advanced directive. An advance directive is a legal document, and maybe our lawyer coming and speaking will speak to this, and if so, you'll get to hear a different perspective. But from my perspective as a physician, as somebody who's medical, the advance directive is this legal document, and it goes into effect only if you're incapable and unable to speak for yourself. So if you can speak for yourself, I'm going to ask you what you want if we're in a place where we need to decide. But again, sometimes people can't speak for themselves. They could have a disease that's progressive or just a severe unexpected injury at any age. And so that's why doing this type of process is really important. And sometimes you'll hear an advance directive referred to by another name. Sometimes people will call it a living will. Another portion of an advance directive is a power of attorney, a durable power of attorney. So the one thing that I do tell people, this isn't like your will. If I say, do you have a living will or an advance directive? Sometimes people will be like, oh yeah, I'm leaving that grandfather clock to my Aunt Susie. And I say, well, that's great and good for you for doing that planning, but that's not what this piece is. This is related, the one that's really important to me is related to medical care. So advanced care planning is the process by which a medical person works with a patient and a family. And together, the patient gets to explore the types of decisions that might need to be made for their medical care. They consider and think about these decisions ahead of time, and then they communicate those preferences. So why are we filling this out? It helps others know what kind of medical care you want. It allows you to express your values and desires related to care, in particular at the end of life, or in difficult decision-making points. And I tell people, think about this as a living document. It's one that you can adjust as your situation changes because of new information or a change in your health. If you fill this out at 35 years old, I don't expect, and if you have 35 years old and maybe you have some hypertension, I don't think that will be the same choices that you would make when you were 95 and have early dementia. So it changes, it's fluid, and I recommend updating it and thinking about it as things change with your health, because values and preferences and things that you would want change. So maybe every single person on this call has theirs, but a lot of people don't. As a whole in this country, I think often more adults don't have these than do have them. And there's a lot of reasons for this, and ones that are very understandable. It can be hard to plan, we spend all of our day dealing with all the things in our day. So to sit down and think about, oh my gosh, what could happen to me? It's hard, it's daunting. And it's especially hard and daunting to think about end of life and death. It can be a little bit of a downer to think in that direction, but it can also be empowering. Another barrier is that things change over time. So somebody's like, yeah, I did that. And I'm like, well, we are in a different place. So what did you say? I don't remember. Where is it? In my locked filing cabinet somewhere. Pull it out. Things change over time. Some people don't really understand what it is or why it's important, or don't understand that their illness is serious. This takes a lot of time. This takes time for doctors. This takes time for patients. And time can be a bit of a luxury when we're as busy as we are with caregiving and living and getting to this and going to that. I'll put in a big plug that we want to do this before somebody has what's called cognitive impairment. So I always tell my patients, who might have memory difficulties, we want to do this while you can still tell us what's important to you. We want your voice in this. And then also sometimes the patient may not have a decision maker. And if they don't have a decision maker, it can also make this a little bit difficult and a little bit challenging. There's a lot of documents for advanced care planning. There's one that is on the state website. There's one that you get in the hospital quite often called 5 Wishes. There's something called a DMOST and the power of attorney type paperwork. The 5 Wishes, if you've been at Christiana Hospital, you might have walked away with this. It's the blue booklet. What I like about this blue booklet is it's nice, plain language. And the first 2 sections of this talk about who you would want to make decisions for you if you could not, for healthcare related things, not for like going to the bank, and some different situations and what you might choose in relation to life support. And then it has some other areas to talk about what's important to you if you were nearer to the end of your life. And it's written in nice plain language, and it doesn't have to be notarized. It can just be witnessed by 2 people who aren't your healthcare people and aren't your family. So like 2 friends, colleagues, Sometimes we run out and grab random people in the waiting room, but it's a good document to be able to do on your own, to read through and to empower you. A lot of times I see some of my legal colleagues fill out this advanced directive form. It's on the state, and it gives a lot of options. And the other piece that I always recommend is if you get stuck on this, bring it back to your doctor, your primary care doctor, your Parkinson's care team. You know, if you're not sure what some of these things entail and you know your wishes, but you don't know what you would pick on these forms, bring it to us. You know, we're here to help you and we're here to help empower you so you can make some of these decisions. The last one I'm going to feature is called the DMOST. It's the Delaware Medical Orders for Scope of Treatment. So I filled out one of these actually this morning with a patient when I went to see them. They had an advanced directive and they didn't want resuscitation at the end of their natural life. And an advanced directive is great, but you know what? If the ambulance accidentally gets called or you go into the skilled nursing facility, you're going to want a doctor's order regarding what those wishes are. It helps them be followed, it helps protect you, and it turns your wishes into an actionable medical order. We don't do these really unless somebody has a very significant illness in the later stages, but it's a good option that I like people to know that they have. So that was my spiel on advanced care planning, and I'm going to finish up the last few minutes of my presentation talking about the end of life. I saved it for the end, you know, I tell people, please feel free to be open and ask your Parkinson's care team about what you can expect as Parkinson's disease progresses. I want people to live as long as possible, as well as possible. And we don't know necessarily in every person, it's a little individual how long it takes to get to later stages, but symptoms can become more debilitating with time. You know, later symptoms have some of that visible bradykinesia and the rigidity. People need assistance to walk, to stand, to move. And then stage 5 is the final stage where people start having severe posture issues in their back, their neck, their hips. They need a wheelchair and often become bedridden. And in addition to those motor symptoms, they can have an increase in non-motor symptoms like incontinence, insomnia, and even dementia. So what is hospice? I like people to know what hospice is. And I tell my patients when I'm meeting them, often even early on, sometimes I'll ask if they know what it is, because you know what, knowing all your options empowers you. And knowing when you might want to use the benefits of something like hospice is very important. It puts some control back to you and your family. So hospice, for those who don't know, is a program designed to improve quality of life by focusing on comfort and quality of life. It's indicated at the transition between curative-based care to a more comfort-based approach. The goal is to provide quality of life and a peaceful death, supporting the patient and the family with a care team that can include nursing, physicians, home health aides, psychosocial support, and it provides bereavement services after the patient passes away and dies. It's covered by your insurance and it pays for the equipment and medications relating to that terminal condition, the condition for which you're receiving hospice. And it can be instituted when the expected prognosis is 6 months or less. But I tell people, don't get hung up on that. There's certain markers that we know just from research that could lead us to believe that time might be getting a little shorter like that. But every individual is different. And it's, you know, it doesn't set the clock or anything. I have people who go on hospice and elect that benefit, and they live a shorter time frame than I expect, or a longer time frame than what I expect. And, you know, hospice can still be the right support for them. But I do encourage people not to wait too long to engage with hospice, because earlier enrollment is just better support and often provides better outcomes and quality of life. So when should I consider hospice in a neurodegenerative disease? And again, this is so individualized. You know, if you have any questions, you can talk to your primary care doctor, your neurologist, your palliative care doc and team. You can, you can even call hospice and talk to them. But some things that make me think, hey, maybe I should talk to this family about whether hospice might help them with their goals are if patients start having difficulty breathing, including short-windedness when they're just resting and sitting, or needing oxygen when they're just resting and sitting. If they have a rapid progression to the wheelchair or bedbound that they can't improve from, you know, when speech starts becoming very unintelligible. If they're having a lot of trouble performing activities of daily living, feeding, dressing without assistance. if they're really having difficulty with the ability to eat or drink, losing that ability. If they have some complications of their illness, like pneumonia, sepsis, kidney infections, pressure sores, or if in addition to something like a neurodegenerative disease like Parkinson's disease, they have other comorbidities like heart disease that's starting to get bad or bad COPD. So those are just some things to think about, but I always encourage people to talk to their care team about that. So with that, I will certainly be staying around for the question and answers, but I just wanted to thank the awesome Parkinson's Disease team at Christiana for inviting us today. And I also wanted to thank all the individuals who, with Parkinson's disease and their family and their friends who've allowed my team to participate in their care. Every day, these people really show us what matters most. And I'm going to flash up my, my phone number, but again, if we are here for you. So I really appreciate the time to be able to talk about this with all of you.
Thank you, Dr. O'Donnell. That was great. Yeah, I mean, I feel like, you know, and I don't need to tell you this, but palliative and hospice care is still so appreciated, understood, or not understood. And so it's just something that I think we need to just keep educating our patients about and utilizing too. And I know there's a question, and we're going to come back to you if you're still with us at the question and answer about, you know, just how to access you. And I know your last slide was great on really how to reach out for palliative care resources. So thank you again for that. And so our next talk is Bill Earhart. He is attorney. He is a certified elder law attorney. He was in the Marines, actually, started in the Marines, so thank you for your service. And then he graduated from Rutgers Law School, and he's a Delaware native. He became a Delaware lawyer in 1982, and since then has been focusing on estate and elder law exclusively. He's helped thousands of families and individuals with estate planning, family trusts, veterans benefits, Medicaid planning, and probate. So you know, brings a lot to the table, especially for our Parkinson's population. And so I'm grateful that he took time out of his busy schedule to be here and give us a nice talk about some elder law issues and basic planning issues. So thank you, Bill.
Okay, great. Thanks for that introduction, Doctor. Hopefully everybody can go ahead and see my screen and my slides as well. So we're going to talk today about what are the issues regarding aging in Delaware? And those issues are similar for anybody who may be suffering from Parkinson's and similar diseases as well. First, let me go ahead and discuss a little bit what's the difference between elder law planning, estate planning and elder law. Now, simply, estate planning has to do with death. Who gets your stuff after you're gone? That's the fun part of planning. But elder law addresses the issues of aging and the problems associated with long life and how to pay for it. Incapacity, long-term care, end-of-life decisions, the things nobody wants to talk about. So. The issues that are rampant are issues regarding autonomy, substitute decision-making, elder abuse, ethics, aging in place, planning for long-term care, and how to pay for long-term care as well. So when I sit down and I meet with clients and I try and give them a framework that they can work from, and the thing I try to tell them is break this process down into three parts. One, what's your plan for maintaining control? How are you going to manage incapacity? So we all need a plan for incapacity. We all need a plan for quick, cheap, easy transfer of property upon death. And we all need a plan for asset protection if it makes sense for us. Okay, asset protection for ourselves and asset protection for our family that comes afterwards. In this context, we're mostly talking about the cost of long-term care, regardless of what the financial advisors like to tell us about running out of money in retirement. The chief threat to the economic well-being of most middle-class and working-class families is the cost of long-term care. So you may have planned to retire on $100,000 a year, and now you're living on $75,000 a year. But suddenly, if you or your spouse is in the nursing home and you're paying an extra $150,000 a year, that'll go ahead and rip into any retirement budget that one might have as well. Okay. When we're talking about incapacity, if I'm meeting with a client, we'll give them a questionnaire. And usually when we ask who's going to make decisions for you, if you can't make decisions for yourself, they usually list their children from oldest to youngest. That's just how they do it. And occasionally they'll have someone in there, John Smith, and I'll ask them, who's John Smith? He's my brother-in-law. He's a CPA. He's really good with numbers. And I'll say, well, how do you get along with your brother-in-law? He's an SOB. I can't stand him, but it won't matter because I won't know what's going on anyway. It's not that clear. I tell clients, okay, with incapacity, we're not dealing with a toggle switch. We're dealing with a rheostat, a dimmer switch, and we may make decisions now, but it's not going to be dramatic, and suddenly others are going to be making decisions for us. We will first need assistance in making decisions before someone's going to take over. And so you need to consider whether that person who's going to give you assistance is someone that you're going to be compatible with, someone that you're going to be comfortable with as well. The other thing I tell people, because lots of times dealing with elder law, it's very often it's the children who bring parents in to see me, and their parents come in and they may feel a little bullied or a little pushed or a little sullen. When that happens, you have to push the children out of the room, sit down with the client and let them know that you're there to serve them. They're the client. You're there to listen to them. And nobody will care more about them or their family or what their plan for the future is going to be than what they care about it. And when it comes with dealing with issues now, the plan, and so the when things are really bad. So it'll be a spouse, a child, could be a neighbor, a relative, could be a nursing home, eventually could be the guardian, owners, and well, a lot of the time disputes of who's going to be but it has to be an affidavit. As we all know, there aren't notaries don't generally work in most medical offices as well. So that can take a little while to go ahead and get the affidavit from the physician. The petition is filed with the court, and then the next thing you know, even if you've done this yourself without the assistance of a lawyer, the first thing the court does is it appoints an attorney to do an investigation for the court. And so the attorney will go out, try to interview the person with the alleged disability, and then file a report with the court. If everything runs smoothly in 4 to 6 weeks, there's a guardianship order requiring the guardian to account to the court, often on an annual basis. Whenever a major item is going to be taken care of, if you're going to sell the house, if you're going to apply for Medicaid, if you're going to transfer a property around, which is generally necessary to qualify for Medicaid, then you've got to go back into court and get permission from the judge to go ahead, sell the house, and transfer the property so it can be preserved when one is attempting to qualify for long-term care Medicaid. And of course, with the annual accountings, there are also the associated court fees that go along with it as well. who makes these decisions? Of course, we all make our own decisions, particularly medical decisions. Capacity to make medical decisions is presumed under the law, and then eventually we are asked to go ahead and get assistance for that, and then someone else will go ahead and take over. Medical power of attorney. I'm going to disagree with Dr. O'Donnell just a little bit in that, you know, it's really presumptuous to think that folks can come into a lawyer's office or go online and just check off a list of do's and don'ts that are really going to be applicable to them in the future. When my clients come in, if that's something they feel very strongly about, of course I'll do that. But what we think is really the best thing when it comes to making medical decisions, we think it's best to have a clearly designated agent who's going to be responsible for making medical decisions if the patient is unable to make medical decisions for themselves. And it's important that be an individual who has a very good idea of what the patient wants under the circumstances. We encourage our clients to pick the people who are best for it under the circumstances. In our process, we just don't have people come in and sign a bunch of documents and then let them go out the door. What we like to do near the end of our estate planning process is to have a what we call a family meeting, very broad definition of family, but it's not just enough to name an agent under a medical power of attorney or a durable power of attorney for an individual, but those agents have to have an idea what their responsibility is and what the plan is and what's expected of them as well. And very often when we're talking about the responsibilities of an agent under a medical power of attorney, sometimes during the process, someone will go ahead and pull on my coattail and say, Bill, you know, I'm not the right person to make that decision for Mom. And just because I happen to be the oldest, it's just something I could never do. I could never agree with the do not resuscitate order, no matter what the circumstances are. So you really need to think and discuss with the individuals who's going to be the agent, who is best suited to be able to make those decisions. When you're dealing with money, when you're dealing with financial powers of attorneys, money can be managed anywhere. We have agents for clients in Australia and Singapore, but if you're going to be making a medical decision, it's usually best to have someone relatively close by, someone who can participate in the care, someone who can go to the doctor's visit, someone who can be the second set of ears, someone who can go ahead and look the healthcare provider in the eye in deciding what is best under the circumstances for the individual. Concurrent or joint agents is usually not a good idea. Of course, lawyers only hear or see the worst of things when we read the cases. And, sister wants to do one thing, brother wants to do another. That's never a good situation. So we say, who's going to be the agent? And let's go ahead and list them successively, one right after the other. One of the things we discuss with our clients is the difference between a best interest standard and substituted judgment. Best interest means, that's what happens if someone goes to court. In the old days, go to court, this person's been unconscious for weeks. What should we do? Everybody testifies. What's in the best interest of the comatose patient? So we approach it using our medical power of attorney in terms of substituted judgment, which means we care about what the patient thought, what the patient wants under the circumstances as well. Therefore, it's really important to go ahead and pick the right agent, Make sure there's been communication with the agent. Make sure you know what your agent wants done for you under the circumstances. The checklist of do's and don'ts on the statutory form, sometimes that's a good guideline for a discussion. We encourage our clients to go ahead and write out how they feel about being cared in the future, not just for acute medical decisions, but also chronic ones as well. So we had a client who had 3 sons who care for her very much, but they don't share her same views of religion. So she signed the medical power of attorney, designated her 3 sons in succession, and she wrote out very clearly how she felt she wanted to be cared for if she went into a long-term care facility. And so it was very important to her that she have religious services if possible, that she get to go outside once a day, weather permitting, and that if she was unable to read, she wanted people to be able to read to her as well. So you don't find those things in a checklist. The other thing we do, we make sure the clients have HIPAA authorizations as well, and it just expedites not so much obtaining medical records, but dealing with the medical billing. So financial powers of attorneys are a major issue for us as well. Back through 2010 through 2012, powers of attorney statutes changed throughout the country to address perceived financial elder abuse as well. And so the rules governing powers of attorneys are very strict, and banks and institutions construe the powers of attorneys using their own rules as well. There's a New York Times article, and I can go ahead and send the link to anybody who wishes, that talks about the difficulties people have using powers of attorneys with banks and financial institutions. One of the issues with powers of attorneys is that the agent is managing property that is in somebody else's name. And so the rules are very formal and unforgiving, because the goal is to make sure that the agent doesn't mismanage the property. If someone in Delaware and right now in all states is going to use a power of attorney, they have to sign a certification of agent. And the certification basically says, I realize I'm only the agent for the principal. The principal is the individual who is giving the power, giving the authority to the agent. And I realize it's not my money. I can't treat it like it's my money. I have to keep it separate from my money, and I can be called to account to what happened to the property as I was managing. Sometimes I tell my clients, agents, to impress upon them the importance of this, that what the certification of agent is, it's really Exhibit A in someone's criminal prosecution if they misuse their power of attorney. But notwithstanding, everyone is a little suspicious, don't want to be held responsible for honoring a power of attorney, and if it turns out the agent misuses it. So banks and financial institutions frequently reject powers of attorneys. Wills have been around for a long time. So have trusts. They travel very well. The laws governing advanced healthcare directives, although different from state to state, are very liberal. They travel very well also. But powers of attorneys, not necessarily so. Certain states, Florida, one I have a great deal of experience with, has a significantly different statute. Several years ago, a man who lived in Florida came up to Delaware to visit some folks. He had a stroke. His daughter, his only child, was in Texas. She came to Delaware and she called up our law office. And she said, Bill, my father's in the hospital. He's had a stroke. He has difficulty moving around, but he understands everything very well. Can you come in and do a power of attorney with him. So I came in, sat down with him, put her out the room, talked to him for a few minutes. It was very clear, although he had some significant physical impairments, that he was able to understand very well. Spoke briefly with the medical personnel out there. They said, yes, there's no issue with his understanding. Went back to the office, drafted the powers of attorneys, came back, put the daughter out of the room again, sat down with him, reviewed it with him. He nodded, he understood, walked up and down the hall, found a suitable witness, came back in, and he signed the power of attorney. I notarized it. I gave it to his daughter, and all was well. Except for the next day, she gave me a call. She had gone to the local branch of a very well-known national bank. And she said, Bill, I have a problem. And I said, well, what's the problem? She said, they said your power of attorney was no good. And so I said, my power of attorney is no good. What did they say was wrong with my power of attorney? And they said, well, it's not on their form. So, instinctually, the lawyer wants to go ahead and write letters and threaten them and say, how dare you say my power of attorney is no good? She needed to get things done. So I said, great, grab the form, went to the hospital, met with the client again, reviewed the document with him, had him sign it, notarize it, and she went off and took care of everything. I thought, okay, that's the end of it. She's satisfied. We've done a good job. 2 weeks later, I get a call from her. She'd moved her father from Delaware to Texas. She was in Florida, where he had 2 pieces of real estate, and of course, he had a bank account there she was trying to close out. And she called again, virtually in tears, saying, Bill, they wouldn't honor my power of attorney. And I'm thinking, well, my power of attorney? I said, no. They said, the Delaware bank's power of attorney. I said, well, wait a second, it's the same bank. She said, yes, but it's not on their Florida form. They won't honor it because it's not on the Florida form. So, I couldn't handle it for her, but that's just an example. Financial institutions seek to have their own powers of attorney signed when they require their form, even if the principal is incapacitated. I mean, the whole purpose of the power of attorney is that the principal can no longer speak for his or herself. And so you look at some of the forms that they ask you to sign, and they have this indemnification language in there, which says basically, if an agent uses his power of attorney, even if we should know better, then we can't be held responsible for it. It's not helped that the financial industry regulatory authorities suggest banks may require their own forms. Banks will reject concurrent and joint agents because they say we don't want one person coming in one day and saying one thing and another person coming in the other day and asserting another position. So they'll require one of the co-agents to resign, and then they will go ahead and assert that they, one agent will resign, and what we've had happen is that the agent who had not resigned, who was acting, passes away. And now you have a co-agent who has resigned. And so it makes it difficult to unresign a resigned agent. There's a statutory form that's promulgated for powers of attorneys, which is a check the box power of attorney, frequently filled out improperly. And the statutory form doesn't give definitions of the powers of attorneys. It simply lists them with a statutory cite. So to understand what the power of attorney grants, you actually have to go online and read the statute. For a lot of people, a good alternative to a power of attorney is using a trust to manage incapacity. An article that you can all access online using the citation was put together by Bob Sitkoff, who's the Harvard professor of estates and trusts. Trusts have been used for years to avoid probate and to protect property, to provide asset protection, but also they're a much more flexible tool for managing incapacity. That's because when the trust holds the property, it's the trustee who is actually the legal owner of the property. So you don't have the same issue of an agent managing somebody else's property. So it doesn't really matter if the beneficiary is a trust maker or the beneficiary is incapacitated. Trust can be modified if the trust maker is unavailable unlike powers of attorneys, with proper safeguards. In Delaware, you can have what's called a trust protector, who would be a neutral individual who would have the power to modify a trust under the circumstance. And of course, trustees don't lose their authority to act when the trust maker dies, unlike agents under powers of attorneys. So financial elder abuse. Common problems are that power of attorney agents look for shortcuts. They'll go into banks to assert their authority as agents in their powers of attorneys. Banks are very careless about adding agents not as co-signers but as joint owners. Very often, agents will jump the gun and make transfers out of the elder's account before the death of an elder. We had an individual, we were assisting her aunt in applying for Medicaid, so we had to transfer some assets around. And right before her aunt died, the niece, who was agent in the power of attorney, transferred $40,000 into her son's name. And when we asked her about that, we said, well, we all knew what my aunt's true intent was. We had to explain very carefully we didn't care, or the law didn't care, what the aunt's true intent was. What we cared was what the will signed as well. Another common form and that you see, not just with powers of attorneys, but you also see this sometimes with trust, is that people look for win-win situations. So a principal who's granted a power of attorney has money in the bank and it's earning just 0.2%, and an agent or the agent's child, more often than not, has some mortgage and they're paying 4%. So the agent says, I know what I'll do. I'll go ahead and I'll have grandpop's money go to the child. That'll be the loan. We'll secure it with a mortgage, and the child only pays 3%, and now grandpop's getting 3% instead of just 0.2%. That's a win for all. Of course, the problem is that all the eggs are in one basket. So there's an unreasonable risk of default, and of course, there's no liquidity. So now all the money is tied up in a mortgage as well. Common problem is, who is the client? Okay, an agent, a child, on behalf of an elder will come in, will assist them qualifying for Medicaid, applying for guardianship, whatever the situation might be, and then the agent begins to think that the lawyer is really their client, really theirs. We have to assert carefully that only the principal is the agent, and it's very often it's a shock to the child when we tell them they can or cannot do a particular thing, because it's the client who is, it's the parent who is the client and not the child who's speaking on their behalf. Long-term care. So clients who typically come in, women who are 65, 70, 80 years old, I'll sit down with them, I'll look them in the eye and I'll say, gee, you know you have about a 50-50 chance living to age 90. There are not many of us at age 90 that don't need some assistance. What's your plan to pay for long-term care? According to the statistics, it's more likely than not that all of us, sometime along the way, will need some form of long-term care. Everybody wants to stay at home. Is it safe? How do you pay for it? Medicaid can pay for it. In Delaware, Medicaid has a very robust home and community waiver. It's self-directed. Children can be compensated for providing care to their parents as well. Very briefly, because I'm running out of time, is that to qualify for Medicaid, you can only have $2,000 in resources. If you're living at home, the house is exempt, and there are various techniques to be able to preserve assets. With married couples, we can usually save 100 cents on the dollar for them. For single individuals, we can usually save at least half. With long-term care planning, if people come in advance, So we can do Medicaid asset protection trust for them. There are certain shared property arrangements that we can implement. There are certain exemptions for transfers. If a child has provided care to a parent under certain circumstances, transfers can be made from parents applying for Medicaid to children with disabilities, and it's not a disqualifying transfer as well. And even at the last minute, if people have not done any planning, well, then we can usually save at least some money for them as well. So I have some important numbers here that I'll keep up on the screen for you. And I appreciate your patience with me as I try to get 40 hours of information into 30 minutes of time.
Well, that was great, Bill. Thank you very much. I know this is kind of an area that I think we're kind of unarmed to answer with most of our patients. And unfortunately, it's something also that, you know, as you pointed out, too many patients wait till sometimes the 11th hour to really figure out, and it's best to get way ahead of that. So I appreciate you talking about it, and you know, for the patients and caregivers, I would really take this seriously. I think you'll save yourself so much, and you know, I know really even within the, not only in the legal field but also in the medical field, we are pushing the importance of making these decisions and appointing these power of attorneys, even, to be honest, after the age of 18, right? As soon as you're adult, you should really try and figure these things out. So the sooner you can get it done, the better. So now we are approaching the questions and answer panel discussion. And it looks like we have most of our speakers still with us, which is great. And so I'm going to have Karen Reed, our nurse, our Parkinson's nurse, read out all of the questions and direct it to different one of our speakers. So if I could ask all the speakers to, you know, show your video and keep yourself on mute, and then Karen will direct the questions to each of us. Thank you.
First question is for Dr. Martello. Is it recommended that Parkinson's patients see a movement disorder specialist in addition to their existing neurologist?
Right, so as I mentioned before, I think, you know, the studies and the effect on a patient's quality of life and the education behind the newer therapies for Parkinson's bear out that you really should have a movement disorder specialist if you can get fit in with one, at least to see them once a year at least. You know, some areas of the country, including Delaware, I would say it's hard to necessarily get in to see us or get in to see a patient, especially if you can't travel that far. Luckily, we've been offering virtual clinics, video clinics, so that you don't need to leave your home if you don't have the means to. So making access a little bit easier for us, but I would say it is important to have a movement disorder specialist.
Second question will go to Dr. Martello, kind of a part two to the first one. How do you get clinicians to work together, especially if they are located in different healthcare organizations?
Yeah, so that's another great question. I think, you know, that question just speaks to the unfortunate reality that it's just a shame that in the medical community, not unique to Delaware or to our institution, but that the communication is really not great between institutions, between areas of the country, between doctors, even close in proximity to one another. We are getting better at that in Delaware in a number of ways. We have this system called DIN, D-H-I-N, that allows a lot of the different hospital systems to share their notes, lab results, things like that. I think that that's one of the tasks of the Delaware Parkinson's Task Force, is to help figure out the communication barrier between institutions, between private physicians and specialists and things like that. So that is something we are hopefully trying to improve on. What I would say is probably one of the best things that you could do, because again, you know, as much as we like to make this easy, and as much as we like to take the the onus on making this, our responsibility. I think at the end of the day, until we're able to get this better, it's just a nice idea to be organized yourself, to have as many of your own notes. Right nowadays, especially with the newer laws, you have access to all of your outpatient notes, to all the hospital records. That's all yours, right? So keeping that all together and keeping it with you to each visit, so that if your doctor needs it, you just have it right there with you and can show it to them. I think that's the best way to do it.
Next question is for Dr. Grill. Has there been any success with acupuncture and the treatment of Parkinson's disease?
Hi, so acupuncture and Parkinson's disease. So, I don't know of any particular studies. Acupuncture, I do think can help various pain syndromes that people have, and I think there's really a good scientific basis for that acupuncture probably releases opiates or derivatives and can help with pain syndromes. And pain syndromes can exist in Parkinson's. I haven't seen any indication that acupuncture is helpful for the motor symptoms in Parkinson's. So it's not a standard part of any sort of therapy, but some individuals may see some benefit from it.
Next question is for nurse practitioner Sarah Hinkle. When admitted to a hospital for treatment, is it not a standard operating procedure for the hospital physicians to consult with the primary treating doctor or doctors to determine the appropriate course of action and appropriate dosage for medication?
I think that's a really good question. In the ideal world, it would be wonderful if the primary care physician was involved right at the beginning of the stay. The truth is that the primary care physicians don't often treat at the hospital anymore. There's just not enough time. They haven't had the time built into their practice anymore. It was prolonging the length of stay for patients in the hospital. So they're actually not contacted right at admission. It doesn't mean that they can't be kept informed, and there is some communication, but right at that beginning of the admission, the best thing you can do is have your list of medications, who prescribes them, the doses, to keep yourself safe.
Next question is for Dr. Ellison. Is there a method or test to measure when anxiety medication should be implemented, such as similar to managing depression?
That's a great question. And the most important determinant of whether an anxiety medicine will be valuable is the history of the symptoms and the circumstances surrounding them. As I mentioned before, and I'll be brief about it now, the evaluation of anxiety involves taking a history of the symptoms, figuring out whether there are other medicines that are already been given that might cause anxiety, figuring out whether there are medical conditions that might produce anxiety, or personal situations like stresses on the relationship from the disease that might impact and cause anxiety. And then some clinicians will use a clinical tool like the Parkinson's Anxiety Scale to measure symptoms. A very important point is that if you do opt to add medicine to the treatments, which might start with psychotherapy, that you also measure the effectiveness of the medicine and be attentive to side effects.
Next question is for Dr. O'Donnell. How can I pursue palliative care services for my mother?
So that's a great question. Palliative care, I didn't really talk about this in my talk, but while we've been established in hospitals for a long time, outpatient groups providing palliative care are even newer. So some groups that have even robust in the hospital teams don't have the outside the hospital ability. Certainly, you can talk to your Parkinson's disease care team and check the Christiana Care website and the slides at the end of this for our phone number for our program. But another great resource is online. It's called www.getpalliativecare.org. It has great information about palliative care in different disease states and all the different providers of palliative care in your area. And kind of where they serve their patients, whether it's in home, in the clinic, in the hospital. So it's a great resource to find, those types of services near you.
Next question is for Cynthia. What type of exercise is good for improving mobility issues?
I apologize. The exercise prescription varies for the person, so that's why they recommend that you get evaluated by a physical therapist to determine what the best movement might be for you, because what works for you might not work for somebody else. So as soon as possible, I would strongly encourage you to get evaluated. But if you feel like you're already doing something that you enjoy, that you feel safe doing, then that's great. Keep going.
Next question is for Dr. Martello. Given the long-term effects of the commonly used medications, such as levodopa, on the brain, is there value in maintaining a minimal dosage for as long as possible before increasing the dosage or frequency?
So I would challenge that notion about long-term effects of levodopa. I mean, the risks of complications to levodopa long-term are really twofold for the most part. One is something you can't control, which is the length of time you've had the disease for, and so obviously that's not in your control. And then the second is being on higher doses of levodopa. So usually we're talking about Sorry, could you hear any? Did I get any of that?
About half.
Half of okay. Sorry about that. I was just saying that, one of the things that we do try to avoid is going to super high doses of levodopa. It is true that we don't just increase it up further and further just for the sake of increasing. A lot of times we'll increase it up and the patient will say, oh, I didn't really feel any difference, and then we'll go right back down, because there is that principle still that is there, that we want to use whatever dose is effective, but that we are seeing benefit for. So I would say that really the way we approach Parkinson's is getting your symptoms under good control, for whatever it takes, and even if that means early on cranking it up, because we do know that the long-term benefits of having your motor symptoms well controlled outweighs any kind of risks that we're going to get concerned about with levodopa. And to be honest, those risks we're able to manage that later on. And so, we're the ones treating you. We're the ones, going to stick with you the whole time. And so we're not trying to make problems for ourselves as doctors trying to treat you later on. And so it's just something that, again, back in the day, we were very restrictive with levodopa, and that's just not the way to go about it. So.
Next question is for Dr. Grill. As you mentioned, Parkinson's is a progressive process. With the option of deep brain stimulation, where you program the instrument placed in the brain, how long will this method help with tremor? And will there come a time when the programming will no longer be effective?
Yeah, so that's a good question. I think it's sort of a fallacy to say that DBS only works for a certain amount of time. Certainly the disease progresses, and a lot of symptoms that we can handle with deep brain stimulation. There are a lot of symptoms that aren't handled by deep brain stimulation. All the non-motor symptoms really aren't helped by deep brain stimulation. But in terms of the motor symptoms, and especially the tremor, it's lifelong benefit. So I have patients 20 years into having had deep brain stimulation, and yeah, we tweak it. We keep up with your symptoms, and we are, frequently making changes and adapting to whatever the new symptoms are. But it stays effective the entire duration of your life. It doesn't stop working. But again, we have to face that there are some symptoms that are not helped. So, for example, balance, is not really helped by deep brain stimulation. It's the primary symptoms, the tremor, the stiffness, the slowness, that are really helped. And we just have to face that other symptoms progress that we can't manage fully with deep brain stimulation, but we have other methods to address them. So it is effective for your whole life while you have it.
The next question is for Dr. Ellison. How does someone cope with Parkinson's disease related fatigue and sleepiness?
Well, I think Dr. Martello may have additional thoughts about this, but I would first take a look at the medications which the person is taking for Parkinson's or other diseases. I would also think about whether depression or anxiety are present. I'd want to make sure that a sleep disorder wasn't interfering with restful sleep to interfere with daytime alertness. And then, if all of those things were looked at, there are medicines that specifically improve energy or increase wakefulness. Maybe Dr. Martello would like to add something to this.
Yeah, so that's a great answer. I would agree with everything you said. The medicine fatigue is difficult to treat. Exercise is yet another thing that we usually recommend, and to be honest, is a big thing. I mean, a lot of patients say they get exercise. I mean, it tends not to necessarily be up to the same par that we expect from patients, but trying to be active throughout the day as well, building up your endurance. And the other thing is, a lot of people, when they talk about fatigue and sleepiness, it's kind of like, well, yeah, I just don't understand. I'm sitting on a couch and it's like mid-afternoon and, I'm watching like a soap opera and I just kind of nod off, and it's like, that's going to happen, right? That's going to happen with aging, and it's going to it happens to me, right? If I'm sitting on the couch, I'm going to nod off in the afternoon. So it just sometimes it's just being active. It is different if you're like, well, in the middle of an activity, I'm falling asleep, or in the middle of something, I'm getting really fatigued. That's definitely different. And while there are medications that sometimes can help with this, it is something very difficult to treat. A lot of the medications that we have are not approved in the setting of Parkinson's disease, fatigue, and so getting them covered, approved by insurances, it can be an uphill battle. But yeah, I mean, everything else I think Dr. Ellison said are things that we look at and try to address.
Next question is for nurse practitioner Sarah Hinkle. Are there things that can be done besides exercise to delay the onset of dementia?
So exercise is a big component to delaying the onset of dementia. The only other one that's been proven is actually that Mediterranean diet to help ward off dementia. I think Dr. Martello might have mentioned it in his talk. Diet low in saturated fats and cholesterols, high in vegetables and fruit. That combined with the physical exercise are the two main things.
Next question is for Dr. Martello. What is the standard treatment for erectile dysfunction with Parkinson's disease?
So with erectile dysfunction, we tend to use the same medications that other people use for erectile dysfunction. So there's nothing necessarily specific in the setting of Parkinson's that we would use. The only thing that we definitely mindful about is the blood pressure issue. So a lot of those meds will drop your blood pressure. And so it doesn't tend to be as much of an issue, with these types of meds and blood pressure with Parkinson's, but it is just something that, if you take and you start getting really lightheaded, that may be playing a role in why that may not be a good medication for you. But we use similar things that are used for other men with this issue.
And I'm going to direct the next question to Dr. Grill. When someone has a traumatic event, such as a broken hip, so a serious health situation, why is it difficult for them to get back to normal when Parkinson's is also a part of their medical picture?
Right. So traumatic injuries, they basically, when you break a hip, you're breaking the bone. And people are just never quite as good. You accumulate these injuries. You know, every time you fall, you're at risk for injuries. And when you break a bone, it never quite necessarily, it takes a longer time to heal than when you're younger. And you're never quite the same. You're never quite walking the same, because there's often some discomfort when you walk, and it affects how well you walk. So you lose ground with each injury. And that's just the nature of the beast, that you don't recover fully. You know, it's a lot easier when you're young, but when you're older, recovering from these traumatic events is much harder. So you know, our goal is to really, you know, you've heard a lot of discussion today about fall prevention and what we can do about it. And we really this needs to be a big priority for everyone with Parkinson's, to avoid these traumatic injuries, because the issue is that they accumulate. You accumulate more disability with every time you break a bone. So be really careful and be compliant with, you know, working with your therapists and using your assistive devices if you need.
All right, I'm going to go back into the chat, actually. I think I'd like to send this question to nurse practitioner Sarah Hinkle. Is there a dietary doctor or technician to help patients with digestive issues and to assist in the ease of constipation?
So for dietary options, I would actually first recommend seeing a GI specialist to make sure that there's nothing wrong that needs to be fixed from their point of view. A lot of times there could be underlying gastric reflux and other things that can be managed. We often do treat constipation with Parkinson's. At every visit I bring it up. I think it's very common, and staying on top of it with lots of water, stool softeners, lots of physical activity is really important. If you're still having trouble with the constipation and they don't find anything with the GI doctor, there are nutritionists that can help people. So if we need to go that route, that there are some people that work with a nutritionist to find what's best for them.
I'm going to address the next question to Dr. Martello. How much is considered to be a high dose of levodopa?
Yeah, so usually, you know, we're definitely trying to avoid anything more than 10 tablets of the 25-100s per day. I will tell you, this is kind of a rough estimate. You know, I have plenty of people who take way more than that, and it's usually that's usually kind of the limit that we are able to avoid, either with adjusting the medications, adding other what we call helper medicines to levodopa. But again, some people, everyone's brains are different. Everyone needs a different amount of dopamine. Also, everyone's GI system works differently, right? So even though sometimes we're giving them 10, 15 tabs a day of the levodopa, their brain may not be seeing but only 5 of them, right, or 500 milligrams. And so sometimes we have to flood the system in order for anything to get through, which again goes back to trying to find better ways to deliver levodopa and dopamine to the brain.
I'm going to direct the next question to Dr. Grill. What is the most effective method of decreasing dyskinesias? We have tried tweaking the dosage of carbidopa-levodopa and tried other medicine. Should we try Rytary?
Yeah, so this, this is the challenge of getting the medicines right. That as with advancing disease, the therapeutic window narrows so that you need a certain amount to get your symptoms treated, and you go a little bit higher, and you can get the dyskinesias. And this is, this becomes a problem as disease advances, usually over 5 to 10 years. And so, the first way to manage it is using smaller but more frequent doses of levodopa. So, it's hard to tolerate taking medicine so frequently, but I'll sometimes use even half tablets of carbidopa-levodopa being taken every 2 hours, every 3 hours. And so the more you can sort of maintain a constant blood level and avoid the ups and downs, the more you can avoid either being off or being on with the severe dyskinesias. So Ritari is this long-acting version of carbidopa-levodopa, and it gives us an opportunity to maintain blood levels more constant and then avoid the ups and downs, the peaks and the valleys. So that is an option that we use. There also are a class of medicines that directly help dyskinesias. So amantadine, which has been around for 80 years, I guess, is a medicine that has some benefit in terms of treating the primary symptoms of Parkinson's. It's helpful for tremor and other symptoms. And until levodopa was around, it was really one of the main medicines we used. But more recently, over the last few decades, we've seen that amantadine directly helps the dyskinesia. So it can be added on to carbidopa-levodopa. And usually I'm usually dosing it three times a day, which shouldn't be a problem because you're already taking your levodopa more than 3 times a day probably. And this can be an effective treatment for the dyskinesias. And then there's also long-acting versions of amantadine available too, that you might take just once a day and provide relatively constant control throughout the day. And then of course, this is the main reason that we refer people for deep brain stimulation, because what deep brain stimulation does is it can treat a lot of the primary symptoms, and at least with the subthalamic stimulation, which is one area of the brain that the main one that we use, it allows a reduction in your levodopa dose, reduces the dyskinesias, allows a more stable level of control during the day. So these are all the ways that we manage the dyskinesias. It's frustrating, and it takes effort on the part of your movement disorder specialist to really figure out exactly what the right dosing is for you and whether to add some of these helper medicines, the amantadine medicine, and then when, frankly, to turn to deep brain stimulation. So it becomes a complicating part of the problem as Parkinson's advances. But we do have treatments and ways to manage it.
I have a couple of questions for William Earhart. We've had a request for the link for the May 16 New York Times article on the power of attorney. Are you licensed in Maryland? And there's one more. How can we get the 5 wishes and DMOST documents?
Okay, well, I don't think I'm the right person to answer all of those questions. I'll go ahead and I'll provide the link. I'll cut and paste it on the chat. It sounds like Dr. O'Donnell may be able to guide someone towards the 5 wishes. I agree with her that most people have nothing in place, and the 5 wishes is a good place to start. I think what people are confused about when they come into my office all the time, they come in with a living will, they come in with the 5 wishes. Then they're shocked to find that it's not a do not resuscitate order. And they often look at me very frustrated and they say, well, how do I get a do not resuscitate order? And then that leads into a conversation about, you really need to meet with your physician. And, it's my understanding they don't do not resuscitate orders or execute a DMOST unless you're really, really sick and you've had a real conversation with them. So, and I think that's about the best I can answer those questions. But I'll go ahead and I'll grab the link, see if I can post it on the chat real quick.
So to answer some of those questions about where to obtain those documents, you can request 5 Wishes forms online. There's a website, it's 5wishes.org. If you have Christiana Care providers, most of them will have 5 Wishes in their office or otherwise be able to obtain one for you. We kind of have them stocked a little bit of everywhere. The DMOST, you can actually go to delawaremost.org. Now, that form does need to be filled out by a physician, a physician's assistant, or a nurse practitioner. So it's not one that I recommend that you fill out, but if you're interested in it, you can either go to your doctor and say, I'm interested in a DMOST, or you can actually print it off and take it to them, having already perused it and looked at it. And as I said, you know, those are very medically focused forms. The DMOST is an actual actionable order for, you know, different forms, not just DNR, but also other types of wishes, questions about feeding tubes and hydration. And there are similar documents to the DMOST in other states, and we all honor each other's. Maryland has one, Pennsylvania has one. And then the last piece I'd like to say is I completely do agree with Mr. Earhart about the importance of a power of attorney. These documents are only as good as you know, as having the conversation. And so I really do feel like having a trusted power of attorney, a trusted decision maker that you've named, and having them be the best person to make decisions for you, and having told them what you put in these documents is really important. You know, I've heard cases of somebody filling out a DMOST, but not looping in their power of attorney, their loved one, their husband. And, you know, it's very challenging from the medical side when somebody comes in with this document, but the family's like, we never talked about this. You know, I don't know, is this right? Is this not right? So great communication is very essential. And if anyone else has anything to add to that, but you can get them online, you can get them at your doctor's office.
I'm going to direct the next question to Dr. Grill. What are the best methods for controlling dystonia, pre and post-surgical and medical procedures? My fear is having a spasm and tearing open an incision.
Can you repeat that? Dystonia was the question?
Yes.
Of controlling dystonia. So repeat it once more, I'm sorry.
Just gonna put it back to me. Come on. He needs to give it back to me.
It's okay, just go.
What is the best methods of controlling dystonia, pre and post-surgical and medical procedures? Fear of tearing open incision.
Right. So, so dystonia, you know, is an abnormal contraction of muscles, basically the brain sending down wrong signals, causing twisting movements. It can involve any muscle, any skeletal muscle. I guess in Parkinson's, it's most common in the foot, where one foot might be turning in involuntarily. So the best thing is to try to have this managed as well as you can, you know, throughout, you know, not just before a surgical procedure or before a procedure. And so dystonia is complicated. It can happen as a sort of early morning thing, and then usually gets better after you take your medicines. It can happen as a wearing off from levodopa as medicines wear off. It can be there just all the time as one of the primary symptoms. So there's different ways to manage it. So if you have dystonia as a wearing off phenomenon, as your levodopa is wearing off, then the thing to do is to try to ensure that you don't have wearing off and that you're taking medicines, you know, close enough in time so that you avoid the dystonia. If the dystonia is a more constant problem and not really related to your medicines, then the way that we manage that is with botulinum toxin injections, injected directly into the muscles that are dystonic. And so if you're concerned, you know, that you're having, I guess, any type of surgery, you could have abdominal surgery, or I'm not sure what surgery the questioner was asking about, but if you're concerned, you know, that you're having surgery on a body part that is close to where the dystonia is, then again, the thing is to just try to have it as well controlled before going into the surgery. So I think that's about all I can say on that. Yeah.
Okay, our last question will be directed to Dr. Martello. Where is DBS performed? When do you suggest that this procedure be offered? And also, will the area of insertion need to have the hair shaved?
So DBS is done. Usually there's a couple centers in Philly, Baltimore, DC, as far as the closest areas that we usually send patients to. Again, it's usually done in the setting of one of usually two situations. Either someone has uncontrolled tremors that are not treated really well with medications or can't tolerate the medicines for tremors, or they tend to have motor fluctuations, and that's kind of the up and down of symptoms throughout the day that we've kind of been talking about, where you have a lot of off time when the medicine's not working well, or you may have a lot of dyskinesias. And so those are two circumstances we typically use, we'll recommend people to go get DBS done. And more of the surgeons are doing this pretty well, that they don't have to shave the entire head. Usually it's just the small area that they drilled a small hole to insert the electrode. So yeah, I mean, that's kind of what we would think about. And so thank you for everyone for coming. Thanks for all of our speakers for taking the time out of their busy work week to come. Thank you, Dr. Grove, for coming, and all of our other speakers. I thought this went really well. We will be sending out the recording of this to everyone who registered, along with hopefully a PDF version of slides if we can get them. And really, some other resources that is available, including our newsletter. So we'll send you a lot of goodies to look through and to think about. And we hope that you take part of our clinic and our resources that we have. As you can see throughout this whole day, we have a lot of resources to offer. And then finally, I just want to say, hopefully we'll have this virtual town hall scheduled soon for our Delaware task force, and get you all involved for your input. So otherwise, have a great weekend, and we'll see you later, hopefully next year in person.